Our first speaker this morning is Tara Jackson, DrPh, MHA, the director of the Project ECHO, which is a revolutionary guided practice model that reduces health disparities in underserved and remote areas of the state, nation, and world. Through innovative telementoring, the ECHO model uses a hub-and-spoke knowledge-sharing approach where expert teams lead virtual clinics, amplifying the capacity for providers to deliver best-in-practice care to the underserved in their own communities. Please welcome Tara Jackson.
Thank you. Can you guys hear me? All right, I'll move this a little closer. Thank you, Dr. Bushman. Here we go. Just to let you know, I haven't stood up to give a presentation for 2 years now, so bear with me. I might need to take a break halfway through. So here we go. I am Tara Jackson. I'm a doctor of public health. I'm very passionate about public health. So if I talk too quickly during this, and I'm very passionate about Project ECHO. So if I talk too quickly, please let me know and just say, hey, slow down. I am the director of Project ECHO at Oklahoma State University Center for Health Sciences. First off, I want to start by just saying thank you to the OOA for letting me come today to give you an update about what's going on with Project ECHO. And I also want to thank all the physicians in this room and the frontline healthcare workers for all the tireless work that they did for the last 2 years during the pandemic, 2.5 years. So with that, we'll move forward. Again, I have no disclosures to share during this time. And today I will be giving basically an overview of Project ECHO, how it started, the history of it, why it's important, what goes on in an ECHO session, and then I'm going to talk about, most importantly, what we're doing at OSU Center for Health Sciences Project ECHO and the future of Project ECHO at OSU Center for Health Sciences. So this is kind of part of the issue. Every day, thousands of variations of this story are playing out all over the world. 1.6 million people die from treatable diseases like tuberculosis every year, and the story goes on in all of these photos. This is also occurring in Oklahoma. People are dying of potentially treatable disease, and so we needed a solution to help with this. So imagine if there was an educational platform that could touch the lives of 1 billion people around Oklahoma and the world by 2025. We at Project ECHO can imagine that. So how did ECHO start? What is it? What does ECHO stand for? All of that. So Project ECHO stands for Extension for Community Healthcare Outcomes, and it was founded by Dr. Sanjeev Arora at the University of New Mexico in 2003. And Dr. Arora is a liver specialist and was specializing in hepatitis C. And it's kind of a long story that I'm going to go into and share with you, but the whole goal and the reason what Dr. Arora did was he developed a model to, as Dr. Bushman mentioned, he developed a model to improve both the capacity and access to specialty care in rural and underserved communities. And the whole idea is to link information and experts, so specialty care experts and specialist teams at academic centers to primary care providers on the front lines, helping those patients in those communities. We do it through Zoom. I'm going to tell you a little bit of story about how and why Dr. Arora started this. So in 2003, Dr. Arora was practicing and treating hepatitis C at the University of New Mexico in Albuquerque. At that time, there was roughly an estimated 36,000 people that had hepatitis C, but only about 1,600 of them were getting treated. At that time, there were only 2 clinics in the entire state of New Mexico that was treating hepatitis C, one with Dr. Arora in Albuquerque and one in Santa Fe. Otherwise, everybody from around the state in rural New Mexico had to go travel those great distances to see a specialist for treatment. And at that time, it was roughly an 8-month waiting list to see Dr. Arora. And he was moving along with this and working through all of that. But one day, a patient came into his office, and it was a 40-year-old woman. And she had been diagnosed with hepatitis C a couple years previously. And by the time, so she came into Dr. Arora's office a few years later, and he did all the diagnostic tests on her, ran some things, and they found out at the end she had a very large, untreatable mass. and had terminal stage 4 liver cancer. And he said, why are you coming to see me at this point? And she said, because I'm sick. And he said, respectfully, very respectfully, why didn't you come previously to get treatment? And she said, I have 2 young children. It was too difficult to take off time from work to get childcare, to travel long distances to get the treatment. And as you know, around 2003, the treatment for hepatitis C it was pretty complicated and took repeated visits. And so by the time she got to Dr. Aurora, she had the stage 4 liver cancer. And shortly after, she did pass away. And at this point, he just said, I don't understand this. I don't understand this. This is a treatable condition. Why, at this point in our history, with the greatest one of the greatest healthcare systems in the world, why are people dying from treatable conditions? And so he decided, I'm going to do something about it. And so he took it upon himself, and he's like, he's trying to figure out, like, how did I learn to do what I do? How did I learn to become the specialist in this field? And so he said, how do I learn to become a doctor? So he went back to his education, and he said, well, they told me to be a doctor, I'm going to learn. I learned from lectures. I learned from gathering information about best practices. And then from that on, so didactics, they learn from didactics. And then they learn from presenting patients during their clinical rounds or grand rounds. And so what they do is, he said, I presented patients. I give the whole patient history. I give the medications they're on and everything about the patient. And then they asked me a lot of questions. A lot of clarifying questions about that case, about that patient. And then in the end, we talk about how we're going to treat that patient during that time. And he said, lo and behold, a few years later, I was a doctor and I was a specialist in that field. So he's like, I'm going to do that. I'm going to go around New Mexico and see who wants to become a specialist in treating hepatitis C. So he actually literally drove around in his car, and he found 24 physicians that decided that they were on board to be educated on how to treat hepatitis C. And so what he did is, then he thought, well, I got all these people that want to do this, how am I going to get them all together repeatedly to train them over a period of time? And at the time, again, it's 2003, so he said, I was doing Skype with my children, and so I think I can use video conferencing to connect all of these people together to do this training. And that is what he did. And that is what became overall the Project ECHO model. So eventually he got all those people together over Zoom. He would meet with them weekly for about 2 hours. He would do a 15-minute didactic presentation. They keep it really short because we don't want it to be a webinar. We don't want it to be a sit and soak kind of one-directional communication. We want it to be a very dynamic environment. So keep it short with the lecture, and then everything else is about that case presentation, learning by doing and walking through that. And he did that for several months, and then this is what happened. So then they studied it. They're like, are the outcomes, what is this working? And so obviously it worked. It was in the New England Journal of Medicine, and they found out the evidence showed that those patients getting the care in those centers with those providers in the rural communities had as good, if not better outcomes than were happening at the academic centers, because those patients were actually going to get the care in a timely manner from those trusted providers in their communities. So they kept studying it, and then they realized during that time, they also, in this article, they talked about that providers felt great self-efficacy in being able to treat those patients. So in addition to the strong outcomes that occurred, there was a provider benefit that occurred, and strong self-efficacy and this knowledge and skill that they had gained in order to treat their patients and bring this to their communities. In addition, there were numerous, this is kind of what it looked like. This was the first kind of ECHO session that ever occurred. And so those are part of the 24 physicians that decided to go along board with Dr. Aurora, and Dr. Aurora's in the center there. And Dr. Aurora's pulled together, so we use as Dr. Bush mentioned, we use a hub and spoke model, and the hub is that those subject matter experts, and we use an interdisciplinary team of subject matter experts in all of our ECHO lines. And we'll get to the ECHO lines that OSU has soon. But so for this first ECHO, what they did is we had Dr. Aurora, who is a liver specialist and hepatitis C specialist physician. He brought together a psychologist that understood all of the social, emotional, behavioral issues that impact hepatitis C treatment and care. and accessing care. He brought together a clinical pharmacist, nurse case manager, and social worker, basically a full wraparound service and basically a curbside consult with all of those disciplines. And it proved very effective. In addition to just having strong self-efficacy and strong outcomes, they also found later, they did a survey of those physicians, and they found out that it really kind of an unintended happy consequence of it was it really diminished provider isolation in the long run, and which helps, you know, a rural provider practicing out in a rural community. It was a lovely support system that was built there, and it also enhanced the professional satisfaction. There was they strongly agreed that there was collaboration among agencies, that it was a benefit to their clinics and to them. And then just having this access to these specialists for this kind of fairly immediate consultation was a major area of need that they needed for their clinics, and it was of value. Since that one ECHO session, starting in 2003, Project ECHO has become a global movement. And currently, and it went exponentially during COVID, and we're going to talk a little bit about that. But currently, there are 530 hubs throughout the world in 55 different countries, and participants from everywhere. And in addition to that one article published in the New England Journal of Medicine, there have been, this is a kind of an old slide that says that there are 328 peer-reviewed articles out there about Project ECHO. It's about 450 articles roughly now about peer-reviewed articles about basically the efficacy and the outcomes that occur in ECHO. The majority of them early on were about provider satisfaction and participation in ECHO, and do they gain clinical knowledge, et cetera. And so all of those are available for you guys to peruse. And then also they're delving into health outcomes and community health outcomes. So what is Project ECHO? And basically it's an educational platform for this is really hard to say, I'm gonna try to say it 10 times, the demonopolization of knowledge. And so we're trying to get that knowledge basically from the specialists to all over our state, to those frontline workers that are actually seeing the patients in their communities. And basically, we're trying to create a force multiplier to increase clinical capacity to care for patients. And we're doing it for these chronic, complex conditions where people can be trained pretty easily to treat. The whole goal is to expand specialty care access to all these rural and medically underserved communities. And what we do is we try to create this all teach, all learn environment. It's not just a subject matter expert delivering one directional communication to the providers in those communities. The whole idea is that I learn from you, you learn from me, and then we all learn from each other. We want to create this very social learning network. We also really, Project ECHO can really address the local needs of a community and state. And so we really delve into where the shortage areas are in the state. Where are the highest needs for health outcomes in the state? We really look into that, and then we can build ECHOs around those. We want to make sure that every time we do an ECHO session, you know, there's so much medical information out there in the world, and so much comes so quickly. In order to stay up to date with evidence-based practices, it's really hard. And so in these sessions, we make sure that everything is always cutting edge, always rooted in evidence, the latest evidence-based best practices. And then overall, Project ECHO, we feel, ends needless suffering and reduces disparities in access to care. So how does it work? So everybody knows Zoom now, which is a huge barrier that we had initially when we started Project ECHO. People didn't use Zoom. Initially, Dr. Aurora started with Skype, but eventually, in around 2011, he moved over to Zoom. He got the first multi-use license. He could give it to anybody that wanted to do Project ECHO for Zoom, which was pretty fortuitous then, because what happened in 2020 with COVID. So he was able to give Zoom licenses to people all over the world to be able to do ECHO. So we utilize Zoom, so we utilize technology to leverage scarce resources of our specialists. We utilize a hub and spoke model. We build these specialty teams, these subject matter experts, and then we remote out to all the providers. There are 4 guiding principles of Project ECHO. Amplification. We want to use the technology of Zoom to leverage our scarce resources. We want to make sure everything is rooted in best practices so we can reduce disparity across the state and across the world. We want to make sure that we're utilizing case-based learning in order to master the complexity of treatment. And then we want to make sure we study it. We want to make sure we're gathering data about it. We want to really monitor those outcomes. So what happens in a session? COVID changed a lot of things. During COVID, a lot of times it was just really trying to get information out to people. But normally in a normal ECHO session, we start with that short 15-minute didactic presentation. Generally, our ECHOs are held over the lunch hour because that's when physicians sometimes have some time, if they have any time during the day, but sometimes that's a good time for them. And then we do that 15-minute didactic presentation, talk about it a little bit, and then we really go after those case presentations. So a provider will present a real patient, de-identified, to the group, and everybody will start talking about it. They'll ask clarifying questions about it, and then they're going to give recommendations on how they would treat that patient if that patient was sent to them. And then we write them up and send them to the provider, and they can choose to implement them or not. And then they can represent that patient if they want to, but we never take over care of that patient. That's an ECHO session in a nutshell. So the whole idea is to create these dynamic learning loops. We want to make sure we have a very interactive environment. And we want to make sure that they're learning from the didactics, but we also want to make sure that they're learning by doing with those case presentations, because that's how all you guys learned. And we want to make sure it's all about this collaborative problem solving with this interdisciplinary group. Some people might not even think of something that a clinical pharmacist has to add, that is a contraindication with another medication or something like that. But the whole goal of Project ECHO is all teach, all learn. No one has all the answers, so we want to work together to solve problems. What's the difference between telemedicine and ECHO? And you guys might know this by now, but telemedicine is basically, as you know, it's one provider to one patient, generally. Whoops, sorry. And then ECHO, so that's a one-to-one interaction. And with ECHO, it's a one-to-many interaction. And the whole goal is to create this force multiplier to increase capacity. So now we're getting to the best part. OSU Center for Health Sciences Project ECHO program. So this is what we're trying to do across our state. And we're trying to create specialists in a variety of different areas all across throughout all our 77 counties. And so where do we start? So we started in 2016 with the vision of then President Dr. Casey Schrum, President of OSU-CHS at the time, and Dr. Johnny Stevens as well. They went and met with Dr. Aurora. And as you know, OSU is a land-grant university, and Project ECHO is completely aligned with the idea of the land-grant mission. The idea is that we are serving rural Oklahoma, and we want to make sure that there's enough care in rural Oklahoma. In addition, at OSU-CHS, we're educating the future doctors of our state. We realize that the majority of graduates from OSU go back and practice in the rural communities here in Oklahoma. And so we wanted to have this mechanism to be able to support them throughout their practice once they graduate and are in the field. So in 2016, we developed a partnership with the University of New Mexico to build ECHO at OSU. In the meantime, we were also doing a needs assessment of what was going on in the state, of all our health issues in the state, the shortage areas, et cetera. We found out in 2016 that the highest areas of need at that time were adult mental health or psychiatry, addiction medicine, and pediatric obesity, but also we had really high rates of maternal and fetal infant mortality during that time too. Then it comes to 2017, and we were lucky enough to have the generous support of the Ann and Henry Zero Foundation to really start to launch Project ECHO at OSU Center for Health Sciences. And at that time, we were able to launch our adult psychiatry ECHO and our addiction medicine ECHO. And then we quickly moved on to our childhood obesity ECHO, because if we can solve some problems early in childhood, we hopefully can mitigate some damages further along in the disease process as they age. And then later on, we started our HIV ECHO. with the high prevalence of HIV in Oklahoma. And the whole idea of getting it out of the academic centers and supporting the rural communities once again. Then we went on in 2018, and we continued to grow. Oklahoma has some of the highest, certainly in 2018, the highest ACEs scores or adverse childhood experiences in the country. And so we really wanted to do something to support that 0 through 18 age population. And so we created a pediatric behavioral and emotional health echo to really help with that population. And in that group, our learners are physicians, our learners are social workers, our learners are LPCs, psychologists, et cetera. So our spoke sites are. And then we collaborate with DHS and ODMH, et cetera, Department of Mental Health and Human Services. For that echo, we also launched our hepatitis C echo. As you might know, we have some of the highest rates of hepatitis C in the country. So we wanted to do an echo with that, and we're partnering with Dr. Jorge Mira, infectious disease physician at the Cherokee Nation, and to run that echo, and actually Dr. Gita Pai at Stillwell to run that echo. We also started a forensic psychiatry echo and an infant mental health echo to support a 0 through 3 population. Again, with all those high ACEs scores, we wanted to be able to help those kiddos. And then in 2018, we also started, it's kind of a little off the healthcare outcomes, echo for healthcare outcomes trajectory, but we started the first education echo. And it sounds a little weird, but it's K through 12 schools. And so we wanted to make sure that the quality of education throughout the state was all the same, and we started with school superintendents. So we did educational development for school superintendents, and it was the first education echo, and one of the first in the country. Moving on to 2019, we launched our TeleEdge, another education echo, in partnership with Oklahoma State Department of Education, and that's helping it's based on the report cards for schools, the rankings of schools. We want to bring up the ones that are lower ranking to the level of the higher ranking schools. So we're really working with those schools, and Oklahoma State Department of Education runs that echo in partnership with us. And then we started a special ed echo, TeleSped, in partnership with the Cooperative Council of Oklahoma School Administration. That was a hugely popular echo, still is a hugely popular echo, and became very high need during COVID. We quickly went from like 40 participants to 500 participants weekly. So, and then in 2019, we also became a super hub. We're one of 14 super hubs in the world. And basically at that point, we're able to train other organizations to be able to do echo. Again, a version of a force multiplier. Then 2020 hit and everything changed, as you know. So 2020 and COVID hit, and in March of 2020, obviously the first few cases were starting to brew, January, February around the world. We had our first case in Oklahoma in March of 2020. And at that time, the president of our university was also Governor Stitt's Secretary of Science and Innovation in his cabinet. And they needed a mechanism to get information directly out to frontline healthcare workers during COVID, and reliable information and data out to frontline healthcare workers so they can manage things. And so they chose Project ECHO to be that mechanism to get the information out. And very quickly, we started running echoes.
Good morning. I'm so excited to see you here on this OSU Project ECHO COVID-19 session. Thanks to Dr. Casey Schramm and her visionary leadership as my Secretary of Science and Innovation and as President of OSU-CHS in bringing Project ECHO to Oklahoma. By utilizing technology, OSU physicians, nurses, psychiatrists, and others can share evidence-based practices and knowledge with healthcare providers across our state, and most importantly, to the frontline workers in rural Oklahoma who are dealing with this pandemic with limited resources. The innovation solution of OSU Project ECHO and the COVID-19 sessions make resources and expertise available to all 77 Oklahoma counties. This morning, we are presenting you the resources and information you need as part of the state's hospital surge plan to be prepared for the peak of the COVID-19 outbreak. I want to thank each of you for the hard work you are doing for your communities to keep Oklahomans safe and healthy. God bless you, and God bless the great state of Oklahoma.
So we watched that a lot during the past year or so, 2 years. So on March 20, 2020, we launched the first COVID-19 Oklahoma Update Echo, and since then we have run 168 of those sessions. We started running them 3 times a week, and then eventually a year and a half later we were able to go to weekly. And during those sessions, what we did is we brought the communities together to understand what everybody is doing to solve this problem of COVID-19 in our communities. So we would bring in the Cherokee Nation to speak about what they're doing. We would bring people to talk about testing. We would bring in all the tribal nations to talk about all the tremendous work people were doing at this time. But we would also give data about what's going on, prepare the frontline healthcare workers to go into work. And then we would bring all the latest hot off the presses literature and basically, you know, that's a lot of information coming at you. So basically we would streamline that information and give that to the providers so they can go in and do their work. Soon after that, we started to do our surge plans. We were tasked with getting out the hospital surge plan or pandemic response plan to all our hospital CEOs and emergency teams at the hospitals, the EMS, the medical examiner teams and the mortuary services teams, and all the healthcare providers. And long-term care facilities and nursing homes, et cetera. We talked about the statewide testing that was available and being built at the time. And then we also worked to give updates to our legislature. We did 44 sessions with our state and federal delegation, and on and on. In total, we did 259 ECHO sessions during that time. So then we continued also, we built a few more ECHOs while we were doing this. So we built a high-risk OB team. We finally got to do our maternal health ECHO. So in partnership with Oklahoma State Department of Health, we're able to do a high-risk OB team. And on that team, we have a maternal fetal medicine physician, we have OBGYNs, we have family medicine providers, and nurse case managers in order to talk about how to manage these high-risk cases. We also started 2 more education ECHOs, Tele-Lead with our new school principals in partnership with COSA again, and we did Tele-Engage, which is parental engagement. So kind of a busy few years there. And the reason I'm telling you all of these, because now you guys can know all the ECHO lines that are available for you guys to join in. In 2021, we started an end-of-life care ECHO in partnership with Clare House to teach nursing students how to talk about death and dying and with their patients. We also started, as a result of COVID, we realized frontline healthcare workers were experiencing massive stress, obviously. And so we wanted to do something to help support frontline healthcare workers. And this one is specifically for frontline healthcare workers. And it's called Help for the Healer. And it gives, during the session, it's a little different than a normal ECHO session where we do case presentations. In this one, it is for the frontline healthcare workers. So we do a lot of mindfulness techniques. We do a lot of self-care techniques. We talk about, there were a lot of financial impacts for providers during this time too. So we walk through that a little bit as well. We talk about organizational leadership and how to support frontline healthcare workers during this time. And then there were another population was struggling with some issues. So we started Heal the Harvester. And so Secretary Arthur and the Department of Agriculture, Food and Forestry approached us at OSU. And they were talking about all the stress that farmers and ranchers were experiencing as a result of COVID. We realized the food shortages, we realized the supply chain, all sorts of things, and the financial impact that was being experienced by our farmers and ranchers. and they wanted to do something about it. So we built an echo around it. And the whole idea is to come into contact with anybody that could come into contact, any stakeholder that could come into contact with a farmer and rancher, the physicians, a banker, your church. Those people were the audience, and to identify stress and anxiety in the farmers and ranchers, and then be able to provide resources for them. And then we started the first education echo in Africa after that. Oh, no, very importantly, we started a veterans care echo. And so that is directly towards physicians to talk about how veterans access the healthcare system, because it's different. And so it talks about military culture. It talks about all things, how a physician accesses the healthcare system. Then again, the first education echo in Africa, and that's in Nigeria. So currently we have a total of 14 healthcare lines, echo lines, and 6 education echo lines. These are them. So you can join in, pick some and join in. We would love to see you. And again, the majority of our echo lines run over the lunch hour for a convenient time for a provider. And so we're strong sticklers to time. We start at 12 and we end at 1 for the majority of them. The infant mental health and like the pediatric obesity with complex cases where they're really dealing with behavioral health issues as well, sometimes they will go to an hour and a half. And all you do is just log in and you can join in the session. These are our 6 education echo lines that we currently have. And physicians can join in this as well. So in total, since we launched the program to 27, just to give everybody an update, we have run over 1,790 echo sessions in total over that time, and we've presented 1,589 cases. So that's patients that we've presented during echo. Just to let you know, in our hepatitis C echo alone, we've presented about 651 patients during that time. So those are patients that potentially would have otherwise gone without treatment. And so they were able to get their medications through our echo sessions. Overall, our total participation has been over 73,000, and we have, in fact, reached all 77 counties through our echo programs. So a lot of people want to talk about cost savings. Overall, with the knowledge, again, this is a force multiplier, and the whole idea is that we're keeping those patients in the rural communities, in your rural communities, with you, the providers that they trust, instead of sending them to the academic centers to specialists. So the cost savings is that idea of the cost averted from sending it to specialty care. There are enough patients to still continue to go to specialty care, so we're just being able to treat the ones that can't get that care. So basically, with the knowledge someone learns in one echo session, they're this is conservatively able to treat 10 patients with that information in a year. So, and then that means keep that patient in that community. So the cost savings just soars. It's discussed that, in New Mexico and in the literature, that the cost savings of averting just one visit to a specialist saves $1,943. So if we can just keep doing this, obviously the cost savings is just going to go up. I think something really important to talk about is if we don't treat this, we're going to have, it's actually the expense of untreated disease. So, with untreated disease, it goes through a higher, goes up to a higher level in the disease process, which generally is more expensive and a burden on our community and Oklahomans. So we want to make sure people can get treated early on in their disease process. And we know this is very conservative now based on echo, but one specialist can train, it started out 20 providers in one session on a subject. But, currently with our echo participation since COVID, we're having up to 80 providers in one session. So clearly we're going to have exponential growth in capacity to care for our state based on that. But the big study came out in February of 2022. We're very excited about this. It came out of Rutgers, and it was from their diabetes endo echo. And the whole idea, big study, but the whole idea in the end, they were comparing utilization and spending of Medicaid patients seen by the primary care providers that attended and participated in ECHO compared to the ones that didn't participate in ECHO. And you can see that there's a massive cost savings there. There's a 44.3% decrease in admissions, and then also a 61.9% decrease in inpatient spending. If you think about globally and just in the United States, all the ECHOs that are running, just in Oklahoma, all the ECHOs we're running, the cost savings is just, again, going to soar. So what's the future of OSU Center for Health Sciences Project ECHO? My goal, my idea, first off, with Project ECHO, it's limitless. It can be anything. We could talk about, when we have talked about building clean water wells in Africa and training people to do that. We have talked about working in vet medicine. We've talked about agriculture in Africa. And we have such wonderful resources in Oklahoma that could share their expert knowledge around the world. So again, limitless. It's just, limited by our imagination and money, funding. So, but we're going to tackle it all. Our goal ultimately is to reach all 77 counties in the current ECHO lines we have, to build all those specialists, and also to decrease disparity and also get the education in our K through 12 schools up to where it's equal across the state. I want to continue to look at specialist shortage areas in Oklahoma. We know that we can look at diabetes and endocrinology. We have some shortage areas there, and rheumatology in particular. And those are two of my ones I really would like to get started. We continue to assess other areas where we need to improve health outcomes in Oklahoma. And you've got to take in consideration what's happened with COVID. What are things that we need to tackle after that? We've got long COVID that we could work with, and working with providers about that. We have mental and behavioral health issues around that, things that occurred during the pandemic, further with addiction, and pregnant women with addiction as well. Those are things that we're looking at. We've been talking with people in the Congo, and we really want to work there. They have about 4 missions that they want to accomplish. Having babies survive is one. Having children survive past the age of 5. We really want to develop their education system and the economic growth, but also train the healthcare providers to be able to care for their country. And so we're going to start potentially with decreasing maternal and infant mortality in the Congo. The next thing we really want to try is combining health and education, the K through 12 schools. We're looking at behavioral health, ways of, and how that impacts learning as well, and also dyslexia and et cetera in schools. But my goal also right here is we really want to increase primary care physician participation in Project ECHO. We can't do this without you guys. We all have to work together, and we're all pieces of this puzzle to solve this. So, and want to really increase participation with our frontline people, providers. I would really like to continue to increase collaboration across the state. That's what Project ECHO is about, and really connecting with other partners to further grow and solve the health issues in our state. So this is kind of a word salad slide, sorry, but what can Project ECHO do? It can do a lot. It's a force multiplier. There's logarithmic growth and capacity to care for our state. We know that it supports healthcare providers in their communities with real patients. It facilitates professional learning and builds this knowledge-sharing network. So if a patient needs to be up to a higher level of care, we have a network in place that can handle that can work together. We use an interdisciplinary lens to tackle all of these health issues. We know that it eases provider isolation. It helps with retention in communities of providers. We know it bridges equity barriers, but I think this is really important. It eases the burden on our patients. It eases travel, it eases time, childcare, loss of income, because they're with those providers in their communities, getting care with their families alongside of them. Patients get the right care, the right place, at the right time. We know it improves outcomes and reduces costs. And guess what? Added benefit, it's no cost to participate in it. It's all free. And you also get free CME for every hour that you're in our ECHO sessions, healthcare ECHO sessions. We do CEUs for the other one. So how do you join in? Want to make sure I'm on track. How do you join in? How do you join in an echo session? It's very, very easy. You go to our website, medicine.okstate.edu/echo, and then you also get to see our new lovely office building donated to us by the Ann and Henry Zero Foundation. But go to the website, you can complete the registration form. It takes a minute, maybe, and then you'll immediately get a participation guide, how to participate in an echo session. We want everybody to have a voice and share their voice in an echo session. Again, collaboration is key. You'll be emailed an invitation 2 days before an echo session and the day of an echo session, so it'll be right at the top of your inbox. And all you have to do when an echo starts at noon, open that invitation, click on the link, and you're in it. It's pretty easy. And we're there to help if you have complications. But overall, this is what we're trying to do. We're trying to, we're trying to build a network, because what we know is when we work together, we're better. The whole goal of Project ECHO, moving knowledge, not people, encouraging collaboration, and building that clinical workforce capacity. Thank you. Any questions?
If anyone has questions, I'll give you the mic.
Tara, I appreciate you being here today, but I participate on a Veterans Health Echo.
Hi.
It's on Thursday at 1 o'clock, and a lot of it has to do with mental health, but we cover a multitude of subjects, and I know in May we're going to cover opioid dependence and treatment, but of course it's such a short time, but there's a wealth of information from people who work at the different programs to try to help veterans. And if you have a veteran that needs help, you can go on this, and it's the first and third Thursday of the month. I'm just throwing a plug here at 1 o'clock, and everybody is welcome to attend. So I just wanted to say that, and I appreciate ECHO and what it does for them.
Awesome. Thank you. Thank you for, he's on our expert panel. Hub team. Any other questions?
We have a question from Zoom. Just a moment.
And sorry, Zoom, I blend into the background.
The question is, are there any plans for a rheumatology panel? Access in Oklahoma is very limited at this time.
That is my hope and plan, that will be one of our next ones that we do. We know that, I think, I have notes on it, but I think 25% of adults in Oklahoma are diagnosed with rheumatology, and we have like 58 rheumatologists in Oklahoma. So that is a high need area from my perspective, so yes. Do they want to be on a panel?
My curiosity, how many people attended the echoes for COVID? Even just one of them? Okay, super resourceful. Being out in rural Oklahoma, like it was huge. It was a lifesaver. Tons of information and very well presented, and still is. Any other questions?
Oh, I also have, if anybody wants it, for people on Zoom, please go to our website. You can take a look at it, but people here, if you just want to click on that, this QR code, it'll take you right there. So I'll put these in the back somewhere. All right.
Thank you again.
Thank you, everybody.
Our next speaker is Cori Hook Loomis, JD. Cori is an attorney with the Christensen Law Group with a primary focus on the representation of healthcare providers with transactional, compliance, reimbursement, legislative, and regulatory issues. Cori graduated with a special distinction from the University of Oklahoma in 1991 and with honors from the University of Texas School of Law in 1994. In addition to being in private practice during the course of her career, Cori has served as the University of Oklahoma's Compliance and HIPAA Privacy Officer and was General Counsel for the Oklahoma State Medical Association. She has been recognized by the Journal Record as one of 50 women making a difference in 2014, 16, and 17. She also received a Leadership in Law Award from the Journal Record in 2010 and was accepted to the Oklahoma Bar Association Leadership Academy in 2011. Loomis was selected by Governor Mary Fallin to the Oklahoma Board of Nursing for a term from November 2011 to 2015. She is a member of the 34th class of Leadership Oklahoma City. Welcome, Cori Loomis.
Yeah, thank you. Thank you all for having me here. Good morning to all those online. We're going to talk about physician contracting issues, and I'll go through. If you all have any questions, I'm opening to answering them. There is bright lights right in front of me, so try to make sure I can hear you. And I don't know if the people online, can they post questions or? Yeah, okay. So just let me know, but somebody get my attention as we're going through this. We're going to start out, with talking about some employment agreement issues that come up and that I see, and try to give you a perspective on if you're going to work with an attorney on those issues, how to maximize the benefit. Again, attorneys are pricey and expensive, so you want to make sure you're getting value out of that and some tips for that. And of course, we're going to a largely employment model. The statistics I saw just this week are, we're up to 70% of physicians now are employed in that employment model. And of course, COVID and all the things going on have even raised those percentages. But there still are some independent, large practice groups. So we want to address medical practice ownership and buy-in issues that I'm seeing, hospital physician integration, and then the new concept, or relatively new, especially in Oklahoma, just to alert you, I'm not going to spend a whole lot of time on it, but is this concept of private equity buying physician practices. And if you're approached, some things you need to understand about how that's working. But first we'll start with employment agreements, and I've just kind of done this as an overview and not the more of a basic presentation, but from a kind of a common mistake, tips sort of thing. And it sounds I was reading my notes, I was like, oh, not consulting attorney, that sounds self-serving, like everyone should consult an attorney, which is not necessarily true. But some of the mistakes is not consulting an attorney, consulting them too late in the process to get any value out of it, or not telling the attorney about verbal agreements. And let me try to explain that. These days, when you have an employment agreement offered to you, and understand that most health systems, employers, they have a template contract. When I started in the legal field 20 years, it would be maybe the attorney for the physician would draft the contract. That doesn't happen anymore at all. The employer has, in 90% of the cases, their, quote, template contract that they start from. And they are very reticent to make huge changes to it. So understand the attorney, there's no opportunity to redraft a whole lot of the stuff or do their own version or anything like that. So if you go to an attorney that's their inclination, you might as well say, time out. That's going to be a waste of time. We're not going to make any progress with that. But within each system's template, the benefit of going to an attorney is to, one, usually if you're going to an experienced attorney, they will have seen that same template several times before. So they know, and they will be able to tell you, here are some things that I've seen them change in the past. In other words, provisions they are willing to negotiate on and say, this, you could ask for this. I've seen other doctors that I've done ask for this, get a little more here. You get what I'm saying. So they'll know if they're in that experience. And that's another thing. Try to find someone, either the OOA probably has a list of attorneys that they know have experience in negotiating these. So you're not going to someone that just has no familiarity with the healthcare laws. Because if you go to somebody unexperienced, they may say, well, let's ask them to change this. And it's a provision that the hospital can't change because there's a legal requirement behind it. So it saves all of that type of miscommunication. Also, if you're going to go to an attorney and you do it at the very end after you've already negotiated all the terms, again, you may not get, the value you were expecting. An attorney can still go through, and oftentimes this is, what I do is there's still some benefit, and it doesn't take as long to say, here's some things. Do you understand what these provisions mean? Have you asked these questions to make sure you're fully informed about what that contract means to you? So there's still some value in it, but understand if you go to the attorney and they say, well, hey, I've seen people get double signing bonuses. You say, oh, well, I've already agreed to that. well, then it's too late. I mean, you've missed the opportunity to ask for a higher signing bonus. So understand that dynamic. But the big one that I wanted to point out, and I always put this when I'm doing summaries for physicians on contract reviews, and some of this, by the way, applies to any type of contract. We're talking about the employment context, but it could, you know, a lot of these things I'm telling you could apply across the board to any contract you're negotiating with the hospital, medical director agreement, whatever. But you're the one been going to the recruiting meetings or the meetings about this project, not the attorney. And so there's a lot of conversations that have taken place. The attorney who's looking at the contract has no idea. So if there are terms, there are things that are important to you that you brought up at the meetings and you haven't told the attorney about, they can't look for it in the agreement. For example, I'm just going to throw out some so you'll know what I'm talking about. If it's very important to someone that instead of working a 5-day work week, Monday through Friday, they work Monday through Thursday, 10-hour shifts, most of the contracts aren't going to say that. They're going to say something very vague, like you'll work the schedule we tell you to work. Well, if that was something that was important to you, it should be in the contract. If you don't tell your attorney that, they're not going to know to say, hey, you know, it's not in here, you should add it. So I always, when I'm working with physicians, say, look, spend some time, think about things that you talked about. If it's that you're a parent and you in this system or whatever, your employer has multiple locations, but it's very important to you that you be close to your child's school. Again, you may not want to agree to the language that says you will work at any clinic we assign you to, because being close to your child's school is something you need to do. Anything of that nature. If there's some piece of equipment you were trained on and you were counting on them providing you that equipment, again, it's most of the templates, all of the templates I've ever seen do not address specific things like that. If you want to have, say, input on any mid-level practitioners that you work with or have to supervise or whatever, it needs to be in there, and they won't, the template. So give issues like that some thought before you engage an attorney or when you do, so that the contract will reflect those terms that are important to you. A second is, and this, I used a legal term that probably doesn't mean anything to you, failure to conduct adequate due diligence or research the employer and the culture. Again, I always have some kind of really routine things that I put back when I'm reviewing any contract with a physician. And one of them is, okay, I mean, this can be a good contract on paper, but it's just what's on paper. And that's not going to make you like working for these folks or at this location. I mean, it's good as the term, but no matter what your signing bonus was or what your comp is, if it's a group that has some sort of toxic work environment, or the administration of this place doesn't seem to respect or listen to the physicians, it's going to be a problem. It's not going to be a fun place to work. And so I've always have you visited the location? Have you talked to your colleagues? Do you feel comfortable you're actually going to fit in and like it, and that this is a good place to work? Is there any idea that there's a lot of turnover here, a lot of dissatisfaction, those type of things? Because again, no matter what's on paper, you can't make up for that kind of stuff. And so make sure you've done, you're comfortable with it. And I know, especially with really, really young doctors, and they're just coming out of their training and residency, they're just ready to hit the ground running and, their first job, and they don't want to think about those things. More experienced people who have lived through, unfortunately, some maybe bad situations understand this completely, but it's hard to get maybe some of the younger physicians coming right out of their residencies to say, okay, have you actually visited? And do you know this place and that type of stuff? So be cognizant of those issues as well. Oops, I pushed the pointer thing instead. Failure to ensure you understand the terms. And this is really the primary role that I feel like in today's environment attorney can help with. Because again, there's not a lot of, we're not going to just start over with a contract. And there's a lot in these. That's why doctors don't like to read them, is because, you're getting 15, 16, 17 page documents full of stuff that you're like, what does any of this mean? And why should I read it? And so a lot of times that's what I'm doing. My primary role is, this is what this means. And have you thought about this? And do you need, understand this is what this term means. And some things like that are, they always put, defined terms. Do you understand those vague provisions? Again, ties back to my other comment. It's a template. So they've drafted these to basically give any doctor in any situation, any specialty, here's our contract. So make sure it's tailored. If it needs to be, tweaked to make your specific circumstance, that's what you need to do. Physicians who share call. Let me just, try to give you some examples so you can tie it together in your head. A lot of times it says you will take call according to our policies and procedures. Well, what are those? It could be a real big bummer if you're going to a place and you find out you're the only one on the call schedule. So is it a realistic call schedule? I mean, that their bylaws or their medical staff policies, you cannot be on call more than X number of days. Do they compensate for call? Who do you share call with? Even if there is a group of 4 now, I mean, unfortunately, what happened during COVID and doctors may be retiring earlier than they thought, you may go and think, well, there's 4 now, but what happens if one leaves in the middle of your term? Again, make sure there's some protection that I will not take call more than once a week or whatever is a reasonable amount for you in your specialty. And who are you sharing call with and how is it divided? And are there any exemptions? Like, well, I thought there was 4 doctors in my specialty, but you find out later that one of them is above a certain age and they no longer share call anymore. I mean, so you want to nail those details down like that. Again, these contracts would be even more voluminous, but for it's very common. They're not trying to hide things, but it's just a common practice because the contracts would be too wieldy. They just incorporate documents by reference. And they'll say, you agree to comply by our medical staff bylaws. Well, do you have a copy of the medical staff bylaws? Or if you are going to work for a Catholic institution, they always put, you will agree to comply with it has a long name, but it's the Catholic directives. Okay, are you at least aware of the implications of that? Do you have any philosophical, ethical, religious, objections to complying with those? You need to think all those through before you sign the document. So a lot of that is also your benefits oftentimes are incorporated by reference. We will give you whatever benefits we currently have in place. What are those? Because benefits are a huge part of your compensation package these days. And what are those? What do they entail? So beware of that and ask if I'm going to be subject and I'm agreeing to comply with your policies and procedures, what are your policies and procedures? Because again, those are usually tied to the termination provisions. And so you don't want to be subject to termination of your agreement for violating a policy you didn't even know existed. So those are the type of issues you need to think about. And then again, goes back to the whole verbal comments. What's not in the agreement is often as important as what is. I mean, if there's things that just simply aren't addressed before you sign the agreement, is your best opportunity to get them addressed. I can't tell you how many times doctors have called, upset about something that, when I was recruited out to Western Oklahoma, the hospital said they were going to remodel my clinic. We were going to, have a new office. I'm still in the same dump that, that they gave me. Well, let's look at your employment contract. And of course, it's not there. So something they verbally said that was obviously important to this doctor is, I was willing to be in this place temporarily, but I thought I was going to get a new location at some point. And then it never happens. And then the doctor doesn't have a right to terminate for that reason. And so you have to work through all of that. So just, really give some thought. That's where I see, frankly, the biggest issues are what ends up not getting into writing between the parties, and then what happens then. This is gonna, is a big deal, understanding your compensation terms. And again, it used to be so much easier than it is now. It would be, a base salary. You're gonna get 200,000, 250, whatever that amount is. But as you all probably know, things have gotten so much more complicated, and we've morphed to paying more for production and work RVU formulas. And now it's work RVU formulas plus. And then, you know, we're heading to, Oklahoma's very slow in adopting, but I think with the push to Medicaid managed care that we're seeing at the Capitol, we're going to start seeing picking up where you're going to have much more value or outcome-based formulas woven into your formulas. And some of this has gotten so complicated that it is not in the base agreement itself, because Integris, Mercy, St. Anthony's, they have a very complicated, and they will say your compensation, maybe you, in the first year you get a base salary or something, but then in year 2 or 3, you morph to our physician compensation plan. And it's not attached. So the attorney has no idea what the physician compensation plan is. And so you need to understand that. And I usually ask the doctor, well, did they give you some pro formas or examples of, if you're making this many RVUs, here's what it will look like. If you're doing this, it will look like this. What are the quality measures that are being woven in? And I think you're gonna see more of those. And again, now's the time to negotiate that. And I think that the next big, I was just talking before I started this, that with Medicaid managed care, the next big push, I think, to protect physicians on contracting and compensation is to do more education with, okay, let's get ahead of this, and with the hospitals, because if the hospitals are getting a capitated payment, how are the physicians how is that gonna flow down to the physicians? And what criteria is gonna be used to flow down to the compensation? And I think it's important that physicians, we start having some input on that and not just be told, because they come up with some, you know, thing that they think is great that a doctor knows is totally unachievable. And I've seen some contracts like that. And I said, you know, I tell the physicians, look, this formula is, I don't see you ever making it. So any of this bonus, you need to be happy with whatever is the non-bonus side of the equation, because the bonus is almost unattainable and you can't even count on ever getting it. So you need to be happy with this side of the ledger, because this is, you know, doesn't make any sense. But I think we should start making it make sense. I mean, let's get in on the ground floor and say, okay, what is a measure that a physician has any hope of controlling? And it makes me very nervous for doctors to hear, you know, legislators and stuff start talking about outcomes. They can't, I mean, you can tell somebody all day long that they're overweight and they shouldn't be, or they should not smoke. And you can ask the questions on your form. I mean, I'm preaching to the choir, I know that. And you can do all these proactive things and document that you've done it, but that ultimately comes down to what the person actually does. And so, you know, making a physician responsible for an outcome is going to be very, very hard. You can do quality measures and certain things. So we're going to have to start working and educating on that, so that it's not, I mean, physicians are probably going to have that model forced upon you, but making it something that you can at least accept and still have a decent compensation and a fair compensation. I think we were also talking before this, nothing is more demoralizing than having a compensation formula that you have really no impact. I mean, yes, that's what the formula is, but you can't positively affect it. And that's what we've got to start educating. So I think that's the next, I think RVUs we're gonna see those become less and less important. It still may take more years, but it's something on the horizon. The benefits, again, benefits are a huge part of the compensation. I think a lot of times physicians they're just looking at the, you know, cash compensation, but benefits are very, very expensive. So, okay, am I gonna get my insurance, my health insurance? Do I have to pay anything for it? What about my dependents? Do I have to pay for them? I really always encourage doctors, disability insurance, especially, you know, for surgeons and things. If you go skiing and you bend your thumb back on a ski pole and you can't do surgery, there's your income. So, and oftentimes the hospitals and system, they will have some sort of short-term and long-term disability, but it's not at a rate that will supplement, that will completely replace a physician's salary. So then you may need to supplement it so that your family will have the same income coming in case you're disabled and not some much, much reduced amount. So work through those. Retirement savings, same thing. Yes, they probably have one for their, all of their employees, but is enough going in that will give you the retirement that you're anticipating at the levels you're anticipating. So think through all those, and if you need to supplement them, that you're doing that from the get-go. Also, you probably do get this, that again, these contracts are written by the hospitals. Like I said, you're not, or by whoever the employer is, you're not going to get to just start over. You're going to get their template. And, you do laugh. There will be pages and pages and pages, but when you get right down to it, it's all of the representations you're making to them, the services you're going to provide to them, and then there will be literally maybe 3 paragraphs or a page saying, basically, our obligation to you is to pay you, to give you supplies and equipment and an office, and it's just that general. I mean, there's no detail on it, and staff. And so there's 3 things they're committing back in very general terms, and that's it. So again, if you have more specific things you want to see, make sure you're addressing it now. Also in there is, tail insurance is a huge issue. Okay, what happens? You need to think, and this again is where an attorney can be helpful, is doctors going into a contract oftentimes are just thinking of the beginning of the relationship. But unfortunately, some relationships don't go the way you want, or you have a better opportunity down the road. And so thinking through what happens if this is terminated is important at the beginning, because you're not going to get, if they've said, okay, if this terminates for any reason, you're done, you're leaving, and you have to buy your own tail insurance policy. Tail insurance is usually 1 1/2 times 1 year premium. So it's a big expense. And if you're not thinking of that and being aware, oh goodness, that impacts your decision to leave a job sometimes, is I've got to stay long enough or whatever the contract allows because I don't have $20,000 or something to pay for my tail. Or if you are negotiating to go somewhere else, you negotiate with the next employer that they will pay for the tail. So you've got to think of all those things at the beginning and make sure. Now, I prefer, and several hospitals here are going to that, where they say we are now self-insured. We have an occurrence-based policy, which is the more favorable type of policy, so you don't need a tail. Or if it's still a claims-made policy, we will pay for the tail. That's very good. That's a very good term. But oftentimes they don't. They'll say you will. At least a compromise position in those circumstances is, okay, if you terminate the agreement without cause, just because you decide I'm an OB and we're not going to have OB services anymore, which happens a lot in rural areas, that you will pay the tail because I don't have any choice. This relationship was going fine, except for you've closed this service line, so you will pay the tail. If you have to terminate me for cause, I will pay the tail. So there's some compromise there, but you need to look through all of those at the very beginning. Again, a lot of people on recruitment, especially in the rural areas, or I shouldn't say that, the urban hospitals too, today, because of the physician shortages, there's signing bonuses, there's student loan repayment possibilities, there's a guarantee that this first year while you're ramping up and your collections haven't come in, we will subsidize you sort of provisions. But oftentimes they come with strings attached, that if you don't work here 3 years, 5 years, you will owe a pro rata amount of that back. Same issue with the tail insurance. Well, what if it's not my choice? You're basically saying I have to leave before 5 years. Well, let's renegotiate those repayment, or let's negotiate it now when you still have some leverage to say, if you tell me this job is going away in year 3 of a 5-year commitment, you'll go ahead and waive the rest or something like that. So think through all those things. Restrictive covenants is also an issue. Again, when you're signing this is oftentimes something non-legal people don't understand. There will be restrictive covenants. You're an employee. Under Oklahoma law, current Oklahoma law, a covenant not to compete with your employer in an employment contract is not enforceable. Now, some people will include them anyway because they bank on the fact that the physicians won't understand it's not enforceable and won't challenge it. They're not enforceable in a straight employment contract. Now, if you own a group and you're sharing, you have goodwill in the business, it's a different issue. But if you are a W-2 employee, a covenant not to compete is not enforceable. So there's that, but there's other types of restrictive covenants that are enforceable, and the most common is a non-solicitation provision. And it usually says you will not, if you leave here, you will not solicit patients, and you will not solicit our employees to go with you and stuff like that. So you have to be cognizant. What does that mean? Especially, I get the question a lot, well, can I not advertise? A general advertisement that you just put a new ad in the paper or something like that is not a solicitation. But you can't, if you're an employee, you can't start giving out new business cards to the patients, or you can't copy patient records from that employer. You can advertise in a general way, but you cannot solicit. And so that comes up a lot in the significance of that. So that's my comments on employment agreements. Do any of you have any questions that came up that you'd like to, any online that came in? All right, if there is, just let me know and I'll be around for a few minutes afterwards. But if you're still in or considering a private practice, situation group that's not employer, there's also practice buy-in issues that you do need to consider. And the first one, I put this right after employment, because if you're going into a situation where you expect to be allowed to buy into the entity or become a partner, become a member of the LLC, really something should be addressed in the original employment agreement. Again, I feel very, very bad for young physicians who come to me year 2, 3, 4 of their employment arrangement and said, when I was recruited, they told me I would eventually someday get to be a partner of this business, and it hasn't happened, and what do I have? Well, did your employment agreement say anything about it? No, it was all verbal. It was all just, someday you will be a partner. Well, ideally, you may not be able to get a lot of specifics, but at least, okay, it's year 2 that you're first eligible, or it's year 3 or whatever it is in your original employment agreement, and some idea of what the terms are that you'll be permitted to buy in at. It's going to make a huge difference, and it has if, sometimes it's sweat equity. and it's kind of like associates at a law firm. You're on this track, and at year 4, 5, or 6, or whatever, the entity feels like you have earned your keep. We've, made money off of your services, and it's time for you to share in the profits. And so you really don't buy in anymore, or maybe you do. Maybe there is a buy-in price. There is more disparity in the physician world than in any area. And unfortunately, I've seen young doctors come back and say, well, yeah, they're offering me an ownership interest, but they want me to pay $500,000. And I had no idea it was going to be $500,000 to buy in. I don't have $500,000 in the, I'm going to have to take out a loan to buy in. So you don't want any really harsh surprises like that. So you at least want to, if that's your expectation going into the arrangement, you at least want to say, okay, it's year 2, you're eligible. There's a significant buy-in or there's not. What are the criteria? Does it have to be a unanimous vote of all the other partners, or is it a majority vote? That can be important. There could be one personality conflict that keeps you out. You need to know that going in, or what the expectations are. The next bigger question is, what happens if I'm not allowed to buy in? Does this employment agreement I'm used to carry over on their same terms, or is there going to be some big change in my status? Will it just be, kind of eat what you kill compensation, and I've been used to being subsidized? So you need to know all of those, at least in some general terms, at the time you're negotiating your original employment contract, if at all possible. And just, some other things, what type of entity is it? Is it a professional corporation? Is it an LLC? Do they have restrictions on who can buy in and how you share the things? The thing that's worrying me most as we go away from the independent practice model to employment models is a lot of old partnership agreements of longstanding practices have some things that were drafted in the 60s or 70s or 80s that are not very good anymore. And they're specifically not good for the doctors that are still there. And so if you are part of a group, it may be something you need to kind of take a look at, because under the old models, and again, times have changed. I'm not saying this was bad at the time, but if you thought a medical group was going to stay as a group in perpetuity, how they would often draft the partnership agreements is basically the doctors that were working at the time kind of subsidized the older doc's retirement. And it would be, okay, when you retire, you get a big buyout, or you get, something, you continue to get trailing money or something like that. Well, reimbursement has changed. And so the doctors who are there now, under today's reimbursement models, they're like, we can't buy you out. we don't have a chunk of money in the practice anymore to, buy this. We had to not only pay, we barely got our shares paid for, and now you're asking us to buy you out. So all of those type of issues need to be reviewed, and because it creates a horrible paradigm for the doctors as groups shrink in size, or some retire and they aren't able to recruit in. I said, you realize this agreement, this model is going to be devastating for what I call the last man standing. The last person in this group is going to get the very short end of the stick, because if all of the other partners have been bought out, and it kind of creates a rush for the door. So if you don't work those things out now, there's going to possibly be an untoward, unexpected consequence going forward. Do the owners of the practice own other entities? Again, some of the more sophisticated groups, as things have gone on, they have ancillary lines of business. They might own an imaging center in this group, and they might have that, or they might have a management company. You need to understand the structure, because the group that you're being permitted to buy into may not be the moneymaker. Well, who cares if I'm a member of the PLLC when the money is being siphoned off by a management company owned by these other group of doctors, and so I'm getting the PC, but all the money's being siphoned out to over here. Well, then you want to own that. When do I get a chance to buy into all these other money-making ancillary businesses? And so you need to understand, how is this group structured, and how many other entities are there? And I'm being offered this, but I want a chance to own that as well. And that's what's meant by diminish the revenue of that. Liabilities, again, you got to understand, if you're buying into the group, you're buying into whatever liabilities are there as well. And again, it may be, yeah, we want more owners. You're going to have to, but when you sign this, you also, by the way, we built this nice new building, and the bank is going to require you to sign an individual guarantee on this building. And that's not uncommon. If the practice has a lot of debt, or has bought a building or equipment or something like that, banks almost always now require not a guarantee by the group, because of the phenomenon I just talked about on the last slide. They say, we can't just say the group, because the members of the group might change. The income of the group will drop dramatically if Dr. X leaves the group. So instead of the group as a corporation or an entity signing guarantees with the bank to get debt, they want the doctors personally to sign a guarantee for the debt. And so that means wherever you go, that possibility of being liable on that debt is going to follow you wherever you go. So you need to understand those issues as well. Is it, again, is it as profitable as you think? Have you looked at the pro formas? I just know that a lot of doctors come to me, not just on partnership deals, again, but any kind of investment you're offered. And they say, oh, I really want to do it. All these doctors, I'm going to make a ton of money. Well, have you seen any financial statements? No, but I've talked, I heard. Well, you heard, are you sure you're hearing the right thing? Are you being told by, is it this entity they're invested in? Are they making a lot of money? And especially if outsiders that are not licensed are involved, be aware that they could, there's a lot of business people out there, and they own the management company that helps the practice. Well, you can own the practice, the management company's getting, paid first, before any expenses. The physicians who own the practice get what's left, and there's not much left, plus the people managing it are business people, and they're making money off of the doctor's services and hard work, but they're not the ones whose name is on the 1,500 forms going into Medicare and Medicaid. They're not the ones saying that all of the services on these claims are correct. They're not the ones, they never ask the management, the non-physician management people to sign individual guarantees. So you need to understand the whole dynamic and what your possible liabilities are. And sometimes ownership, frankly, in my opinion, is not that great of a deal. If you can ask for more money, just cash up front, for your services, why take on the liabilities of ownership? So you've got to really make sure, hey, you may be in the better position and not even appreciate it, that I'll pass on your ownership because I'm afraid you have a billing issue out there that's not discovered, or a Stark Law violation that I do not want to be a part of. Again, a few well-documented cases in the city area where, big, hard-hitting entrepreneurial places, and it was very uncomfortable I represented several doctors who were just, minority owners, and, things went sideways and the government's investigating, and they were very, very uncomfortable, and it was very, very stressful to them to be a part of something. And we're like, I was barely getting any money out of this deal, and now I'm having to hire an attorney to possibly defend myself against this, potential liability. They ended up, eventually the government even realized the minority owners had no idea what was going on. But you don't even want to be in that. Sometimes it's just uncomfortable to be in that place. Was it really worth it, the minor amount of revenue they got out of it? Maybe it would have just been better to say, I want to bump on my service, my income from this, and forget about the ownership. You just, keep that, because I can't get enough of a percentage of ownership to warrant taking on the liability. So really weigh those things. Again, there's lots of other documents that come with ownership: a subscription agreement, a purchase agreement. Attorneys usually get involved in these things when things go sideways. And I cannot tell you, I think probably upward of 95% of the time, people say, something's gone bad with this investment, this group. And I'll say, well, give me your documents. I don't have them. I don't know. I never got them. I signed something. You gotta make sure you have the documents you sign and actually have a fully executed copy of them, and that you have evidence that you own the shares and that kind of stuff. The governance documents are also very important, because when you're an owner of something, there might be bylaws, there'll be an ownership agreement, just a ton of other things that you need to understand and that have ramifications for you personally. So those are definitely probably good to have an attorney sit down with you and say, this is what this means. This is what you're signing up for. Because again, you may be buying into a limited liability company and you have no authority. Now, maybe that's okay with you. Maybe you want a passive investment. As long as I'm getting money from it, I don't care who manages it, who has votes. I don't care. Okay, that is your prerogative. But if you're getting into an investment on any practice, any group, and you think, well, I'm going to be going to meetings, right? I'm going to have a vote. Not according to this. The shares you're buying are Class B shares, and you have no vote. Well, then you need to know that going in, or it'd be nice to know that. So understand there can get some very complicated documents associated with certain group practices, as well as any sort of investments on that. Major terms, major issues, the buy-in, what the terms are, how long you have to pay it back. Will the practice or the investment subsidize your buy-in? Control decision-making, I just addressed. Transferability of ownership. With any investment, can I sell this even if I wanted to, or is this contingent upon me practicing medicine? Or can my family own it? Can the profits, if something happens and I'm practicing with a group or have this investment and something tragic happens, will my family get paid for this investment? All of those things need to be worked out, and at what price? Because sometimes, again, physicians say, well, I paid $50,000 for the share, so when I sell, won't I get $50,000 back? Not necessarily. Sometimes there's provisions in there that say, well, if you sell under these circumstances, you get a very big discount and you won't get the money back that you paid in, or you're not guaranteed the money back. So understand all of those. How are they going to allocate expenses within the organization or the group? Especially, the group. Is it important that, well, I'm only going to be working 3 days a week, so I don't want to have to pay, if there's 4 members of the group, 25% of the expenses, because I'm not using the office 2 days a week. I'm not using the staff 2 days a week, and I'm only getting part-time revenue. So make sure the allocation of expenses and payments, and of course, it's always good on all these to consult, get an accountant involved too, if you're getting into these things, to make sure you're maximizing your taxes. Conflict can often arise in these situations on the income and allocation of expenses. Departing physicians, again, this is one that it is really good to know up front before things go sideways. Okay, if a doctor does want to leave or exit, how is that going to all shake out? And so that you're not scrambling around in what's already a very tense situation, and now you're having to negotiate. Well, okay, are you going to get a runoff of your AR? Because you know how a group works. AR comes in 3 to 6 months after they've already left. And does the agreement address that? Or are they just cut off on the day they left? The insurance, non-compete, medical records, all of that. And I represented groups where the doctor was just I don't want to be a part of this group anymore. I'm going to go across the hall, literally, and open another one and put a sign out the door. Okay, well, are you going to give him his medical records? Do you want to keep the patients? Do you have the capacity to keep the patients? All of those things should be discussed. Here's some others: the buyout, on-call responsibilities, outside income. If a doctor, okay, I'm in this group, but I have a medical device I'm working on, and that's not going to be shared with the group. Well, they may think, oh yeah, it is, because you're doing research here in our office with our staff. So when you develop the next great device, we are shared in that, right? All those things need to be, if you're really entrepreneurial and want to have outside things, you might need to discuss that again. Buy-in terms, those are, is it a formula? Is it a flat amount, lump sum, sweat equity, payout? What are the terms going in? What control issues? Will I get a vote? Will I get to be on the executive committee? What happens if I don't want to be a part of the group anymore? As we've said, valuation, again, they'll put in there that, okay, you're entitled to whatever the fair market value is at the time. Well, how is that computed? Or is it some other formula? Payment method, how are you going to pay, or how will you be paid by the group if you leave? All those are important. Income distribution, is it equally? Hey, the group has 5 members, we just take what's in a pot. That is hardly ever the case anymore, because again, it comes down to, well, I'm not going to share equally if I'm working 5 days a week and you're working 3 days a week. So it's usually some sort of production formula or a combination of the two. We've gone through this. This, though, is the situation. If you are a member of a group, you may have what you call within your group an employment agreement. But when you're an owner of the business and you leave, a covenant not to compete in that situation is enforceable. So you have to understand that too. If you have, and you're like, I'm mad at this group, I'm going to go out and I'm going to go across town. If you're selling the goodwill of the business, then a covenant not to compete can be enforced against you. So be cognizant of that. And I know I'm running out of time. Starting the buy-in too late. Again, if you've assumed that you're going to buy in, but you're already in the practice as an employee, you've lost a lot of your leverage there, unless you're willing to leave to get them to negotiate. This buy-ins, like I said, they've gotten really complicated. So this is definitely employment agreements. Maybe, it's not necessary unless if you're confident you do understand the terms. This, you get into a lot of issues that it is probably good to have someone look over these documents for you. Failing to negotiate at all, that's usually the most common thing I see is I was given this document, I signed it, there's a problem now, and I don't even know what I signed at that time. That's usually the most common mistakes. And then tax issues can be very important. Hospital physician integration models, I alluded to this. I think we're going to see more, and they're going to morph not just to employment, but accountable care organizations, PHOs. All of that is going to be significant about how in these new models will physicians get paid and what will be the criteria. And we need to start getting vigilant on that and really advocating for physicians to get a fair shake on those. And they're very complicated in these new models because there's a lot of federal laws that weigh on and dictate how a physician will be paid under these models. And it's not just you're free to come up with whatever works. There's all these rules regarding it. Contracting issues. The last thing I wanted to touch on is private equity. This doesn't probably, I mean, there's just a small amount of this going on in Oklahoma now, but there is some. And it's like anything else. Private equity has started on the East Coast and West Coast, but I know some specialty groups have sold to private equity. But just be very cognizant. I think it's good for the older physicians under this model to sell to a private equity. It is horrible for the younger ones. That's my opinion. They use fancy terms. They say, this is going to recapitalize your practice. And you need to understand that that basically means we're going to pay you a lump sum now, and the dollar signs go off, and it looks really good, but then they take a cut of your earnings going forward. Basically, you're going to pay yourself. So the older doctors who are ready to cash out and retire within a year or two of the transaction come out pretty good. But the people who are there and who are expected to stay for a long time after the transaction often don't come out as well. So just, again, understand that. And it is a sophisticated area where if you're approached and you're in a group or have an investment by private equity, I would definitely recommend, getting attorneys involved, because again, this is also a concept where sometimes the person pitching the idea of private equity is a broker. And so they're working for the deal, and they get a commission if the deal closes. They're not representing the doctors themselves, and they're not telling the doctors, here's the pros and cons, other than you'll get paid. And they will get paid if you sell your practice to them. So you need to understand that, that's their dynamic. And so they're not telling you how this will affect you 5-10 years down the road, the pros and cons, like an attorney representing you will. Also be very leery of attorneys who are attorneys, but they're acting as a broker in the deal. I think it's a huge conflict of interest, and they really absolutely should be disclosing it to you, but I don't think it's wise to even agree to allow an attorney be a broker in a deal. That's my 2 cents. So, any other questions on any of these concepts? Yes, sir.
We do have an online question.
Sure.
If Sooner Care becomes managed care, will the private insurance companies have to offer a contract to current Sooner Care providers?
No. There's actually a federal law, and that's been and again, I was just talking about this before I came. There is actually a federal law that says in this managed care concept, a Medicaid managed care, there's federal rules dictating how the states implement it. And one of those rules is you cannot require a managed care company to contract with all providers beyond their network adequacy standards. So what is going to be our network adequacy standard is not determined yet. It's a concept that's not determined, but it is clear from the federal regulations themselves that it is not simply an any willing provider situation, that anybody. Now, I don't think a lot of physicians should have too much fear, especially if you're in a rural area and there's a shortage. I mean, chances are in Oklahoma, if you are a licensed physician, duly licensed, practicing good medicine, no restrictions on your license, or you're not debarred from Medicare, you're going to get a contract because they need you for network adequacy. But it can't be mandated that they retain. So there's going to be some, okay, well, what's our adequacy standards and how many providers in this area do we need? Also, they have the provision that there was previously under all these managed care regs, there were distance requirements. They had to set some sort of distance. And there is in the RFP that was issued last year in the Oklahoma, there was distance requirements, but there's also a requirement that permits the managed care companies to request a waiver of those distance requirements, like the patient has to be within 30 or 45 miles of their primary care or whatever the distance requirement was. You can use a waiver if you can substitute in telehealth. So I could see, a lot of the managed care companies, telehealth has proliferated, during COVID. And so I would say that there's also that possibility as well, that instead of having a physical distance, a provider in a community, if they can't get somebody contracted, they'll defer to telehealth. Did that?
Any other questions? I have one for you, Cori. We kind of spoke about this a little bit. So the MCO that Medicaid's looking at right now, how for the employed physicians that are under contracts with hospital associations or physician organizations, if those organizations are being paid on a quality basis, how would you recommend physicians try to negotiate their contracts to be paid on that same type of quality basis rather than just a strict volume or RVU basis?
Yes, I think, and I don't have myself specifics, I'm still trying to get my head around it and feel like I'm a little bit behind the curve. I think that's where we need to put our focus as an attorney who works a lot for doctors, working with the medical associations, and then I would like to see the medical associations be more proactive and then go to the hospital association with, we want to advocate for these compensation formulas or these criteria within this system, because on one level, employed physicians are going to be, you could look at it that you're going to be somewhat sheltered, and you could just say, just leave it to the hospitals to figure out. They'll get the capitated payment, and and they just need to figure it out and pay. I think we lose an opportunity there in driving some of the discussion. And I think it would be maybe better or more empowering for physicians for us to collectively get together and say, look, these criteria are not you need to advocate for a model that empowers physicians more. Thank you all. Enjoy the rest of your meeting. I'll be around for a few. If you want to have questions that you don't want to ask in the group, feel free. Thank you very much.
There you go.
All right, thank you for your patience. We had just a slight change in schedule, and I'm pleased to introduce our next speaker. This is Dr. Clayborn. Our next speaker is Ashton Clayborn, DO. Dr. Clayborn is the program director of Choctaw Nation Family Medicine Residency in Talihina, Oklahoma. She's a graduate of Oklahoma State University College of Osteopathic Medicine and completed her family medicine training at Choctaw Nation. She is passionate about teaching, preventive medicine, and care for all ages, advocacy, and community involvement. Dr. Clayborn is also a member of the OOA's Board of Trustees. She lives in Kinta, Oklahoma with her husband and 4 children who enjoy raising cattle on their small farm, spending time on Lake Eufaula, and traveling around for various sporting events. Please help me welcome Dr. Clayborn.
Thank you. Good morning, and thank you all for having me. As he mentioned, little change in plans, no time like the present, so I'm glad to go ahead and speak. You all might have to be a little bit patient with me as I make it through these slides that I was going to review, but I put them together, so here we are. Today I'm going to be speaking about a practical approach to the pre-op evaluation. So this is actually something that has been taught to our residents in the past in a very similar way from an internal medicine doctor at Choctaw Nation, and we loved his approach. We liked that it was evidence-based and it was very stepwise and somewhat methodical. in a process that sometimes can be a little bit subjective. Oh, okay, go ahead, have surgery, I don't know. So his approach was great. I put it together into a teaching method that we can use with our residents, and hopefully it'll be something that you all find useful in your practice. I have no conflicts of interest. Objectives today are for us to understand the difference in the clearance of the surgical patient versus risk characterization and optimization of the patient, recognize common preoperative evaluation tools, and describe that standardized approach to a preoperative evaluation and apply that knowledge in a few patient cases. So we've all seen this. I'm primary care, family medicine. I know that many of you all in the room are, though we have other specialists here. And we get this, clear the patient. And so many times I'm going, okay, clear them. You just want me to be responsible? Is that how it goes? I know we feel that sometimes. And so it puts us in this situation where we go, okay, how do I actually do that? And I'm in a few groups, especially on social media, where I see other specialists talking, and the anesthesiologist says, yeah, only I clear the patient. So what do we do in family medicine? As my kids would say, nose goes. And in that situation, is the PCP the giraffe? Well, sometimes we might feel that way. It's not fair, but they're sent back to me and I need to handle this situation. So then what can we do? Do we just put our stamp of approval and say, okay, it's guaranteed, you can go ahead and go on for surgery? And I feel like I'm saying that nothing bad is going to happen. Not really, and we all know that. So in reality, it's more a risk-benefit consideration. We weigh those risks and benefits, we describe their risk or try to do our best job at doing that, and then determine based on evidence whether that patient should proceed on with surgery or whether additional testing is needed. So a big consideration in this is the type of surgery, and these are just official definitions of things that we already have in our minds as we consider what the patient is about to undergo. Emergent is obviously life or limb threatening, so that's considered to be a surgery that will be life or limb threatening if not performed in the next 6 hours. Urgent would be something that will threaten life or limb if it's not done within 6 to 24 hours. Something that's time sensitive would be a surgery that can be delayed up to 6 weeks without negatively affecting the patient. After that, it would be considered more urgent. And then elective is something that can be delayed up to a year without harm, or potentially forever if it's truly, truly elective. So this is the algorithm that you'll see many times throughout this presentation. It looks a little bit complex, but I'm here to simplify it, and hopefully it truly will simplify the process of a pre-op evaluation if you're not already using this process. So I know that it's really small on the screen, and there are certain things that I included in this presentation that are in the slides, particularly so that you all can go back and review them or click on the links if needed for your practice. So I will read some of this if it's difficult to see. So that first line up there says, patient scheduled for surgery with known or risk factors for coronary artery disease. And that's most of the time any of our patients. Is the surgery emergent? If so, yes, we just have to proceed with surgery. Is the patient having, and so if not, is the patient having acute coronary syndrome, in which case we jump over and deal with that. So we're going to kind of move past all of that today, and we're assuming we're in that situation where we're in a primary care office, and now we've been asked to do that thing, clear the patient. So the first step in this process in this method, and there are other risk assessment tools, and I've provided some links to some of those, but using this standardized approach, our first step is to estimate the perioperative risk of MACE, so major cardiac events, based on clinical and surgical risk. And the tool that we use for that is called the RCRI, the Revised Cardiac Risk Index. And so we'll move back through some of that algorithm. As I said, it'll come back up multiple times. But these are a few links to some of those evaluation tools. I'll have pictures of them and use of them here in these slides. But just in case you need them for future reference, the Revised Cardiac Risk Index is that first link. So there actually is a calculator for it if you'd like to use it, but it's pretty straightforward, and I'll explain that. The DOSI score, and we'll get to that in just a moment as well. The ACS risk calculator is another version, and it still is accepted in many forms. A lot of people still use it. It does help you stratify risk. It is a little bit more complex, and I think a little bit less objective, and it's a little bit, this is, in my mind, easier to move through, so this is the method that we've chosen to use in our practice. And then the ACP pre-operative cardiac risk assessment has been traditionally replaced by the above. So know that that is in existence and a lot of people still follow. But the method that we're going to use according to this algorithm and the NSCIP have actually replaced that for most practices. So back to the algorithm. Moving forward to RCRI, and let's see, there we go. Revised Cardiac Risk Index. So that's where we are with our patient. We've been asked to clear the patient, but truly we know now we're going to evaluate this patient, determine their risk, and then whether additional testing is needed. So Revised Cardiac Risk Index involves these questions. So prior TIA or CVA, that one's pretty straightforward. Diabetes, but it's specifically insulin-dependent diabetes. A serum creatinine, so they used to say CKD, but they've defined it with a serum creatinine greater than 2. History of coronary artery disease, which I've further defined according to some guidelines that fall into this risk index by history of MI, history of a positive stress test, current chest pain that is considered possibly due to myocardial ischemia, use of nitrates, or an EKG with pathological Q waves. So one question that commonly comes up, you're frequently expected just to get an EKG. Is an EKG used for screening purposes? So we've had that discussion in our practice and with our residents. Typically, you don't just get an EKG to screen in this setting, but so many times the patient comes with a set of orders, here, gather these things for me. So you either get it just simply because it's a battle that is not worth fighting that day, or you've got one on record and there are questionable findings and you review it and it does make you think twice about this situation. So that's how the EKG kind of falls into this process for now. Other things are high-risk surgery. And so there truly are definitions for what's considered high-risk surgery, but for this purpose, it's pretty simple. That includes only chest, abdominal, and suprainguinal vascular surgeries. So while there are many out there that we may feel, oh, that's high risk, according to this risk index calculator or calculation, only those surgeries are considered high risk. And a history of CHF, so that would be defined as pulmonary edema, bilateral RALS, or an S3 gallop on physical exam, paroxysmal nocturnal dyspnea, or a chest x-ray showing pulmonary vascular redistribution. When I think about that, we think about all those cases where you're also asked to get a chest x-ray. Again, like the EKG, it's not just done for screening purposes here and truly not indicated in many settings unless you already have that chest x-ray showing these findings and you think, okay, I believe that patient has a history of CHF and you want to further classify that. But this is supposed to be kind of quick and dirty, calculate these points. And so the way that that works then is you get 1 point for each of those things, and then what do those mean? So low risk is someone who has 0 to 1 point, so maybe a low risk surgery, but they do have a history of insulin-dependent diabetes. Okay, that person gets 1 point, and so on and so forth. Moderate risk is 2, high risk is greater than 3, but we'll simplify it even further than that as we move on here. So back to the algorithm and how that applies. Patient comes in, we do that risk calculation just as I mentioned, very simple. If that person has an RCRI of 1 or 0 or 1, so 0 or 1, that is it. Those are the only ones that fall into this low risk category. And given that low risk, the next step is proceed to surgery. No further testing is indicated based on evidence and what has been applied to this algorithm. So in that case, there are many times where we get that patient and they have an entire list of things that are being requested. Often our practice still just does those so that they're provided and we don't have to come back and get them later. But truly based on risk for surgical clearance, as they call it, but in our case, describing the risk of the patient and the benefit of moving on towards surgery, no further testing is indicated, and we can document that that patient is at low risk for surgery and can proceed without further testing. So what's next? The RCRI of 2+. Okay, just described that, so we'll move forward, proceed with surgery. Remember to optimize their chronic medical conditions if they're present, but hopefully that one's common sense at this point. So then back to that other category. And again, I said low risk, moderate risk, high risk, but this simplifies it. Low or elevated. So we just talked about low and what happens, but this is the patient who is considered to have elevated risk, so it's going to be both moderate and high. What do we do with that person? Now we're moving over to the other side of the algorithm that's still, again, looks complex, but is simpler than it appears. What do we do next, and how do we look at that patient further? While they're still sitting in our office that day, we then consider the Duke Activity Status Index, or we call it the DOSI, and we come up with a score for that patient. I'll come back to what those numbers mean in just a second, but I'm going to show you guys. That's what we were just talking about, the DOSI. And so it's a series of questions, and it's easiest just to have this printed out. In fact, we have one page, and maybe I'll get that to Audrey so that she can either make it available to participants or put it on the website. But we have both the RCRI and the DOSI on a single page document that we use for our pre-op evals. Should we need to use the DOSI, we look at the patient's answers to these questions, and the score for these is simply, can you do this without difficulty? And so we ask them to just be very honest. Are you able to do this without difficulty? If the answer is yes, then obviously they get credit for that question. The answer is no, they get nothing. And then you see METS values over to the side there. So those are values that are scored to that particular question. There's an online version of this on MD Calc that you can just click yes or no, and it will automatically calculate their METs. So that's metabolic equivalence, and that allows us to stratify their cardiac risk based upon essentially home stress testing, or the things that they're able to do at home without difficulty. So we have them fill out this questionnaire, and then we score and we determine their METs. So this person, again, greater than 2 points on the RCRI. Now what? I will go back to the algorithm, but it's simple. Equal to or greater than 4 METs can go ahead and, just like the other low risk person, proceed to surgery without further testing. There will always be individualized cases, or sometimes just that situation where you go, I don't know, this person's father had a heart attack at age 50. There's something not right here. That's why we're physicians and we can practice the art of medicine as well. But according to evidence and risk for complications here, that person who is moderate or elevated risk, but still has equal to or greater than 4 METs as calculated on the DOSI, can proceed to surgery without further testing indicated. If there are less than 4 METs or unknown, in our system, in order to get a stress test, you get a referral to cardiology. I realize that in most private practices, other employed practices and health systems, the primary care physician can order stress testing. So different than our practice. So in our case, that person then just moves on to cardiology to have their stress testing done. Sometimes we get in trouble for saying the real world because we're practicing in the real world, but in the outside world, that can look a little bit different. But in that case, that's that person that you would move on and consider stress testing for them, and then further workup as appropriate depending on the results of that stress test. So now the algorithm that looks even more complex, but hopefully actually appears very simple to you now based on what I've said. Calculate the DOSI. If greater than 4 METs, proceed to surgery. So that's that yellow arrow off to the side over there. And then if less than 4 METs, or it's just unknown, they can't answer those questions, they're unsure, you, for whatever reason, can't determine, then that person moves on. And so that's the big red arrow, cardiology or stress testing is indicated. So again, I say cardiology specifically because in our system, that's where they go. So then what do we say about that once we've made that determination? We don't ever in our practice say, I've cleared the patient, simply because we feel that that indicates or it causes us to take on a liability, and that's like that stamp earlier. I'm assuring that nothing is going to happen. I can never do that. No one can do that. So we say, according to the ACC AHA guidelines, which are what this algorithm is, for perioperative cardiovascular evaluation for non-cardiac surgery combined with a calculated risk for MACE, the patient and/or surgery is considered low risk. The patient may proceed to surgery without further testing or cardiovascular risk stratification. So that's our clearance. And if I ever get that form that says clear with a checkbox, I just actually write this out to the side of it, and it probably irritates a bunch of people, but that's what we do, and we feel that it's best for the patient. Of course, if not, then my statement in that note for that visit that day would just be the patient and/or surgery is considered to be of elevated risk and requires further cardiovascular risk stratification. Obviously, then we're moving forward with that process. I included a few slides before we get to some cases, just for some medication considerations. Again, I know that table off to the side is very tiny. It's there just so that you know that it exists, not so that I can read every little bit and expect you to from where you're at, because I can't see it either. But this is an algorithm from UpToDate on anticoagulants. So again, I included it not to cover it in detail because that's not the point of this talk, rather just so that you know it's out there, because the new anticoagulants can be a little bit more difficult to consider. So basically, if the patient is on a direct anticoagulant, what is the bleeding risk for the patient? And so then that table off to the right actually has information on specifically which surgeries and which patients are considered high, low, moderate, or minimal risk of bleeding. And so then there's information as far as what you do with those direct anticoagulants for that particular patient, given their bleeding risk. If they're on a vitamin K antagonist, what's the bleeding risk? And then what do we do with that patient? So again, the talk isn't to cover every bit of that, but just so that you know it's a pretty simple process. And I put that in here just more as a resource. As far as direct oral anticoagulant interruption goes, the intervals provided are for individuals with normal kidney function. And so that's also factor 10A inhibitors regardless of kidney function. So the timelines provided in that previous slide are for those patients. If their creatinine clearance is 30 to 50 and they're receiving dabigatran, longer intervals are used, and so that information is also provided here. Bridging, as we know, is not included for DOACs. And then if they're on a vitamin K antagonist, the following applies. So for warfarin, it's discontinued 5 days before the procedure. If bleeding is needed for a high-risk patient, we use low molecular weight heparin at a therapeutic dose approximately 3 days before surgery, and the last preoperative dose is going to be approximately 24 hours before surgery. So that's simple bridging for that. We resume warfarin post-operatively once hemostasis is assured, which in this case, I just thought, for teaching purposes, that typically is the evening of surgery or the day after. And then we resume low molecular weight heparin approximately 2 to 3 days after surgery as to be determined by the bleeding risk of the procedure, and discontinue it after stable warfarin anticoagulation. So again, standard bridging for the most part. The overlap, of course, depends on the patient's thromboembolic risk. So this information was just provided as an adjunct to the preoperative evaluation, simply because that's usually our next job. Optimize medical conditions, consider medications, with anticoagulants being the big one that most people care about when it comes to pre-op and perioperative situations. So this again is just kind of a resource or timeline for those patients. So high-risk procedure or no major bleeding, and the time frame for stopping those DOACs. So again, won't go over every bit of it, but that's what it's there for, just as a resource to look at. So the timing of stopping and resuming those medications can vary based upon high bleeding risk procedure or low bleeding risk procedure. So again, resource so that you're aware of it. And just a few other specific considerations, because this is one thing that actually is on the back of our handout when we do these pre-op evals. I told you we have the RCRI and the DOSI, and then on the back of the paper, just so that we don't have to look it up, if it's not in memory, are these common medications and basically when to hold them. Again, always individual considerations, but in general, Plavix 5 to 7 days, aspirin 7 to 10, estrogen 2 to 4 weeks, diuretics the day of surgery. They can still take their PO diabetes meds the day of surgery. If the patient is on steroids, greater than 10 milligrams, so this is who gets a stress dose of steroids. If the patient is taking a chronic dose of steroids defined by greater than 10 milligrams for greater than 3 weeks, we need to notify the surgeon, and that patient that will then receive 50 to 100 milligrams of hydrocortisone IV before surgery, and then they also receive 25 to 50 milligrams IV Q8 for 24 to 48 hours. That's something we probably have to look up every time if it's done, but just knowing that that exists, looking at that definition for when it's indicated, and also providing that communicating with the surgeon is going to be key there. Any anti-lipids except for statins need to be held just for surgery. Herbal supplements, it's recommended 1 week, as many of those can affect bleeding risk, and don't go through the FDA, so we don't have clear definitions on those. And then NSAIDs are typically held for 1 week, although guidelines are changing on that based upon surgeries too, so I didn't get into detail there. All right, so I have just a couple cases here to help apply this information and hopefully make it stick a little bit better. So we have an 82-year-old male with a history of non-insulin dependent diabetes. The patient reports they have a history of CKD, although they're just kind of unsure of staging or anything like that. They have hypertension, and he says he's here, I'm here for pre-op clearance today. I'm gonna have some cataracts. I'm gonna have cataracts surgery done, and my doctor said to come over for clearance. He's been asked to provide a chest x-ray, an EKG, a CBC, and a CMP. And sometimes we get an even longer list in our clinic. So as I mentioned before, sometimes when those things are requested, I don't fight that battle. I order them so that they have what they need and it doesn't delay their surgery. But as we'll find out here, not indicated in terms of, this is a frequent board question, so not indicated in terms of the boards, not indicated in terms of risk stratification. But this patient was last seen last month for a primary care visit, and fortunately we did some labs that day in managing his chronic care. And so the CBC at that time was within normal limits, and the CMP showed this. And so because you all saw the RCRI earlier, you know that really the only thing pertinent on this is going to be, other than chronic conditions that significantly affect the patient's, or comorbidities that affect the patient care, the one that matters for pre-op risk assessment is the creatinine. So this patient has a creatinine of 1.0. So how does the patient fall? We'll work back down this. I might have a laser pointer. Nope. Okay. So jumping down on the left-hand side of the screen, moving forward, because this is non-emergent surgery, the patient is not having acute coronary syndrome. We don't want to deal with that in the office today. What is a patient's estimated perioperative risk of MACE based upon the RCRI? So in this case, using the RCRI, let me go back. The patient's risk is 0. The patient has low risk. I'm going to see if I can, there we go. So the patient does not have a history of prior TIA or CVA. Patient does have diabetes, but is non-insulin dependent, so no point there. Serum creatinine was 1, no point there. No history of coronary artery disease, and it's considered a low-risk surgery. So we'll go back. Patient's RCRI is 0, so then now we're moving down to that orange block, low risk, no further testing indicated. So simple as that for that patient. And hopefully that just kind of allows us to follow through this process on something that is a little more real. Again, don't ever forget, confirm optical medical management of those chronic conditions. So I didn't report what that patient's A1C was, but it's always important to consider, wow, in our patients, I work for Choctaw Nation, so an average A1C seems to be higher than what it might be in the outside world. In private practice, going through school and residency, would hear about a 9 and go, wow, that's great. Not so much, but in our system, our scale for what's considered controlled diabetes or severe diabetes is probably skewed a little bit. So take care of the patient as you would anytime managing those chronic medical conditions, but try to optimize them the best we can before surgery. But in this case, patient's low risk, can proceed to surgery, no further testing indicated. All right, one more. This is a 54-year-old male with a history of insulin-dependent diabetes, hypertension, hyperlipidemia, and he presents for a preoperative evaluation with plans to undergo a colon resection for a mass recently found because we were astute clinicians and asked that patient to undergo a screening colonoscopy. Thank goodness it was caught. So this patient's RCRI, prior TIA or CVA, no. Diabetes requiring insulin therapy. I'm going to jump back. The patient did have insulin-dependent diabetes, so we've got 1 point there. Serum creatinine of greater than 2, so that was not in that slide, but in this case, we're going to say that it's no. In some cases, you can see you might actually need to collect labs on that patient. This is an insulin-dependent diabetic, so it may actually be indicated if it wasn't time already to check that serum creatinine. You can't know if it's not checked. We did not get a reported history of coronary artery disease, and there's none in the record, and there's nothing that we know of, so no point there. But is it a high-risk surgery? In this case, it's a colon resection, it's abdominal, so, and you may need to clarify sometimes, tell me a little bit more about the surgery, and that could be from the patient or the surgeon. is this going to be, how are they going to approach this? Because we know that there are different methods to doing that surgery, but in this case, it's an abdominal colon resection. So 2 points, insulin-dependent diabetes, high-risk surgery, abdominal surgery. So this patient is not 0 or 1, so they are considered elevated risk. So here we are back to the algorithm. That middle section, what's the estimated perioperative risk of MACE? It's not 0 or 1, so now we move over. It's anything greater than 1 is elevated risk. Now, the next step, we move on to the DOSI, and here we are. So I put a few examples in here. These are the patient's answers. You can see, so can take care of self, which includes eating, dressing, bathing, using the toilet, can walk indoors around the house, cannot run a short distance, gets really, really winded, and I'm not sure about chest pain, but it's tough. I'm not gonna say yes to that. Climbing a flight of stairs is really tough. Don't feel comfortable saying we can do that without difficulty. Of course, they can have sexual relations. They don't want to admit that that's a problem, but doing yard work, raking leaves, yep, we can do that, but heavy work around the house, like scrubbing floors, lifting, or moving heavy furniture, that one's really tough. So pretty realistic answers here in calculating the METs for this patient. And so there we go. So if you look at that, and I actually used the calculator when I did it, but again, there's a calculator online, so that link is in the front of these slides. If you choose to use that, it's available. It will just yes, no, and it'll calculate the METs for you right there. So it's kind of nice to just have these on your home screen if you're using a computer. It'll calculate them for you. If not, you can quickly add those up based upon the patient's answers. So according to the DOSI, this patient gets 7.4 METs. So on the algorithm, what's next? Equal to or greater than 4. Patient can move on to surgery without further testing indicated. So this is a patient that you would have otherwise looked at and probably gone, okay, insulin-dependent diabetic, we're having a major surgery. I don't know, do they need to see a cardiologist? And some people have their own methods for this, and maybe this is old information to you, but we just really love this strategic approach that provides us an objective way to handle this. So again, confirm optimal medical management and then proceed to surgery. I gave one more example here of a change in the answers to that question, just so you can see how this case would go differently if the answers to those questions change. So in this case, the patient says, yeah, I can take care of myself, I can walk around my house without problems, I can still have sexual relations, but everything else is tough. I get short of breath, I sometimes have chest pain, I don't know if it relates to that or not, but we can't clearly say, yes, I can do any of these things without difficulty. So in this case, the METs are only 2.8. So this is a patient that we're now concerned about, and they need to undergo further cardiac risk stratification. So that's when we hear those words, cardiac clearance. And again, cardiologists probably don't like to say those words either, but further cardiac risk stratification. And it's indicated for this patient, whether that is us proceeding to order a cardiac stress test or that patient gets a referral to cardiology, and that'll just be dependent upon where you're practicing. So that's it. Hopefully that simplifies things for you all and provides you a useful tool or useful method that you can use to navigate these visits in your practice. If you've got your own way, share, please. We're always happy to learn, but I'll also take any questions if you all have them. Sure. 2 hands. I'll start over here.
Kind of assumes, it assumes the ability to have the ability to walk. And so I was wondering what you do for patients who have to use a wheelchair, but maybe have good cardiovascular health that's not related to that. And then for children, when we're not as worried about like coronary artery disease specifically, but might have like congenital heart disease or bronchopulmonary dysplasia, those things, if there's tools for that.
Sure. I didn't specifically research those situations for pediatrics, so I'm not going to try to give you an answer that's made up and say that it exists because I didn't specifically dive into that for this purpose. So having said that, if we have, and we don't have too many of those kids with those issues in our practice, we want more. If you want to, anyone who would like to send us some children, we would love to take care of more kids. But right now, our pediatric population is actually pretty low in our clinical practice. So I didn't address that here. Having said that, in our practice, we would probably, if they have issues that are that complicated, they often already have a cardiologist on board, and of course, we'd just be phoning a friend. But for the DOSI, the way that algorithm works, and so again, we use our brains, it's case by case, but many times if our patient is in a wheelchair, we have to also think about why they're in a wheelchair. So, is it simply a mechanical injury, in which case I'm less worried about their cardiac condition, although they're probably also not getting a lot of cardio exercise, and so then even still, I might think their risk might be elevated. So truly, we do have to kind of, weigh it in our minds there and go, okay, why is this person immobile? Does that affect their cardiac risk? In which case, I would just say the answer to their DOSI score is unknown, truly, which means that we do move forward with cardiac testing. We're always going to err on the side of caution. So I do feel like this method makes it pretty simple, and it helps us quickly stratify those that don't need additional testing. But in any case, when we're unsure, err on the side of caution, that patient moves on for additional risk stratification. So again, that's going to be mostly adults. I realize with kids that's even harder, and you don't just send a kid for a stress test. But for those adults, that's a great question. What if we're unsure about the answers to those questions or truly can't determine? Our only option in this case is to say it's unknown, therefore we have to move forward with additional testing. Yes?
So in my job, I do frailty assessments for pre-op clearance. And I'm just wondering whether you do any in your practice for frailty prior to surgery, which can, if they are frail, and I use the DASI as in the modified breed frailty assessment. So do you do any frailty assessment? Because that can certainly give you an idea whether they're going to be more difficult to extubate. They may stay in the ICU longer. They may have a longer length of stay in the hospital setting. And it does increase the likelihood of morbidity and mortality depending on the surgery. So DASI is wonderful, but I was just wondering whether in your practice you use that.
Yes. So yes, depending upon the patient, and certainly I think most of us can subjectively look at a patient and know that it's probably more indicated to address those things on that patient, although not always, and that's exactly what those tools are for. So yes, we do, and yes, we do sometimes for other reasons totally outside of the perioperative eval. For these purposes, specifically speaking of quick version, how can we risk stratify? Does this patient need that? Moving on to the cardiac clearance side of things, I stuck with this method, but absolutely, and thank you for bringing that up because the frailty assessment can be valid. Here we're specifically talking about MACE, but as you said, there are things other than MACE that can be important. So that's a great point from an overall primary care standpoint. Thank you. Yes?
In our practice, the big thing that most people are asking is if they're diabetic. The thing they're asking, if they're diabetic, are they over a 7 A1C? And most of the ortho guys are turning them down if they're not under 7 or below.
Correct, yes. And again, I address mostly the cardiac pre-op risk here, but at the same time, I witnessed that many times rotating with them as a resident. I still see it in practice. We get that same situation. And so in that case, it does come back to urgency of the surgery. And then truly, if it can be delayed, we're right back to that second point, which was no matter where we fall on the risk stratification, if the medical conditions are not optimally managed, then either you or the specialist performing the surgery may say, okay, your cardiac risk is this. We don't need that additional testing because we've done this pre-op eval, but absolutely it's still not time for surgery just yet because I haven't optimized your medical condition. Yeah, thank you for that, good point. Anything else? All right, thank you.
Ready? Bree, you ready? Okay. Good afternoon. It's good to see you guys. What I can see of you, I've got these lights are pretty bright up here. I feel like I'm getting grilled by the police here. I'm Dr. Dennis Blankenship, the interim dean of the OSU College of Osteopathic Medicine. Glad to be here. I'm also a 2001 graduate of the college. I know many of you guys have seen you around the campus and through the community for years. One of the biggest things that I think kind of a great talking point for us today is about our 50th anniversary. As you all know, it's the College of Osteopathic Medicine's 50th anniversary this year. The college was established as Oklahoma College of Osteopathic Medicine and Surgery in 1972. Its mission then was to place physicians in rural and underserved Oklahoma, and that mission remains today, despite the name change to OSU College of Osteopathic Medicine. I think the number is 3,782 osteopathic physicians that have graduated from that institution since 1972. So we're really proud of our 50th anniversary coming up. We've got some events planned that I'd like to tell you guys about and invite you to be at. If you've been around the campus in the past year, you've seen there's a lot of construction going on. It's loud, and it's dusty and messy, but to good end. The North Hall, which will be the new administrative building, will house our anatomy, also house the medical examiner, and several classrooms, a lot of office space. That's set to be completed on July 28th. We are having a celebration to celebrate the grand opening, the ribbon cutting of that building, but also will serve as our 50th anniversary celebration. So we'd love to have you all there and help us celebrate that moment, that great moment. At that anniversary, there will be an opportunity. There's an opportunity that we've been trying to tell everyone about, to kind of leave your mark with a legacy brick paver. Have your name or someone in memory of someone to go on a brick that will go there in front of the new building. There are 4 different options to choose from, and Bria can give you more information on that if at the OSU Medicine booth if you guys have questions or would like to contribute to that cause. Some other upcoming events coming up very soon. Our Spring Fling CME event is coming up from May 16th through the 27th, 15 AOA category, 1A credits. And then Saturday on Saturday, June 4th, we're also having an alumni reception in Durant at the Choctaw Hotel Casino. So it'll be a good time if you can make it to that. Again, Bria can give more information on that at our booth. Besides the growth, you guys, the other growth at the medical school, the Barson building, which most of you know as one of the main buildings there on campus, is being renovated. Currently, they're replacing windows, redoing the exterior of that building. Once all the occupants of that building move over to North Hall, then they'll start doing some deeper construction. But there will be a great change in the look of that building, kind of to match the campus. So that's another part of construction you'll see there on our campus. In addition to the growth at CHS, there's a lot going on across the street in the new hospital district there. Many of you know OSU Medical Center and the Houston Medical Office building in that area will be the new home of our Veterans Hospital in Tulsa. Just north of the medical center at the old Kerr Edmondson building, we're building the new VA. So that's going to be a 275,000 square foot facility. It will have 58 inpatient VA beds, scheduled to open in 2024. In addition to that, a new state-of-the-art mental health hospital that's going to be operated by the Oklahoma Department of Mental Health is set to open also in that area. That will double the size of our psychiatric beds there, from in the 50s to over 100 beds. So we're looking forward to that coming online in 2024 as well. That's going to be a 150,000 square foot building. Along with that, the city has helped us build a parking garage on that facility as well, that will serve the mental health hospital as well as the new VA, and also the city will use it for events downtown. So really excited. Those are kind of the first efforts we have there in our new academic medical district. If you've ever seen the long-term plans for that area, a lot of innovation sites, research areas, a lot of room for growth down there, and we're real proud to get these first 2 projects started get them completed. We think they're going to have great impact on Northeast Oklahoma, the state, our veterans. Over 40,000 veterans in Northeast Oklahoma will use that facility. So it will add to the other Tulsa offerings that they've had with their new South campus. So both of those facilities, the mental health hospital and the VA, will utilize OSU residents, physicians. We've done a lot of joint hiring with the VA, partnering on hiring of faculty members. The hope is to grow our offering of residency slots there on that campus from roughly 200 to over 300 spots, with both mental health, behavioral health spots, as well as primary care and specialty care. So we hope to really grow the residency programs with those two offerings. So it's a real exciting time. I'll give you guys a few of the things we're proud of at the COM going on right now. One of the things that we're measured on nationally when we look at our osteopathic med school peers is board pass rates, first-time board pass rates for level 1 and level 2 boards. We've had some lean years where we struggled. We've kind of been just at the mean, just below the mean for the past couple of years. We instituted a lot of changes, both curricular changes and just identifying learners that were struggling. And with that program this past year, we went, our first-time board pass rate jumped to 97%. And to give you kind of an idea, we had been kind of in the low 90s for the past few years. The national average is about 93%, so we're well ahead of the national mean. And our average board score compared to the nation was about 20 points higher. So some of the things we've been able to institute to kind of get through some of the problems we had in our curriculum and just kind of improve those metrics on both level 1 and level 2 boards, we're really proud of. The other big metric is match rates. How are our graduates doing as far as matching to GME spots? And that number has always been really good for us compared to other osteopathic schools across the country. Just with a hospital, with the rural medicine programs we have around the state, we've always done really well at that. And again, this year we were at 100%. Half of those students went into primary care specialties. So again, vision-driven, mission-driven as far as providing primary care physicians for rural and underserved Oklahoma. So we're real proud of those numbers with our board pass rates and now with our match rates as well. That's really all I have. I planned on kind of opening up, take a few questions, and hoping that I could answer them for you.
Have you made any more changes to the academics? Because the students I've seen really had a tough time with this, taking a 1 month class and then supposed to remember that stuff 2 years later, and they got away from the systems and it's spiraling. Step up, as I call it, education, starting at the bottom of the basics and then spiraling that up, leaving the systems, everything within the systems, whether it be pharmacology, whether it be anatomy, whether it be physiology, whether it be whatever it is, that they could build on instead of having pulmonologists come in and talk about thromboembolism in the lung to a first-year student who's not going to hear anything else about it for years.
Right. Yeah, we have revised our curriculum. One of the things that I think is the toughest thing about level 1 boards that we've seen is you get a lot of the basic biomedical foundations early on, and then when you look at, after your second year taking boards, you're a year and a half removed from a lot of that information. That's probably the toughest part about level 1 boards is, it's just has so much biomedical foundations in it. And by the time they've taken it, they've really started into our systems in the second year. And we do implement all of the foundations throughout the systems, but it still is tough. We have seen, I think that's a big part of our improvement lately, is that we try to carry a lot of that stuff over. And keep it closer to when they take their boards. I think the best thing we've done over the past couple of years is just the frequent assessment before they sit for their boards and kind of identifying weaknesses, whether it be if they've had trouble with different classes, where their class rank is, how they do on the practice board exams. We kind of put them in different categories, and we know some of those that are struggling, we're able to identify and get them specialized help. We have a department of student success, and so you get individual work with an instructor to kind of help you with board-based questions and kind of prepare you for that level. So yeah, we're always kind of evaluating the curriculum and kind of evolving if we see areas that we're having trouble with. Yes, sir. Yeah, the Tahlequah campus, obviously this is our second year on that campus. So we've got 2 groups there now, about 50 students in each class, 50 to 54 students. What we've done there is just kind of recreate the entire campus from the Tulsa campus. Everything that we offer in Tulsa, we offer at the Cherokee Nation. Most of the lectures are streamed from one location or the other. For instance, if someone's given a pulmonology lecture on the Cherokee Nation campus, that is streamed to our students live on the Tulsa campus and vice versa. Our goal is that we have that at as close to a 50-50 split as we can. And we have a ton of faculty that are based out of that campus in OMM and the basic sciences and clinical faculty. But thus far, it's been really good. If you look at the metrics between the 2 places, as far as how they rank in the class, how they perform on our testing, it's been really good and very consistent. We deal with a few issues that are just distance related, when we have things that we can only offer one place or the other. But it's been great, and we've had great support from the community. Most of the students at that location are from rural areas, want to return to rural areas. So it really fits our mission as far as providing primary care for Oklahoma. All right, well, thank you guys. Happy to visit with you throughout the rest of the program, and if there are any questions that I can answer, I'd love to visit. Thank you, guys.
All right, welcome back, everyone. We're going to go ahead and get our afternoon started here. At this time, we'd like to welcome to the stage Dr. Jerry Childs, DO. He was born and raised in Oklahoma. He graduated Berry Hill High School in 1973, Oklahoma University in 1978, and the OSU College of Osteopathic Medicine in 1981. He performed a rotating internship at Chicago Osteopathic Hospital and started practice of emergency medicine in 1982. Board certified in 1988 in emergency medicine, Dr. Childs practiced emergency medicine for 30 years, then took the position of medical director at the Oklahoma County Jail. He has been involved in correctional medicine for the last 10 years. Now semi-retired, he and his wife Nancy hope to do much traveling and spend time with their 7 grandchildren. He continues to go on medical mission trips, working with the Samaritan's Purse Medical Missions. He is active in a faith-based 12-step recovery program. Dr. Childs is currently testing out the theory that one can only play so much golf. So please help me in welcoming Dr. Childs.
Well, thank you, guys. Wonder who she was talking about. Firstly, I want to apologize. I was at home at about 10:30 working on this presentation. 11 o'clock came and I got a phone call from someone based in Honolulu, Hawaii. And the voicemail, normally I'm sure like you guys, I'm like, I don't know anybody there. But for some reason I pushed on it and listened to the voicemail, and Ms. Hendricks was telling me, Dr. Childs, where are you? I was thinking I was Friday. And so I need to thank Dr. Clayborn for stepping in for me so I could switch wherever you are. Thank you for that. Then my wife said, people that are in recovery or impaired physicians or impaired people often miss their appointments. And fortunately, I'm far enough into my recovery that I can joke about it, but I promise my drug screen would be negative right now. So with that being said, I have some slides I want to show later on, but first I just want to give you a glimpse of what happened in my life several years ago. It's May 9th, 2006, and I've walked into my office after bringing my oldest daughter home from college for the summer. I found this card on my desk and knew instantly that my life was going to get very interesting. It says, Mary Surovec, Diversion Investigator, Drug Enforcement Administration, United States Department of Justice. My wife said that the agent had been to our house and wanted me to call her. I called and she said she would be at my house the next day. I knew instantly I was busted. It was over. I grew up in a loving home with two parents who raised me and my two younger siblings to be responsible, respected adults. I had a very enjoyable childhood. We had everything we needed and some things we just wanted. Once it became clear I was a short guy who could not hit a curveball or run fast, and professional sports were not my future, the only other thing I wanted was to be a doctor when I grew up. Though they all died before I was born, my grandfather and his brother were doctors, and my great-grandfather and his brother were doctors. My uncle was a doctor. My younger brother, who is alive, is also a doctor. He's a cardiologist in Tulsa. Some of you may know him, Darwin. But my grandfather, the physician, died of a morphine overdose. I can recall my dad saying one time his dad gave him a prescription for morphine and said, get on your bike and don't come back until you get this filled. This was in the 1940s in Tulsa. I guess he was able to get that done. My maternal grandmother died in a drunken stupor. So perhaps I have a little bit of a genetic predisposition to addiction. I wasn't the smartest guy, but I worked very hard to make good grades that could get me into medical school. And despite attending a very small rural school in Berry Hill, Oklahoma, which is strangely enough about 10 minutes from the OSU campus, really interesting. Although I was probably the very last person, this is a different story, accepted to my medical school class, my lifelong dream of becoming a doctor was really going to come true. In college and medical school, I seldom, if ever, drank. I never used illegal drugs. I was not one who I wouldn't call me the party type. Some of you, my age, remember in those days there was still some lack of knowledge or outright discrimination towards DOs, and I was just a regular guy trying to be the best osteopathic physician I could be. I was just a normal, regular guy, a happy marriage, happy kids, stable lifestyle, just a regular guy. I started my practice of emergency medicine in the early 80s when emergency medicine as a specialty was still very new. I began my practice in a small hospital in Guthrie, but soon realized I needed more experience if I was going to get board certified via the practice track or grandfathered that you could do back in those days after 5 years of practice. I therefore moved to Muskogee, which had much trauma and high acuity before the days of transferring major cases to Tulsa or Oklahoma City. I recall many times the ambulance calling in after 1 a.m. when there was just one doctor on duty saying we have 4 from an MVA and 2 or 3 are critical and I would have to manage them alone. I later spent about 10 years at Presbyterian Hospital here in Oklahoma City and 12 more years at Baptist Hospital as well. In the 90s, several popular television shows glamorized the specialty. My career blossomed, and in 2006, I was highly successful in my practice and was ready to take care of anything that came through the door. I was the man. I had no fear. I was indestructible. I was bulletproof. If you go to Proverbs chapter 16, verse 18, pride goes before destruction and a haughty spirit before the fall. I started running for exercise in the 1990s and decided I wanted to qualify for the Boston Marathon. You know, we're all type A's, so I set my goal, and I was the man, and I met my goal. But while I was training for the Boston Marathon, I had several aches and pains, and I was working nights in the ER. And believe it or not, I had received some Lortab samples in the mail. This came with a little card saying, "Do you want more?" And I thought, well, may need them someday if one of my kids ever breaks a leg or I break a leg. So I kept ordering them, and I saved them if they were forever needed. And then one day I decided to see how they would work on me. They were magic. My runs went better. I was working nights and they were a breeze, and it was not long before I was hooked. I was involved in the early development of my church's foreign mission work. I led multiple mission trips to Haiti, Honduras, Nicaragua, Mexico, Belize, and Romania, and other countries. And I always carried my supply of Lortab across the border. And I can only imagine what might have happened if I, the leader representing my church, had been caught with my drugs. If you've ever seen those episodes of Locked Up Abroad, that's what I think about. It could have been very, very ugly. I was ordering Lortab from a pharmaceutical company on the internet under my own name. Click a button, and it would be there pretty much the next day, and it wasn't even expensive. I never sold any or wrote prescriptions for others or shared it. I remember many times seeing a patient in the ER wanting pain medication for one thing or another. I might refuse them and advise them I thought they had a problem with narcotic pain medication. And then I would go to the doctor's lounge and take 1 or 2 Lortab and not give it another thought. I never took more than what was prescribed. This is an addictions and addicts thinking. I didn't want the Tylenol to damage my liver. I wasn't worried about the hydrocodone. It was the acetaminophen that was going to kill me. The hydrocodone, I believe I was never impaired. I believe I was never impaired, but I know, and we know, as medical professionals, we are held to a higher standard. I know it now, and I knew it then. It was wrong. I just ignored my conscience. So May 10th, 2006, the DEA is coming to my home. And some other things, I can laugh about this now. It's been long enough I can laugh about it. It's never good when an agency with 3 letters in the acronym come to your house. The IRS, the DEA, the OBN, the DOJ. It's rarely a good thing. I had to tell my wife why they were coming. She had no idea. No one knew except me and God, till now. She had found pills in my scrubs from time to time, and I told they were Tylenol left over from work. And I'd never lied to her before, so she believed me. The company I'd been ordering the Lortab from had turned my name into the DEA. I got little sleep the night before. Was I going to be arrested, handcuffed, taken downtown, fingerprinted, mugshots? I prayed to God to give me a story the DEA would believe to get me off the hook. I prayed to God to give me a lie. Fortunately, about 3 a.m., I came to my senses and decided I just had to tell the truth. When Agent Surovac arrived, she asked me where all the Lortab I had been ordering was going, and she probably already knew. And I told them it was all for me. I had to give up my DEA certificate to prescribe and my medical license. And sometimes I still cry over this. As I handed it over, I realized I was losing everything I had worked for, and it was all my fault. This is the part where I cry sometimes. I had to tell my partners at the hospital. I had to tell my friends. I had to tell the people in my church. And hardest of all, I had to tell my children that their dad was a drug addict. My son was already out on his own, but I had one daughter getting married soon, one daughter starting to college, and one starting to high school. How was I going to take care of them? I was told I had to go to drug treatment for medical professionals to have any chance to get my license back. There were no promises, just do this and we'll see. Meanwhile, the withdrawal started. It was miserable. I couldn't sleep, I couldn't eat. It was just horrible. And the look on my wife's face as I struggled through the withdrawals was just so painful to see. I was so afraid and so ashamed and so desperate. I spent 3 months in drug rehab treatment. Previously, I did not know about buprenorphine, which we all pretty much are aware of now. I was given a prescription of that to help with the withdrawals, but I was determined to get completely clean. And after about a month and 3 sleepless nights, the withdrawals finally went away. The most important thing I learned in rehab, because I'd already convinced myself I was done, and some people believed that, some people didn't, but my situation was not as bad as some others. These are all physicians. While there, one of my roommates was fired from his practice. One agitatedly walked around our apartment in a blackout, completely unaware of his actions. One had felony charges placed against him. On Family Week, I witnessed a family completely break up due to the physician and mother continue to deny that she had a problem. And another guy received a divorce notice while he was there. My family, my employer at Baptist Hospital, stood with me when they could have fired me immediately due to the loss of my DEA license. My partner supported me, my friends all stood with me during this time. Upon return from rehab, I was initially told by the OBN, those 3 letters, it would be 2 years before I could get my certificate back, which obviously meant I wasn't going to be working in the ER. Somehow, after meeting with them, they made an exception. And I talked with them, and somehow they made an exception. I had to pay a $14,000 fine, and they wanted to do some more investigation of my addiction and the hospital and things. And after 3 more months, I was able to return to work at the same position I had previously. I think my decision to be completely as honest as I could and did what I was told, which we'll talk about here in a bit, helped much. I can't express how thankful I am to my partners and to my employer that they took me back. I still had to have random drug tests for 5 years, and I can remember every time going into that bathroom and thinking, how did I get myself here? How did this happen? I had to attend recovery meetings every Monday for medical professionals for 5 years. And needless to say, I had pretty large credit card debt. I wasn't working. And ironically, it took 5 years to pay that off. But I am completely restored. At one time, I had 0 state medical licenses. Now, through a series of business deals that just sort of fell in my lap, I have 23 licenses, 23 different states. And I don't have 2 now, but for a while I had 2 DEA certificates. I have almost 16 years of sobriety. Coming in May, it'll be 16 years. So, when the DEA calls, life, needless to say, gets very interesting. And my life got very interesting. This is a picture of the card I carry around in my pocket, in my billfold at all times. Every time I open my billfold, I see that card. You can see it's pretty worn. That's 15 years old, but it reminds me of where I've been and what I need to stay away from. Agent Sorovac was very gracious to me. I just can't say how easily she treated me. We all know that there's an opioid epidemic. We all know that. As I was introduced, I spent 5 years as the medical director of the Oklahoma County Jail. And just one thing I want to say, whatever you read in the paper about the Oklahoma County Jail is a lie. It's actually worse than that. It's a bad place. But there were so many young men, young ladies that would come in addicted to some narcotic, some opioid. And I would ask them how that happened. And they would say they had an injury, they had a back injury, back pain, whatever, and they were prescribed narcotic pain medication. They kept getting it refilled, and finally, and this is a lesson to all of us, finally their doctor said, that's it. And they were hooked. So they went to the street and started buying off the street. And because of that, not because they were a bad person, not because they wanted to be a criminal, because they were hooked. They got arrested for possession of narcotics and were in the county jail. So it's a lesson to us. And I understand that, I know the rules have changed and it's harder to do that now as physicians, but it's still something we need to think about. So I want to talk about the history of an impaired physician. Physician burnout is often a reason that doctors start looking for some sort of relief. My story, I was well into recovery, and I practiced emergency medicine for 30 years. The first 28 years, fine. Everything was good. I handled everything, no problems, and nothing changed, but the last 2 years, I was absolutely miserable. I was completely burned out. I tell my friends, if I had 7 days off from work, on the second day of those 7s, I was dreading going back to the ER. It was just horrible. And because of that, I left emergency medicine and then went into the county jail, which basically I went from one circus to the other, but at least there were no nights, no weekends, no holidays anymore. When I had something really bad, I could send it somewhere, send it away from me rather than have to try to figure out what to do with them. There's a lot of family stressors that can bring on looking for relief. Some of the literature I've read is, and this, it makes sense, physicians tend to keep their practice, their public life fairly well under control when they have a substance issue. But at home, things are beginning to get really ugly. And by the time things fall apart, their house, their family situation is in shambles. So just because on the surface things look good doesn't mean they are. And some of the other papers I've reviewed is the 4 specialties that seem to have the most difficulty with this is anesthesia. They're dealing with controlled substances every day, and they have a big issue. Emergency medicine, I have to raise my hand. They couldn't decide whether it was the risk of the specialty or because of the person's personality into the specialty that led them to be more likely to have an addiction issue. Psychiatry and family practice as well. The study also said that a lot of physicians think it's okay to self-prescribe. You have some sort of infection or something, you give yourself an antibiotic. You have a pain issue and you think it's okay to treat your own pain, and that can get out of hand. Recreational use is not in my studies, is not as big as an issue as just trying to get relief from the stress. And then another one that fits my case is after I had taken Lortab or hydrocodone for a while, then I just took it to avoid the withdrawals. I can remember many nights waking up at 3 or 4 a.m. and get up and take Lortab so I could go back to sleep. It's not an easy thing. One of the biggest things that's going to keep me from relapsing is I don't ever want to go through withdrawals ever again. We have a lot of access. You know, we have a prescription pad. Well, it's electronic now, I guess, but we have access. We have, you know, like I said, I had samples sent to me in the mail. And I know that probably doesn't happen anymore, but we have access. We have patients that have access. You know, that before you know it, you're asking your patient to share with you, or, you know, and then you get into that situation. And then there is a conspiracy of silence sometimes. You have a doctor in a group practice and you need his body there, and you know there's probably an issue, but you don't want to confront it. And you think, well, maybe it'll get better, maybe it'll go away, maybe it'll improve. And then a lot of us say, well, alcohol is legal, so that can't be a problem. You know, I don't have a problem. Alcohol is legal. I'm not doing anything illegal. So the signs of impaired physician there's a list here. Withdrawal from social settings, just sort of hibernating, and COVID brought a lot of that even worse. I've spoken with the director for OHP in Eastern Oklahoma, and he said COVID has that now that people are getting back out. They're learning that a lot of physicians were having trouble coping with being isolated. Decreased work performance, obviously. Frequent absences or showing up late for your presentation can be one of those signs of impaired physician. Disruptive behavior, just not acting right. Excessive sweating. I can recall this was in the 90s when I was at Presbyterian Hospital. This attending physician that I well respected, he's a very strong clinician. He came to the ER to do an H&P, and he was just sweating like crazy. And I looked at him and thought, what is, at the time I had no idea. And later on, I read about him, and he had an issue with alcohol. And so that's something you can look for. And obviously, patients and staff start complaining. You don't show up on time. You're late for your patient's appointment. You yell at the patient. Those things, and mood alterations. I think I'll mention later. A lot of people with issues with substance have mental health issues as well, depression, anxiety, or whatever. And then I wrote in my notes, or not. I didn't have any of those that I am aware of. Everybody that I told about my addiction when I was getting ready to go to treatment said, really? Really? You? The nurses loved me, the doctors loved me, the attendings loved me, the administration loved me, but somehow I was able to put on a face that got me through. And as I mentioned, a lot of times, professionally, everything looks great, but at home, things are completely in shambles. And even there, my wife, like I said, my wife had no idea that I had an issue. So this is a little bit dated, but in 2009, the Mayo Clinic did a study of physicians in a recovery program, and they said about 1 in 10 physicians have some sort of substance issue. And in some of the specialties, it gets higher than that, 15% maybe, instead of 10%, and which is very similar to the general population. We are no different than anybody else as far as substance issues are concerned. We're exactly the same. 50% was misused alcohol, and 36% abused opioids. And it goes on to say 50% of those people had a multi-drug issue, and 13% even used IV drugs. And I would think that might be where anesthesia might be involved. When I was in my treatment program, there was an anesthetist that was in the program, and he was found on the floor in the recovery room with a needle with a syringe of fentanyl in his arm. Fortunately, he didn't stop breathing, but he was in treatment. And they also mentioned that a lot of physicians in recovery have co-occurring psychiatric issues. Like I said, depression, anxiety, those sort of things. So, treatment for impaired physicians. There's 12-step programs, and I think most of us are probably familiar with the AA or NA, you know, Alcoholics Anonymous or Narcotics Anonymous. I am involved with a faith-based recovery program called Celebrate Recovery. It's a 12-step program. It fits me. AA, NA are wonderful. And what I would say is that those are available immediately. If you know someone or you have an issue, you can get involved today. You can start your recovery today. It doesn't have to, you don't have to postpone it. The other treatments are, as I mentioned, was the residential treatments program. I was given a choice of 3 places to go. At one time, 30-day treatments were available, and they found that 30-day treatments just don't work. In my case, I spent the first 3 weeks of my treatment in withdrawals. I would have had a week of clear-mindedness of treatment. So 90 days is the standard anymore. So there's the issue of alcohol versus legal versus illegal drugs, and treatment programs will be different for that. So I want to talk a little bit about the Oklahoma Health Professionals Program. Some of you may or may not be available with it. I have good friends with the director of the OHP for Eastern Oklahoma, Dr. Lowell Robertson. And I spoke with him at length because I've not been involved with OHP for a while. And it's an advocate for physicians. It's not a punishment program for physicians. And they don't have to necessarily report you to the licensing agencies, depending on your position. Now, obviously, if you're requiring an intervention and you get turned in by your wife or your partners, and you're just refusing to admit to an issue, then you probably are going to be reported to the medical board and maybe other boards, the OBN or the DEA. If you refuse recommendations and you just do not follow the plan, then more than likely you're going to be reported to the medical board. If you're obviously impaired, you may have to be reported to the medical board. If you're abusing prescriptions, writing prescriptions and selling them or sharing them or trading them, it may require reporting. If you're doing illegal drugs, or if you get arrested, like with a DUI, if you get arrested, then obviously it's a public knowledge thing and will probably be reported. But the OHPP really wants to be your advocate, but they have to protect the public. It's not about punishment. It's about recovery, but it's about protecting the public as well. And so they don't absolutely have to report you to the medical board, to the board of examiners. They don't have to refer you to the DEA, or they'll report you to the DEA or the OBN. They don't have to report you to law enforcement. It's a case-by-case basis. So the prognosis actually can be very good. If you follow the program, you do what you're told, you have a 75 to 90% abstinence rate. Now, obviously, we have the OHP sort of has a hammer. Do it our way, or we will report you to the board. So there's a hammer there, but it's a good hammer because it will lead to recovery. Currently, the OHP requires an independent, out-of-state evaluation of each person that gets that comes to OHP, and that independent agency will determine your treatment needs, whether you need outpatient 90-day treatment, whether you can continue to practice, whether it needs to be reported to the medical board or the OBN. It's a outside agency that does that. Let's see here. So part of the treatment is participating in the OHP program. Weekly meetings, I think in Tulsa, it's on Thursdays. In Oklahoma City, it's on Mondays, going to weekly meetings. Random urine drug testing. The first year for me was once a week. And then after the first year and a half, it went to 2 weeks. And then the last year or so is once a month. But random drug screening is absolutely imperative. If it's an alcohol-related issue, Dr. Robertson says sometimes they require you to have one of those SoberLink devices in your car or that you carry around with you, and you get paged and you have to blow into it to get a breathalyzer test sometime, anytime, 24 hours a day, to make sure that you're staying sober. And then this evaluation agency may also recommend that you get mental health issues resolved or addressed, psychiatric treatment, whatever, counseling, whatever. So it doesn't have to be the end of the world. I'm an example of that. But you have to follow the plan. You have to follow the program. It will save your practice, and it may save your life. Dr. Robertson, I have to tell you about Dr. Robertson. He's a close friend of mine. I was actually his sponsor for a while. He gave up his license in just, I think, 1999 or 2000. He was doing everything you could think of. And he said, I'll show the medical board, I'll just turn in my license. He showed them. 20 years later, as I was talking with him and as I was his sponsor, he said, Jerry, do you think I could ever get my license back? So we started down that path. And that took a while. It didn't just happen overnight. But he went to the medical board and talked to them. They said, here's things you need to do. Here's programs you need, review courses you need to do. And 2 years ago, I was at the medical board meeting when he was reinstated to practice medicine. And he's since done a fellowship in addiction medicine at OSU and returned to practice. And he is an example of it doesn't have to be the end of the world. Things can return to good. I want to read one letter I had that I save in my computer. I told you I have 23 state licenses, and all 23 states I've sent this letter to them. I voluntarily relinquished my DEA certificate and my Oklahoma Bureau of Narcotics certificate in May of 2006 and entered rehabilitation for an addiction to narcotic pain medication. I was in treatment until August of 2006. And in December of 2006, I was reinstated with the DEA and the OBN and returned to my full-time practice of emergency medicine at Baptist Hospital. I had random urine drug screen testing for 5 years and attended the state's health professionals recovery program. I was able to return to practice of emergency medicine with no restrictions on my license. I have not had any issues since 2006. I continue to work on my recovery by assisting others with similar issues in a faith-based recovery program. I understand that I made very poor decisions from this experience. Hopefully I can help others. And I've sent that to 23 different states, and 23 different states gave me a license. So it's not the end of the world. if you get treatment and you follow the plan. But it can be the end of the world. There's another side. I know of 3 physicians that it was literally the end of the world for them. One of them, a young man that I helped mentor into medical school. He did a rotation at Baptist Hospital in the ER while I was there, and I worked with him there. And then I met with him from time to time after he got out in practice, and I talked with him after he started having trouble with, actually his wife called me and said, would you please meet with him and talk with him? We talked, met together several times, and the last time I saw him, he said, I'm just going to go a different way. And he refused the 12-step program. And he drowned in his bathtub. I don't know if he did it on purpose or if it was an accident, but he's no longer with us. There was an anesthesiologist at Baptist Hospital who was in recovery that gave me a lot of encouragement. He was in recovery and gave me encouragement when I was early in my recovery. He gave me a lot of encouragement. Unfortunately, he relapsed, and it was broadcast on the local television stations. The next day, he took his life. So it can be the end of the world, but it doesn't have to be. I made a foxhole promise back in 2006 that God, if you get me through this, I promise I'll try to help any way I can other people, not just physicians, other people who are struggling with substance abuse. That's why I'm here. It's not easy to read this garbage that was in my life to you guys. I know people that know me. Matt back there knows me, and it's not easy to admit the failures in my life. But that's why I'm here. There's a website, ohpp.org, that you can go to and look at if you have issues or you know someone that has issues. And like I said, it's confidential. I was looking at the website today. The first 2 words are a confidential. So it's available. I'm willing to talk to anyone, anytime. I know you probably don't want to be seen with me now talking to me. You might think that someone might think you've got an issue. But I'd be willing to talk to anyone. My phone number's in the DO directory, 405-659-8840. If you want to, I'll talk to anybody, anytime. And my wife says that I'm probably in the 4th quarter of my life, and it might even be at the 2-minute warning with no timeouts left. But I want to finish strong, and you guys can all finish strong. If you've got an issue right now, don't let it get out of control. If you know you're going down a path that you know in the back of your mind, you know, this isn't the best choice, but I'm going to do it again. I know I probably shouldn't do this, you know, and someone confronts you and you deny. Don't deny any longer. Admit and get help and get your life back, save your practice, and maybe save your life and finish strong. And I think that's all I have. Thanks.
Talihina, Oklahoma, where I also serve as a Chief Medical Officer for the Choctaw Nation. We're happy to have you join us here today. Hope you liked your lunch. And the exhibits will be open until 6 today, and tomorrow from 7:30 until 5, and Saturday from 7:30 to noon. And make sure and go and thank our exhibitors and visit them if you can. So we're going to go ahead and call the 2022 OOA Annual Business Meeting to order. And we're going to start this off with an invocation I'd like to invite Pastor Danny Reed to the microphone. He's a pastor at the First Baptist Church in Elmore City, Oklahoma. He's going to deliver our invocation. Pastor Reed.
Thank you. Would you bow with me? Father, we bow before you today, and God, we thank you for just simply who you are. The beauty of the day, you've given us another gift, Father, that you have bestowed upon us of life. And God, I pray that we would use every breath, Lord, to just exalt you and glorify you. Father, I thank you for this opportunity. And God, I thank you for every person that is represented here in this place today. God, I thank you for the gifts that you have given them. They are precious to us as a society. Father, we are so very, very thankful for them, for their families, God, the sacrifices that they have made. And God, I pray and ask that you would continue to grant wisdom to them, grant knowledge to them, and Father, just grow them in their profession. But Father, more importantly, God, I pray that they would grow in you. Lord, we ask now that as they gather together for this time of business, Lord, I pray that wisdom from only you would fill this place. God, I pray that all that is spoken in word and deed, attitude and mind, God, would be pleasing to you. And Father, most of all, we are thankful for Jesus Christ, for his sacrifice on Calvary, the blood that he shed to cleanse us and save us, forgive us of our sins. Lord, we ask and pray all of this in his powerful and precious name. Amen.
All right. Thank you, Pastor Reed. Now call upon the outgoing OOA trustee and past president, Richard Schaefer, DO, to the podium to lead us in the Pledge of Allegiance. Dr. Schaefer.
Would you stand with me? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you.
Thank you, Dr. Schaefer. That's your last official act? Close to it. All right. Next on our itinerary is to appoint, or the appointment of special committees for this meeting. For the Committee on Credentials, I'm going to appoint Dr. Leroy Young, Dr. Doug Nolan, Dr. Rebecca Lewis. For the Committee on Resolutions, we're going to appoint Dr. Richard Schaefer, Dr. Tom Carlisle, and Dr. Brett Langerman. For the Tellers, Dr. Dennis Carter, Dr. Mark Keichel, and Dr. Dwayne Kaler. For the Sergeant at Arms, Dr. Tim Moser. Introduction delegates, I want to recognize the dignitaries that have joined us today. I think Dr. Michael Ogle couldn't be with us, is that right?
He has COVID at the moment.
He's ill,
Yes.
so okay. I don't want to do any HIPAA violations here. I'd also like to next introduce Dr. Bruce R. Williams, DO, FACOFP, President of the American College of Osteopathic Family Physicians. You told me last night it's just your first trip to Oklahoma City, so welcome. Please join me now as we take a moment to recognize and remember our osteopathic family who have passed on in the last year.
Frederick W. Bowling, DO, April 26, 2021. James S. Stouffer, DO, June 3rd, 2021. Arnold C. Todd, DO, June 29th, 2021. Joel W. Korn, DO, July 14th, 2021. J. Steve Grigsby, DO, July 15th, 2021. Craig C. Cooper, PhD, DO, August 11th, 2021. Michelle D. O'Meara, DO, August 12th, 2021. G. Dale Derby, DO, August 17th, 2021. Michael H. Whitworth, DO, August 22nd, 2021. Robert S. Lawson, DO, August 25th, 2021. Ronald E. Jackson, DO, August 27th, 2021. Gary Gramellini, DO, September 3rd, 2021. Stephen W. Baldwin, DO, September 5th, 2021. Tony L. Brown, DO, September 17th, 2021. Abby Renner, OMS 2, November 22nd, 2021. Deborah J. Bruce, JD, January 21st, 2022. Harry J. Whetstone, DO, January 24th, 2022. Gary M. Freeman, DO, March 29th, 2022. Wilbert Wilson, W.W. Stover, DO, February 9th, 2022. Thomas R. Pickard, DO, February 24th, 2022. Regan G. Nichols, DO, February 25th, 2022.
A little choked up, sorry. Some friends and some mentors, and miss them. Now time to recognize our lifetime members. An OOA life membership may be granted to any regular member who has reached the age of 70 or completed 50 years of osteopathic practice, whichever comes first by November 1st, and has been in good standing for 25 consecutive years immediately preceding in the OOA or any other divisional society of the AOA. Such members shall have the privileges and duties of regular members, but shall not be required to pay dues or assessments. Please come forward and accept your award when your name is called and have your photograph taken. Our lifetime members include, I think this is yours to do, isn't it?
Our first one is Henry M. Allen, DO. Next one is David W. Asher, DO. Joseph A. Braden, DO. Gary W. Cannon, DO. Gary T. Dykstra, DO, FACOI. G. Wayne Flatt, DO. Terry R. Gerard, DO. James I. Graham, DO. Christian S. Hansen, DO. Bo C. Jennings, DO. Peter C. Lafon, DO. And Kenneth R. Trinidad, DO. Thank you. That's a record.
Well, I guess maybe they're virtual, right? So congratulations to our lifetime members. I now ask our independent CPA, Mr. Ross Roy, to the podium to present our 2019-2020 fiscal year audit progress report.
Mr. Roy wasn't able to make it. He has a conflicting commitment, but a full audit has been undertaken of the 2019 to 2020 fiscal year by the CPA from Gray, Blodgett and Company. Our auditors are working to wrap up the few remaining items, and a full report will be published and disseminated to the OOA membership with all due haste. An annual review of the 2020 to 2021 fiscal year will be completed and published to the OOA membership within the next month, and we'll be all caught up at that point.
Now for the presentation of the 2021 annual business meeting minutes. Our annual business meeting minutes from last year can be found on pages 5 through 8, and I seek your approval. Any discussion? All in favor? Aye. Are there any opposed? Motion passes. We'll now hear from our bureau chairs as they present their 2021 reports. Bureau chairs, please line up near the microphone. We'll begin with the Department of Professional Affairs and with our Bureau on Awards Chair, Dr. Gabe Pittman. And I haven't seen Gabe.
I'm the vice chair.
Okay.
We're going to give out plenty of awards this year, including a new award we haven't given out in about 10 years. So you'll have to go to the meetings to see who gets the awards. Banquets.
Thank you, Dr. Moser. Supplemental reports. I now recognize individual for, I'm sorry, did I miss one? Actually, Bureau on Membership, Dr. Chuck Thurman.
Thank you. The Bureau on Membership held 10 meetings since May 2021. The Bureau made the following recommendations: 60 new members, 1 waiver or reduction in dues, 12 life memberships, and 0 honorary life memberships. The OOA Board of Trustees approved all recommendations. As of April 13th, 2022, OOA membership is 2,492, including 827 paid members. The total membership number includes students and residents. This report is informational in nature and no resolutions were presented.
Thank you. Bureau on Continuing Medical Education, Dr. Rebecca Lewis.
The Bureau on CME has met multiple times throughout the year. We have now had 2 conferences in the last year that we've had back in person, so we're very excited to have everybody here. And then we also had our one in January that was virtual. We have also received, with the help of all of our OOA staff, a 5-year credential approval through the AOA so that all of our CME will continue to be approved without question on that. So we commend the efforts of our staff on that, and the rest of the report is in the report and informational in nature.
Thank you, Dr. Lewis. Bureau on Constitution and Bylaws, Dr. Douglas Nolan.
We have 3 amendments to the Constitution and Bylaws for membership to consider. If you'll look on page 20 of your annual report. The First Amendment deals with the Constitution, Article 7, Meetings and Conventions, Section 2. We propose adding the phrase, "or electronically communicated," to allow for modern technology to be used when notifying the OOA members. The second that we're recommending would be this, to the Constitution, Article 9 amendments. We propose adding the phrase, "or electronically communicated," to allow for modern technology to be used when notifying the OOA members. The third is very similar to the others, just to make sure that we're staying with technology. That'll be to the Bylaws Article 9 amendment. We propose adding the phrase, "or electronically communicated," to allow for modern technology to be used when notifying the OOA members. Thank you, Mr. Chair.
Dr. Nolan, since he's come out of committee, that's got a motion and a second for approval. Is that
That's correct. That's correct.
Are there any questions regarding these amendments to our bylaws? Comments or concerns? Since they come out of committee, they don't need a second. So all in favor, say aye. Aye. Are there any opposed? Yes, we're so moved. Bureau on Postgraduate Education, Dr. Teresa Hardesty.
The Bureau on Postgraduate Education met 5 times over the last year, and we discussed ways that we can assist students and residents in Oklahoma. The Bureau supported the 13th Annual Research Poster Symposium, which is for osteopathic physicians and postgraduate training programs, as well as osteopathic medical students who were invited to participate. The poster symposium presentations were given at the OOA Virtual Winter CME, which was held via Zoom. There were 22 students and residents who submitted their research to the poster symposium this year. 3 finalists presented during the virtual CME seminar. There was research grant money available to promote ongoing research among osteopathic physicians in training. However, no grants were awarded this year. Cash award sponsors included $2,500 from the Oklahoma Osteopathic Association for the first place, $2,000 from the Oklahoma Educational Foundation for Osteopathic Medicine for second place, and $1,500 from the Osteopathic Founders Foundation for third place. This report is informational in nature and no resolutions were presented.
Thank you, Dr. Hardesty. Next, for the Department of Public Affairs, the Bureau on Legislation, Dr. Leroy Young.
Well, the Bureau of Legislation, we have been very busy this past year, especially this year. Since the last time we all got together in person, as you well know, we have a new lobbyist, Jami Longacre, who is a very excellent lobbyist for all of us. And probably the most important things going on this year, we've been very successful. I will say there has been no scope of practice bills this year. So we have done well. Now, next year, it'll be a new story because everybody's wanting to be physicians without the education, as you all know. So the other big issue that we're dealing with right now is Medicaid expansion. Today, they're hearing in committee the bill on that. It doesn't, we're not happy, shall we say, with what's coming out of this bill. But it apparently, from what I have told on the way over here today, it doesn't probably make a lot of difference, because the governor has said if we don't have a Medicaid expansion bill, the one that he is pushing with the healthcare authority, there will be no budget signed. So they're probably going to be a Medicaid expansion bill.
That's a Medicaid, managed Medicaid bill.
Managed Medicaid, which capitation, they're going to put commercial insurance companies involved in it. We're trying to make sure that physicians are involved in the overall process, which we will see if that happens. So more, hopefully, maybe by this evening, we'll know more when they get through with committee meetings. The other highlights, I think, we had also had DO Day, which any and all of you are invited out at the Capitol. We had that showed up out there. We had 16, well, this year, we had 9 students, 2 residents, 12 physicians, and we had 15 meetings with leadership out there, which was very good to talk to leadership on both sides of the aisle, in the House and the Senate. And then that evening, on April the 4th, we had, again, because of the pandemic, we had a reception for the legislators, and we had 60, well, I believe they said 48, excuse me. We had 48 legislators show up out there, and we had 6 students, 1 resident, 11 physicians who sat around for approximately 2.5 to 3 hours and visited. Again, you're all invited to come when we have that and talk to your legislator. And it's really a good deal because you can sit there. We have hors d'oeuvres and we have adult refreshments, and you can discuss, and they're very receptive. And again, Jami did a very good job on getting them to come over. So that's just a report. I didn't sit in again. As you know, advocacy is a big thing for this association. I want to thank everybody who does donate to OPAC. I'm the chairman of that, but we also need you to continue to help us out there with these legislators and on the issues that are important to all of us and to your practices and to your patients. So thank you all.
Thank you, Dr. Young. From the Department of Business Affairs on Bureau and Finance, Dr. Jonathan Bushman.
The Bureau met 10 times during the past year and reviewed monthly financials with the association's CPA, Peter Terranova. This report is informational in nature. No resolutions are presented.
You also get to do Bureau and Convention. Very good. Dr. Bushman again.
All right. All right. Bureau and Convention met periodically over this last year to ensure that this 122nd annual convention, What's Next, at the Sheraton Oklahoma City Downtown Hotel would attract members from all specialties and across the state by providing quality education and social events for networking and reconnecting. This is the first in-person convention since the COVID-19 pandemic. The 122nd annual convention is considered a hybrid event for registrants to have the option to attend in person or via live stream. The hybrid 122nd annual convention offers a maximum of 27.5 AOA Category 1A credits. The AAFP credits are pending. This report is also informative in nature. No resolutions are presented. Thank you.
Thank you again, Dr. Bushman. Past presidents and district presidents council, Dr. Tim Smosher.
Past presidents met virtually in Zoom in conjunction with the district's president council during the virtual 2012 Winter CME. Council just briefly discussed issues of importance. Again, this is informational.
I think he's
He's not? Okay. Okay. Dr. Justin Sparks was scheduled to do the Bureau on New Physicians and Residents. I actually skipped him. So I think our resident attorney and executive director, Allison, is going to go ahead and, can you give his report, Allison?
It's the district president's council.
Sorry, the new physicians and residents.
So the Bureau has been moved to ad hoc status and did not meet between April 2021 and April 2022. I believe it might be pending y'all's decision rolled in with the Bureau on Postgraduate Education. So we shall see what happens in the future. But this report is informational in nature and no resolutions are presented.
Thank you. Thank you, Allison. Okay. Dr. Moser, did you do nominating committee?
Yes.
Thank you.
Are we on?
Yes.
Good. The nominating committee met, and we have recommendations for consideration of the membership of the Oklahoma Osteopathic Association. For 2022-2023, the vacancies to be filled. Would you rather me do it as a slate or one at a time?
Slate.
Okay. Dr. Jason Hill as past president, Dr. Jonathan K. Bushman, DO, as president, President-elect Rebecca D. Lewis, DO, Vice President for one-year term, Jonathan B. Stone, DO, Trustee, three-year term ending 2025, Amanda Foster, DO, Trustee, three-year term ending 2025, Mark Keichel, DO, Trustee, one-year term ending 2023, Ashton Clayborn, DO, and Trustee, one-year term ending 2023, Mark Callery, DO.
I guess that comes in a form of, since this will, I'd like to vote on this individually. So is that, those are your nominations?
That's the nominations to go onto the board.
Okay. Are there any questions about that group? Anybody have any suggestions that other than what we have? I can say most of them are here.
Why don't you stand if you were just nominated? So I think everyone literally that's nominated is here.
Thank you. Okay, so hearing no other nominations, all in favor say aye. Aye. Are there any opposed? Okay, thank you. Thank you, Dr. Moser. Is that in your report?
No.
Okay, sorry.
We've got delegates to the AOA.
Okay.
And alternate delegates to the AOA. I'm going to read the delegate list as a slate, unless someone wants to do that individually. Stand if you're here, that way we'll. Jonathan K. Bushman, DO. David Hitzman, DO. C. Michael Ogle, DO. Justin Sparks, DO. Dennis Blankenship, DO. Leroy Young, DO. Trudy Milner, DO. Jonathan Stone, DO. Rebecca Lewis, DO. Jason Hill, remains standing. Casey Schrum, DO. Christopher Chuck Thurman, DO. Teresa Hardesty, DO. Timothy Moser. Dennis Carter, DO. Lane Sabera, DO. And a student delegate to be determined as our 2022 AOA House of Delegates.
Thank you. Since that also comes out of committee, we can vote on those as a slate. Is there any opposition to voting on these as a slate? All in favor of this group, say aye. Aye. Are there any opposed? Thank you.
All right, now we have our alternate delegates for the AOA House of Delegates. I will read them as a slate as well. Ronnie, and stand if you're here. Ronnie B. Martin, DO. Brett Langerman, DO. Richard Schaefer, DO. Mark Keichel, DO. Amanda Foster, DO. Joseph Schleck, DO. Doug Nolan, DO. Dwayne Kaler, DO. Natasha Bray, DO. Emily Grew Nelson, DO. Gabriel Pittman, DO. Bob Aaron, DO. Thomas Carlisle, DO.
Dr. Carlisle?
Ashton Clayborn, DO, and Mark Callery, DO. There's an empty spot, and then a student delegate to be determined.
I need to go ahead and vote on these as a slate. Is there any opposition to voting on these as a slate? All in favor, say aye. Aye. Are there any opposed? Thank you.
That concludes my report.
Thank you, Dr. Moser. Supplemental reports. We'll like to recognize the individuals for supplemental reports. Included our foundation. We're going to do these one at a time. Are they listed in there? Our foundation report, it's in there, right? Okay. OSU-CHS, our Political Action Committee, and the Osteopathic Licensing Board. Just move on. For the OEFOM report, Dr. Tim Moser.
The report, if you want to follow, is on page 10. OEFOM had a successful year in 21-22. The executive committee is led by myself, Dr. Schaefer, Dr. Hill. Beginning in 2022, Dr. Schaefer will take over, Dr. Hill and Dr. Bushman will come in. I will roll to past president, and then Allison LaBeouf, our executive director, who's acts as secretary and treasurer. The OEFOM has awarded 10 scholarships, or will award tomorrow, 10 scholarships totaling $17,000 to well-deserved students at OSU who have applied for the endowed scholarships. Please encourage, if you do have any students, to apply for scholarships next year. More information can be found on the foundation's page and also on the OOA website. Scholarships awarded during the OOA annual convention tomorrow. This year's been a very eventful year. Last April, if you didn't know it, we had a catastrophic flood causing major damage to our building. The OAFOM had a campaign to reach $50,000 titled Building Preservation Initiative. We definitely exceeded that $50,000 goal. Some of the funds, as well as the insurance claim, helped fund also building restoration. Please visit the OOA central office to view the updates when you get home. 2 trustees are rolling off. Dr. Gabriel Pittman and then his father, Marsh Pittman, were very helpful to the foundation. We'd like to give them thanks for everything they did to the foundation. We'd definitely like to thank everyone for all the continued support to the foundation. I've already met the other people on the board were Dr. Keichel, Dr. Young, Dr. Ogle, Dr. Langerman, Dr. Bushman, and Dr. Lewis. So we did have a nominating committee, and the nominating committee would like to present to the 2022 OEFOM board members. Dr. Schaefer, again, will be president. Jason Hill will be president-elect. Dr. Bushman will be vice president. Allison LaBeouf will be secretary treasurer, and I'll be immediate past president. The trustees will be Dr. Lewis, Dr. Stone, Dr. Young, Mark Keichel, DO, Brett Langerman, DO, Dennis Carter, coming back on the board, and then 2 lay members, Dr. JD, David Ogle, and JD Jared Davidson. A vote of membership is required for the new slate.
So we go ahead and call for a vote to approve the slate of the OEFOM trustees. All in favor, say aye. Aye. Are there any opposed? Thank you, Dr. Moser. Okay, we're going to continue with some more reports. The OOPAC committee, Dr. Leroy Young, chair.
Thank you, Dr. Hill. You can look on page 13. I briefly alluded to the OPAC previously. As you can see, we had 19 physicians who donated $9,297 this past year to OPAC, and so we spent $6,500 so far. We're unable to do anything during session, and when session's out, we will continue again. But due to the restrictions, we can't donate during the legislative session. So again, I would encourage, I thank the 19, but would encourage more people out of our association to donate.
Thank you, Dr. Young. Okay, the OSU Center for Health Sciences report, which can be read on page 13. We're going to ask Dr. Dennis Blankenship, who is the interim dean of the OSU-COM Tulsa.
Thanks, Dr. Hill. As Dr. Hill said, there is a complete report in the packet. Just to touch on a couple of highlights of things that we have going on at the university currently. One of the main projects, many of you have probably heard about, the Veterans Hospital in Tulsa, which is an expansion of our current academic teaching campus there at OSU Medical Center. A donation from OSU was made of the current Edmondson building just north of the hospital to the Veterans Administration. That facility is being renovated, 275,000 square foot facility that will serve the veterans of Northeast Oklahoma, over 40,000 members of that, of the Veterans Association of Northeast Oklahoma. Included in that project is also a new mental health facility. That's a 150,000 square foot facility on that property that will have just over 100 beds to serve Northeast Oklahoma behavioral health services. The addition of a parking garage on that campus will also serve in that district. These projects are the first of many that we have planned for that academic medical district there in downtown Tulsa, to include innovation centers, research centers, future clinics, but very excited about that project. The other things to mention, kind of high points, are the completion of our North Hall there on the campus, OSU-CHS campus. That in conjunction with the medical examiners, which will be moved into the bottom floor of that new building. It will house our new anatomy labs, neuroanatomy labs, as well as multiple teaching classrooms and office buildings there. So the grand opening of that building is July 28th. That will also be a celebration of our college's 50th anniversary. As many of you know, the college was opened as Oklahoma College of Osteopathic Medicine and Surgery in 1972. Since then has graduated 3,782 DOs, many of which have practiced alongside you in Oklahoma. We have a graduating class of 102 this year, 51 of which matched in primary care here in the state. So very happy to report things are going really well, and happy to visit with any of you if you have any questions.
Thank you, Dr. Blankenship. If anyone anyone serving in elected government or anyone serving in federal or statewide positions would like to give a report, please do so now. Okay. Moving on. Actually, we already did the OOA nominating committee. So we're going to move on. Is there any old business that needs to be, I'm sorry. Okay. Is there a licensure board report?
Yes, sir.
Dr. Young, thank you.
The licensure board, you can find it on page 11. I'd like to say a couple of highlights. We have a new executive director, Michael Leake. He's JD. He's not here, he's ill, but we hired him approximately a year ago. As you saw, our former Executive Director Deborah Bruce passed away this past year. So there's no mystique to the licensure board. We operate on complaints only, and our charge is to protect the public. It is made up of 8 members, 2 being lay, 6 physicians. This past year, as you saw, Dr. Derby had an unfortunate accident and passed away. He drowned at the lake. So, but I would like, so you guys know who is on the licensure board. Some of them are here today. I'm going to ask them to stand. Katie Templeton is current president. She's a JD and layperson. Her dad happens to be Neil Templeton, a DO, so that's just sort of keeping it in the family. He's an anesthesiologist, now retired. Brett Langerman. Brett, would you stand? Continue to stand. Kathy Taylor is the other layperson. She's an attorney also in Tulsa. Myself, Jay Cunningham, Dwayne Kaler, Mike Ogle, who has COVID today, and Dennis Carter is our newest member who replaced Dale Derby and come back on the board. So these are the ones, the board members. If you have any questions or anything, don't hesitate to ask any of us. You know, it's better if you have questions now than later. Okay, and just if you look there, I think it's interesting that we have 2,546 DOs now that are licensed in this state. That's a long ways from where it used to be. And we have 562 out of state. We have 404 residents and fellows that are licensed now. 58 retired physicians still have their license. 7 volunteers. 77 residents, PGY1, that's a special license we have. It's not required, but the majority of them is starting to get it. So we have a total license of 3,654 DOs in this state. Thank you.
Dr. Young, do you mind explaining the process of how these positions come about, they're appointed?
Sure.
It's a little different than, we don't get to vote on those here.
No. Yeah, so you all know what happens, and it was put in the statute many, many years ago. The association selects 6 names. They have to be in practice at least 5 years and in good standing. Then they are submitted to the governor, and the governor makes a selection from those 6. So that's how we were all, the association put us up, and then the governor selected from that list.
Okay, thank you. I just want to make sure everybody understood those are appointed by the governor.
Good point. Right. Thank you.
Thank you, Dr. Young. We'll now move on to new business. I'd like to ask Dr. Doug Nolan, Chair of the Bureau of Constitution and Bylaws, to present the proposed amendment changes. Dr. Nolan? Oh, sorry. I guess I'm on autopilot here, I'm sorry. Where are we? Okay, old business. Anything old business that needs to be discussed? Okay. Okay, thank you. I guess that concludes our 2022 annual business meetings, unless there's anything else. Thank you for joining us today, and hope and for joining us here at the 122nd Annual OOA Convention. Thank you.
Good afternoon, everyone. We'll go ahead and get started with the Oklahoma ACOFP meeting. I would like to call the meeting to order. And first, we'd kind of like to start off with a roll call. Are there any past state Oklahoma ACOFP presidents in the room? And then what about national presidents of ACOFP? Thank you. And then anyone currently serving on a committee for the ACOFP? Thank you for your service. Now I'd like to recognize a national visitor that we have. We'd like to welcome ACOFP President Bruce Williams, DO, FACOFP. Dr. Williams practiced osteopathic medicine for over 30 years in Eastern Jackson County, Missouri. He is currently the Associate Dean of Clinical Education at Kansas City University College of Osteopathic Medicine. Dr. Williams was elected president-elect in 2021 following his appointment as Secretary-Treasurer of the ACOFP Board of Governors in March of 2019 and has chaired ACOFP's Task Force on Physician Wellness. His elected Board of Governors position follows years of active ACOFP volunteer involvement, including his role as a delegate to the Congress of Delegates and as a member of the Patient-Centered Medical Home ACO Committee and the Ethics Committee. From 2011 to 2013, Dr. Williams also served as president of the Missouri Society of the ACOFP. Please help me welcome Dr. Williams.
Thank you very much. I guess they're going to bring, there we go. I want to say it really is a privilege for me to be here serving as national president. And my job is made a lot easier by the support that we have from our ACOFP staff, but also from our excellent Board of Governors, including Dr. Rebecca Lewis, and also the wisdom and mentorship I have from my predecessors, including Dr. Kaler and Dr. Martin. So I so much appreciate the efforts of these people. So we did get to meet for our annual convention in person this year, which was absolutely wonderful. I've added one four-letter word to my vocabulary, and that's Zoom. So not having to prepare presentations over Zoom and look at little boxes was absolutely wonderful. So, but our new Board of Governors, our newest members on the Board of Governors, obviously yours truly, Dr. David Park is our president-elect coming in. Dr. Gavin Desai is our newly elected vice president. Dr. Brian Kessler is continuing and was reelected as our secretary treasurer. Dr. Peter Biddy is our newest governor, and our resident governor is Dr. Jordan Wong, and Evan Bishop is our student governor. As I said, Dr. Kessler was reelected, and Dr. Cohen was reelected as governors, and Dr. Pomerosi was reelected as our Speaker of the House, and Dr. Sampanides was reelected as our Vice Speaker of the House. All of our other governors have continuing terms, and you can find the list of our Board of Governors on the ACOFP website. Our membership, so at our annual convention, we had a number of award winners. There was 11 total. Of particular note was Janelle Johnson, DO, MPH, which was a recipient of the ACOFP Distinguished Service Award for her work. She's a clinical assistant professor of medical education at Oklahoma State University of Osteopathic Medicine at the Cherokee Nation and serves as vice president of the Tulsa Area Osteopathic Medical Society, in addition to being an active member within the Oklahoma Osteopathic Association. And so some kudos to Dr. Johnson, and I'm sure her state association is extremely proud of her performance. We had 11 physicians that we brought into our conclave of fellows. Who in this room is a current fellow of ACOFP? Excellent. So for everybody who isn't a fellow, I strongly encourage you to seriously look at that opportunity. Everybody here pretty much is a leader, and there is, it involves you attending a few meetings, continuing your leadership. You will need a sponsor, so as you looked around the room and those who raised their hands are all fellows, please ask them about their interest in being a sponsor. And there's a requirement for you to do a paper. So it really is a prestigious award. I encourage everybody to look into becoming a fellow. How about distinguished fellows? I know we have at least 2. So carrying your fellowship forward, serving, attending a few more meetings, you get the very prestigious honor of being a distinguished fellow, as Dr. Kaler and Dr. Martin are. We welcomed 4 new fellows into or distinguished fellows, I'm sorry, into our ranks this year at our annual convention. And we also awarded 7 Master Preceptor Awards. Being a preceptor in our profession is extremely important, especially in our specialty. I know when I graduated from medical school, there wasn't really any question about whether I was going to be a preceptor or not. It just seemed that it was something that, you did. I felt obligated to do it. It doesn't seem like it seems that it fits into that mold anymore, but being in clinical education, I can tell you that without our preceptors, our students are really at a loss. So I hope, I'm going to guess that everybody in this room is a preceptor in one form or another, and we certainly appreciate the service that you provide as preceptors. So our MD membership update on March 10th, 2021, the Congress of Delegates passed the resolution to allow MD membership. That was approved and finalized on May 11th. And then on May 24th, 2021, we actually welcomed our first MD member into our ranks. So our specialty and our membership is growing with the inclusion of MD members. So education obviously is very important. It's part of it's very well embedded into our strategic plan. And in addition to our annual convention and our and OMED, we have the intensive osteopathic update. If you've not attended the intensive osteopathic update previously, I strongly encourage you to do so. Even if you're not getting ready to sit for recertification or initial certification, it really is a wonderful opportunity to refresh and renew your knowledge of osteopathic family medicine, in particular OMT. I know I've attended a couple of the IOUs, and I always come away with learning a new technique of one form or another that I use every day in my office. I don't think when I was still practicing the last few years, I think everybody that came in with a head cold or an upper respiratory tract infection of some form got OMT given to them. And I really found that it cut down on those patients coming back in 3 and 4 times with recurrent symptoms. So it really is a wonderful opportunity. It's a great weekend to network, see friends, but it really is a great educational opportunity. That is coming up in August. It's the 5th through the 7th this year, and it's in Chicago at the Rosemont Convention Center. Hot off the press is digital health for practicing clinicians. This is a certification program, a certificate program, I'm sorry. that we're doing in conjunction with the Digital Medicine Society and Rocky Vista University. It's got 5 1A credit hours with the AOA, and it offers topics including Introduction to Digital Health, frameworks for selecting technology for patients in clinics, best practices for telemedicine, artificial intelligence in healthcare, integrating digital health technologies, patient advocacy in digital health, consumer health informatics, and health equity and ethics for the digital age. So obviously, you know, especially since COVID and the pandemic, we're learning new and different ways to use technology in our practices. And we hope that this opportunity is going to provide our members with some additional tools to be able to use that they can use. We also are excited to partner with the Endocrine Society to offer a certificate program for diabetes. This offers 15 AOA 1A credits, and it also offers AMA credits as well. It's actually 12 interactive modules that you can complete, and there's information on our website about that. A couple of complementary offerings. One is developing HIV testing and treatment that we do with MedIQ, and the other one is hepatitis B recognition and care determination in primary care that we also partner with the Hepatitis B Foundation and MedIQ on. Again, these are complementary. The HIV testing offers 2.75 hours, and the hepatitis B offering offers 1 credit hour. And then there's OMT Total, which offers, it's a large online OMT video library. There's more than 150 different techniques that are constantly being updated. I know I was on a meeting the other night with Dr. Lewis where we talked about, you know, ongoing efforts to be more inclusive in that library. So I believe you can also get that in addition, included as part of your membership when you renew your membership. So please look at that. And of course, our journal, The Osteopathic Family Physician, there's opportunities to get additional CMA through the OFP. As far as advocacy, the ACOFP has its own advocacy firm in Alston and Byrd, and they monitor proposed legislation and regulations that impact family medicine. With their monitoring, they apprise the ACOFP staff and leadership as to upcoming changes. But we also provide them with our platform in the form of the Principles of Healthcare System Reform, where we let them know what our priorities and what our initiatives are. One of the things that we're looking at this year is that in May of last year, the National Academies of Science, Engineering, and Medicine came out with some recommendations for primary care. And ACOFP is part of the Family Medicine Leadership Consortium, which has considered the recommendations from NASM. And I think it really does highlight the need to promote family medicine. And that's actually one of the things that I want to be focused on this year. Coming out of the pandemic, when our patients had been cooped up at home as the rest of us were, and they were getting their health care through emergency rooms and urgent care centers, they were losing the continuity of care and the preventive care that they should be getting. So now as our patients are starting to come back to our offices, we're seeing that they haven't been getting the screenings, they haven't been getting their immunizations, but they haven't been getting the care that they needed. And it's really now is a time to put family medicine back in the spotlight and really promote ourselves for what we do. We provide that continuity care. We provide that preventive care that our patients really need and has been missing. But the other thing is that we should get the recognition that we deserve for it. And part of what's highlighted in NASM is that family medicine really does need to have not only the recognition, but the compensation. It's time for us to get paid for the work that we do. And that's something that we're going to be focused on in our advocacy, as well as the discussions that we have with our family medicine partners in the Family Medicine Leadership Consortium that's centered around the NASM recommendations. Also, as far as advocacy, you can see information about the ACOFP advocacies from the View from the Hill, which is a weekly newsletter that highlights the latest health policy news. Live and on-demand webinars and blogs also are available that report our advocacy information. As far as initial certification, the AOB, oops, I'm really bad about advancing slides. Oh, I can do it. It's just a matter of telling you. So the AOBFP in-service exam is produced and administered by the ACOFP. It's a formative exam that fulfills the ACGME standard requirements. And it includes the osteopathic component that fulfills the ACGME's OPP and OMM formative assessment programs for osteopathic recognition. And it also meets the ACOFP's early entry initial certification requirement. So the ACOFP's initial entry certification requirement is that you take the IFC exam each of your first 2 years, and you can sit for the initial certification exam in your 3rd year of your residency. There's also the ACOFP Cortex exam, which is a formative standalone OPP-OMM exam that fulfills the osteopathic recognition requirement for the other OR programs. So if you're, DOs, interns, MDs, in other residency programs that have osteopathic recognition, you can take this Cortex exam and fulfill those requirements. So our ACOFP Foundation in 2019 started the initial certification grant through the Forging Our Osteopathic Future campaign. The goal was to raise $2 million to support residents getting their initial certification exam and doing their performance examination. As of now, I believe we've got like 1.8 million of that raised. So it's been quite successful. If anybody is interested in still contributing to that, we're always willing to take more. But this started in 2019. So I got some statistics. So in 2020, 130 residents from more than 20 states and Washington, D.C. were awarded the initial certification grant. In the spring of the 2021 cycle, we awarded 110 grants to residents from more than 30 states. And this number will continue to rise. As of the 23rd of March of this year, 88 third-year residents received the initial certification grant through the spring 2022 cycle. So part of the problem that we have with getting residents to take advantage of this program is just them being aware of it. So, what can you do to help if you're a program director, if you're residency faculty, if you're a preceptor, whatever, please make sure that your residents are aware of this opportunity and that they apply for it. Our goal is to get as many of our osteopathic family medicine residents certified through the AOBFP. And so between the initial the early entry initial certification pathway. And this grant, we hope that, we can provide the board exam to them at a lower cost. And actually, if they're doing the certification, initial certification grant, they can get it for practically free. So I think it's important to make sure that they're aware of it. That's the challenge that we're noticing right now, is just making sure that they're aware of it. During the last ACOFP Foundation board meeting, they actually developed a new mission, vision, and strategic plan that were finalized. And these are centered on three main goals: their workforce, professional development, and community health. So they are going to be moving forward with further work on their strategic plan, but that's moving forward. So this is a slide again on what to do to help get the word out to our residents about the opportunities through the ACOFP Foundation. So getting involved, what can you do to get involved in the ACOFP? You can write an article for the osteopathic family physician, create a patient education handout, submit a blog, record a podcast or webinar, or speak at an ACOFP event. And I know there's a lot of members in here that are already working on ACOFP committees, but if there's a committee that you have an interest in, we encourage you to reach out to us as far as getting more information and opportunities to engage in committees. As far as the coming year and what my focus is going to be on, I already talked about just promoting our specialty and working on opportunities to get that out into the public. I really do think that family medicine's time has come. I get tired of hearing about how the physician extenders are taking over family medicine. There is a strong role for family medicine. I believe that every person should have a family physician. I also believe that it's time for full scope family medicine to take center stage again. And I know I'm speaking to the choir, especially in this state, but our patients expect their physician to deliver their care. They get tired of being sent to every ologist around. They want us to deliver their babies. They want us to give their immunizations. They want us to do their chronic care, and they want us to provide their end-of-life care. They want us to set their bones, and we're all trained to do that. So, I think it's time for us to start promoting full scope family medicine to our students and to our residents, and encourage them to provide that type of service. The other thing that I really hope to focus on and see take a foothold is OMT. That's a wonderful gift that we are all trained to give, and it's something that our patients have the right to get. And it's disheartening to see that less than a third of us actually provide that service to our patients. It's something that I think we're shortchanging ourselves on. I know I did OMT in my practice. I documented it, and I coded for it, I billed for it, and I got paid for it, and I got paid well for it. So, I know there's some challenges depending on regions, states, and just information. I think, what the ACOFP needs to do is help overcome those challenges where there's barriers to physicians being able to use OMT. Again, Dr. Lewis and I were on a call the other night where I kind of challenged the Knowledge, Learning, and Assessment Committee to look at ways that we can use OMT to help some of our diverse population, in particular our LGBTQA patients, who are very resistant to getting health care in general because they don't trust physicians. But we are trained, one of the very first things that we learn to do as osteopathic physicians is be a patient. If you think about it, practically on the first day of medical school, we were taught how to be a patient because we had to be the patient for our fellow students to treat us with OMT. So we learn how to feel comfortable. We learn that trust to allow physicians to put their hands on us and approach us. And because of that, we have a better ability to form that physician-patient relationship. And in somebody who's very resistant to having that physician-patient relationship developed with them to begin with, there's another opportunity for us. But just OMT in general, it's a wonderful tool. We know it works. We know the evidence is there to support it. There isn't any reason we should be using it. So we need to find out what the barriers are and try to overcome those for our members, our family physicians, and mostly for our patients. So with that, Dr. Cori, I will turn it back over to you. I really appreciate the opportunity to come and visit with you all, and I've really enjoyed my time here. Thank you.
Thank you. Does everyone have a copy of the last year's minutes at their table? There should be some on the tables. If you take a minute to look over those, and then I'll take a motion to approve. Do I have a second? Everyone in favor? Okay, and now Dr. Lewis will give us the treasurer's report.
Okay, here's our financial statement overview. So our beginning balance for the 2021-2022 year was $86,528.09. With our deposits and our expenses, our ending balance comes to $87,408.09. Here's our detailed statement on that. There are two places that you'll see a variance where we spent more than what was budgeted. One is on the student delegate should be for 2022 House Congress of Delegates. It's actually a really exciting problem to have. This is the first year that we got to welcome our students from Cherokee Nation, OSU-COM, to participate in our Congress of Delegates for ACOFP. So we had additional student delegates that we weren't anticipating, and we've adjusted that going forward. The other variance is just on the ACOFP Foundation and the timing of when I wrote the check for next year. I paid at the conference, so it came across on this one. So our total expenses were under budget. And then our budget for the 2022-2023 year to account for the additional residents and continue with what we're doing. So with that, are there any questions on the financial report or the budget for next year? So we'll just need to have that approved. So we'll look for a motion for approval. Okay, grab a second. Okay, all in favor? Any opposed? Okay. Okay, so our next part is our Congress of Delegates report. So this was the first year since COVID started that we did meet in person for our Congress of Delegates for National ACOFP. We met down in Dallas. We had a decent show. We would have liked to have seen more physicians there on the attending physician side. I understand with COVID, we still had some issues with some organizations not allowing their physicians to travel. And so if there's anybody in the future who's wanting to participate as a delegate, we would love to have that. Just let us know afterwards, and we'd be happy to talk with you about next year. We'll be in Disney, if that's an appeal to anybody. We did have a strong representation from our students and our residents, which we were pretty excited to have that and have our future family physicians involved with us. So we had both of our resident slots filled and then 2 each from OSU-COM and OSU-COM Cherokee Nation. Dr. Williams talked about a lot of the things that we discussed with ACOFP there, and then just the policies to enforce all of those things. Nothing groundbreaking really that happened at this one. So with that, it was great, and we'd love to see you at our next conference. The next part is the nominating committee report. So on the screen, it's our list of slate for next year from the nominating committee. That should be Amanda Carey on there. And for president, President-elect Glenda Tiller, DO, Vice President Matt Else, DO, Secretary Treasurer Rebecca Lewis, DO, and then our trustees, Dwayne Kaler, DO, Trudy Milner, DO, Tim Mosier, DO, and Monica Woodall, DO. Glenda Tiller and Matt Else have accepted the nomination. If the group approves that, they were not able to be here today because of previous, one is on service and one had a previous engagement. So with that, I would just need to know if there are any other nominations. Hearing none, do we have a motion for approval in a second? Okay, all in favor? All right, so with that, here are our upcoming officers, and we look forward to a good year and trying to get our students involved, being back on the campus this year and having the option to go and engage with the students and the residents, and trying to just kind of reignite our organization since we had a nice little pause put on it with COVID. So if anybody has any ways that they'd like to get involved or like I said, participate as a delegate for the Congress, please come up to us afterwards and we'd be happy to talk with you about that. Okay. So is there any old business that we needed to discuss? Okay. New business, we have our election of officers, now our oath of office.
Yes, Dr. Carey, you need to stand up. So thank you, ladies and gentlemen. It's indeed an honor to induct Amanda Carey DO as the new president of the American College of Family Physicians, Oklahoma State Society. We're grateful for the leadership of a physician of such strong commitment to our profession. Amanda Carey DO, you have been selected by the members of the American College of Osteopathic Family Physicians at Oklahoma State Society for the office of president. With this office goes the responsibility of the success and objectives of your association during this year. You're charged with the responsibilities of providing leadership before educators, public health officials, and agencies of health and welfare. You are charged with the responsibilities of naming able committee leadership that will diligently carry out the activities assigned to the committees and to successfully promote the programs of the State Society in such manners that its goals will be achieved. I know that you will serve your members well and accept these responsibilities to the utmost to bring great credit to our profession and to our college during your year in office. Will you please raise your right hand and repeat after me? I hereby affirm that I, Amanda Carey DO,
I hereby affirm that I, Amanda Carey DO,
will do all in my power
will do all in my power
to uphold the Constitution and bylaws of the American College of Osteopathic Family Physicians, Oklahoma State Society,
to uphold the Constitution and bylaws of the American College of Osteopathic Family Physicians, Oklahoma State Society,
and during this year
will
carry out the duties of the president to the best of my ability,
will carry out the duties of the president to the best of my ability,
and that I will deal justly, fairly, and impartially with all matters that become before me.
and that I will deal justly, fairly, and impartially with all matters that come before me.
To do this, I solemnly pledge myself.
To do this, I solemnly pledge myself.
Congratulations.
Do I have a motion to adjourn? I look forward to serving in this position. I'm looking forward to the new board members coming on as well. I've worked with them and trained some of them, so I know they'll do a great job as well. And I'm looking forward to us being more active in the community again and getting more involved with the medical school and just, promoting our family medicine again. So that I'm looking forward to this year. Now do I have a motion? Oh, okay. Yeah.
Our next speaker is Rebecca D. Lewis, DO, FACOFP. Dr. Lewis is a 2012 graduate of Rocky Vista University. She completed her family medicine residency at St. Anthony Family Medicine Residency in 2015. She is the current president-elect, as of about 90 minutes ago, of the Oklahoma Osteopathic Association and is a governor of the ACOFP Board of Governors. Dr. Lewis currently practices full-scope family medicine with obstetrics at St. Mary's Hospital in Enid, Oklahoma. When not at work, Dr. Lewis occupies her time with her husband, Tyler, 2 children, Owen and Gianna, and her 2 dogs. Welcome, Dr. Lewis.
Okay, thanks everyone. So the lecture that I have, I don't actually have a PowerPoint for it. I do have a little handout that I can have Audrey link to the app so that you guys can have access to that. So today we're going to talk about perinatal mood and anxiety disorders. And I know probably the ones that are left lingering in the room are the ACO or the family physician, since we just finished the ACOFP update. Even if you're not a family physician, this is a really important topic to know, because even if you're not treating obstetric patients in your clinic, you're still going to make decisions that are really critical when it comes to perinatal mood and anxiety disorders. So the reasons that everybody needs to be aware of this and be prepared to treat these in their practice is that for some of you, you may be treating the mental health disorders for a patient during their pregnancy. You may also be the one who is taking care of a patient before they know that they're pregnant or before they establish care with an obstetric provider. So most patients don't actually see their OB for their first appointment until they're 8 to 12 weeks pregnant, and a majority of their organogenesis has already occurred. So the chance that a medication that you prescribe even a year before they become pregnant could have an impact on a pregnancy is very high. And so that's why it's a very important thing for us to know. So preconception, counseling, and selection of medications is huge. And then also the fact that you're going to be managing patients who are in that peripartum period, in that postpartum period, who may also be breastfeeding. So even if you're not managing pediatric patients, not managing obstetric patients, you still have a big impact on what's going into that infant's body by what's going in through the breast milk. So very important areas that we have a big impact on this. As we go through this, we'll talk about the different screenings for perinatal mood and anxiety disorders, becoming aware of some treatment options to use or to avoid, and then just some special care considerations that we need to have in this population. The 4 main areas that fall into the perinatal mood and anxiety disorders are going to be depression, anxiety disorders, that's including your generalized anxiety, your PTSD, situational anxiety, the list goes on with that, bipolar disorder, and schizophrenia disorders. As far as screening, ACOG recommends that every patient who is pregnant be screened in that first trimester, and then again throughout the pregnancy, or first trimester or first visit. Sometimes we don't get them in the first trimester, but at that first visit, they need to be screened for depression. They need to be screened for depression again towards the end of the pregnancy, especially if there's a clinical concern. Screening a birthing parent for depression at a newborn check is also a very important thing. So Oklahoma state law actually says that we're required to screen, if you're providing pediatric care, you have to screen for caregiver depression in that first year of life. It only has to happen once, but it does have to happen. So it is a billable code. The code for that is 96161. I think Medicaid reimburses like $8 for that. It's not huge. It is something that can be done now. But it's also a very important tool when it comes to giving appropriate care for those pediatric patients and making sure that they're in a home that's safe and stable. when you screen these patients, the most important thing that we need to make sure that we're doing is using a validated screening tool to actually evaluate these patients. Asking the patient, hey, do you think you're having any depression? And them saying no, that's not adequate screening. We need to pull out a PHQ-2, a PHQ-9 in your postpartum period during the Edinburgh or one of the other postpartum depression scales, and making sure that you're adequately testing the patients, because what they think is depression and postpartum depression may not be what's accurate or what is actually a problem. For instance, I had a patient just this last week. She cried through the entire prenatal or newborn visit, just tears the entire time, talked about how anxious she was. She goes, but it's not postpartum depression. Okay, she's like, I'm not sad. I don't feel like I want to smother my baby. I still want to take care of her. I still want to be here. I want to be a part of her life. I just cry all the time and I don't know why. So we talked about postpartum anxiety. We talked about postpartum depression, how it can present differently for different people. In her mind, if I just asked her, she would have said, no, I'm not depressed. Her Edinburgh score was 19. So she had severe postpartum depression on the validated screening tools. So the screening tools are huge and can really help you catch some patients that may just be dismissing their symptoms as normal postpartum baby blues or just normal, you're tired and crazy after you have a baby. We hear that a lot. And so having those tools are really important. Anxiety, same thing. You can use your Edinburgh, the GAD-7, the Beck anxiety depression or anxiety tool, and then your bipolar and schizophrenia screening. Those are not ones that are routinely recommended, but if you do have a suspicion in the patient, using like your mood disorder questionnaire or the Young Mania rating scale for that. So some general considerations when you're taking care of these patients. One of the biggest things is just knowing that as far as pregnancy and breastfeeding and medications, there's not a lot of data. We're getting better. We've got registries. We're getting better data. Most of our data is retrospective. Because of that, everything that you do just needs to be shared decision-making with that patient. So saying this is, a category C, we don't have a lot of information, but if you do look at the studies that we have, here's why I think this would be a safe and accurate good medication for you. But here are the risks. And again, we don't have a lot of information, but we may have enough based on these studies. And a lot of times the patient will tell you whether or not they're comfortable with that. Having that discussion with them in the clinic is also huge. I'll tell you, there's been times that I'll think a patient is on board with it. We'll send them out with medication. They'll come back for their next 4-week appointment. And they'll say, well, I never started that Zoloft because my friend, somebody told me that that's not a good medication in pregnancy. And they'll go to look online and they can't find the information on Dr. Google to support using it in pregnancy. And then they just kind of go untreated for that whole time. So again, making sure you have that information in that discussion is huge. If you do have a patient who's pregnant that you put on a medication, check to see if there's a registry for that. So one of the apps that I use a lot is called Infant Risk. It's one through the same people at Texas Tech that made the Meds and Mother's Milk book. In that, it has a link to the registry information. So if you have a patient that you put on ziprasidone during the pregnancy, then you can tell them to sign up for the registry, and then they'll gather more information so that we've got better information as we go along. The other thing to know is just kind of reassessing where is the patient in the perinatal process. So are they in a specific trimester? Are they breastfeeding? Even how far into breastfeeding are they? And then also asking the patient, is the baby getting breast milk? Because I've had patients before too that they'll say, well, I'm not breastfeeding. You ask them some more questions. They are pumping, but they're not putting the baby to breast. And so because of that, they kind of lose that association of, oh, I should worry about what's in the breast milk, because they don't think about the breastfeeding process there. The other thing that when I gave this lecture last time, the most important thing I want people to take away from this lecture is to not subtherapeutically dose your patient. If you have a patient that you're subtherapeutically dosing, you're still giving the risk of that medication to the developing fetus, but you're not adequately treating the patient. So if you're just giving them low doses of a medication and they're still insanely depressed and possibly suicidal, you're still exposing the baby to the medication, and you still have those risks that could come with it, but you're also risking all the things that come with mom. The other thing to know, medication is on the subtherapeutic dosing is that higher doses of medication are often needed in pregnancy compared to a non-pregnant patient.
With the volume distribution increasing, with the physiologic changes that happen through the pregnancy, the doses that are needed are often quite a bit higher. So again, that subtherapeutic dosing can have a really big impact on these patients because they're needing higher doses already. Monotherapy at higher dosing is also going to be preferred to polytherapy at lower dosing. So if you do have a patient, say they're on sertraline and you think, okay, maybe if we go up just a little bit higher on this one, we'll get some better improvement, that would be ideal compared to adding another medication and then having the potential of 2 sets of risks for the mom and for the fetus. The other thing to know is that untreated perinatal mood and anxiety disorders really increase the risk of complications for both the pregnant patient and for the developing fetus. Because again, I mean, if you have a patient who's suicidal or attempts an overdose during the pregnancy, that's going to have some severe implications for the developing fetus. There's also the risk of just not getting adequate prenatal care. A lot of times our patients who have severe depression aren't coming for their appropriate prenatal visit intervals. They're not eating appropriately. And so then again, that's having some really big impact on both mom and baby there. The medication categories, the big thing on those is checking your apps and finding out, because these categories are changing because we have such great data and with the registries now. Medications that had been category C are now moving to category B, and we're seeing or category D. We've got things going in both directions that we thought were safe and now they're not. So making sure to just really stay up to date with something that's constantly changing, like Hippocrates or infant risk or LactMed, is a really good thing to do for that too. So as far as your specific disorders throughout pregnancy, so depression is going to be the most common one. Again, our scales and our testing to find out whether or not there is depression are really important, because 70% of women will report at least one symptom of depression during their pregnancy. If you think about it, fatigue, lack of focus, the mood fluctuations. I know when I was pregnant, I had a lot of those things. So now if I had taken a depression score with that, I would not have met the criteria for it. But if you had asked me at any day, there may have been a yes answer or there may have been a no answer. So the depression symptoms are constantly there. 10 to 16% of patients will actually have a diagnosis of depression, and so treating that is going to be the big thing. Now, most of the medications that you use in a non-pregnant patient are safe in pregnancies. SSRIs are still your first-line medication. The one caveat to that is paroxetine. Do not prescribe paroxetine in pregnancy or to a patient that is considering pregnancy or a patient that you don't think will not become pregnant. So paroxetine has been shown to have a lot of cardiac malformations in the developing fetus, and it is just a very unsafe medication for pregnancy. It's one of them that actually does fall into that category D, and so it is not recommended in pregnancy at all. Your risks with your SSRIs, sometimes we'll see some jittery babies. There is a slightly increased risk of the transient tachypnea in the newborn, and sometimes they'll have a weaker cry, poor suck reflex, but typically the SSRI withdrawal in a newborn is very mild, and it's one that they, with just mild symptoms like Tylenol if you need to, or swaddling and the low stimulation, typically they come past that within a few days. SNRIs and atypical antidepressants are both considered safe. TCAs are actually the most well-studied medication in pregnancy and are considered very safe, and the safest class in pregnancy. They have a lot of side effects, though, that a pregnant patient is not going to want to add to what they're already dealing with. So constipation and fatigue are very high complications in pregnancy. If you add a TCA to that, it's going to be even worse. So it is a safe option. You just, again, have to talk about the risks and the benefits with the patient. All of the depression medications do have that risk of some withdrawal type symptoms in the newborn, and the management typically is just that low stimulation and swaddling. ECT therapy is recommended or is safe in pregnancy. So if you have a patient that is completely treatment resistant and needing electroconvulsive therapy, it is appropriate. I personally don't prescribe it or do that. They're in psychiatry's hands if we're at that point, but it is an option. The cognitive behavioral therapy is also a great option in pregnancy, but it does take a lot longer for that to be effective. And because of that, it's not it's not really recommended for that to be your first line solo therapy. It's great to use in conjunction with medication in pregnancy. The other medication that is newer to the market is the brexanolone IV. This is the one that's specific for postpartum depression. It is an IV, it's administered over 60 hours. And so it's a patient that you do have to put into the hospital to get the medication. But if they're severe postpartum depression, they usually are walking out of the hospital in a really good place. So it's a great medication. It came out right as COVID was really ramping up, and so our hospital spaces were down. We haven't seen a whole lot of utilization of it yet. I do think that we'll start to see some more of that now that bed access is better availability there. As far as your anxiety disorders, there is up to an 18% prevalence of anxiety in pregnancy. So again, treating similar to depression as far as your SSRIs and everything that you would use for your generalized anxiety disorder. For acute anxiety, the biggest thing is that benzodiazepines are not indicated. They are not safe in pregnancy. They put them more into that category X with pregnancy. And that's because there's a high risk of neonatal withdrawal. You can also have what's called a floppy baby syndrome. And they actually can have those symptoms for up to 3 months postpartum. Floppy babies are never good babies. Nobody wants a floppy baby when they deliver that. So having that is a really big thing. It also has a high risk of cleft lip and cleft palate deformities in the newborn. So benzos, not safe. Do not use them in pregnancy. If you have a patient that's on benzos, trying to get them off as soon as possible when you find out that they're pregnant or even in that preconception phase. Your medications like buspirone, hydroxyzine, and propranolol are all very well studied and very safe. The one thing I caution people with propranolol is just watching the blood pressure. If you get that blood pressure too low, you're going to decrease the perfusion for baby, and that could cause some big problems too. So as long as you're not getting too low on that, then you're good. The other thing on benzos is that they're not safe in breastfeeding either. So benzos do have a high transmission through the breast milk, and that's going to, again, have a really high risk of infant sedation and infant withdrawal and everything along that we would see with the benzos. Bipolar disorder. So bipolar disorder is a big one in pregnancy. The symptoms decrease in pregnancy. It's one of the few that the body seems to have a protective benefit against. The problem with, the problem with bipolar disorder is that it will often come back with a vengeance after pregnancy. So having that pre-delivery conversation with the patient as far as risk stratification and planning, and how are we going to help keep you from becoming manic, or what are our plans as we get closer to delivery, is going to be really important on that. If you do have a patient that still needs medication in the pregnancy with bipolar disorder, lithium is one that we need to try to avoid. There's a really high risk of cardiac malformation and arrhythmia and withdrawal in the newborn, as well as lithium with pregnancy. It's in the labor process. When you give the IV fluids and the shifting that's happening physiologically, it can lead to acute lithium toxicity in the pregnant patient. So it's one that you have to be really cautious with. Even if they've had a stable lithium level and then they deliver, it could be catastrophic. The recommendations on lithium, again, a lot of my patients would be in psychiatry's hands at this point, but I'm also in Enid. We don't have a lot of access to psychiatry, so I have patients that aren't going to go, and they're going to just keep coming to me. But if you do have a patient who is rapid cycling bipolar, you have tried everything, you are exhausted everything, and that is where you are, then the recommendation is to very sparingly use lithium. But again, it is one, if you can avoid it at all costs, it needs to be avoided. It also should be avoided in breastfeeding. It's another one that can cross into the milk and really have an impact on baby. Valproate and carbamazepine are also ones that should try to be avoided through the pregnancy. They do have a higher risk of neural tube defects with that, so trying to make sure you're avoiding those. Again, if they're ones that are absolutely necessary, then you can supplement with higher doses of folic acid, and that can help. But you still have a high risk of neural tube defects. So it's one that, again, trying to avoid that if possible, but with bipolar disorder, we're often left without many options. Lamotrigine is the one that is generally accepted as safe, and it's pretty well studied in pregnancy, and it's one that can be used with that. It's also safe in breastfeeding. Valproic acid and the carbamazepine are also safe in breastfeeding. Well, they're not preferred in the pregnancy, they are okay in the breastfeeding portion. And then again, the electroconvulsive therapy is another option in this group. Schizophrenia is kind of a unique one when you're looking at pregnancy. So it's a fairly low rate, only 1 to 2%. It's one that though has the highest comorbid or highest mortality rate in the pregnancy, and then the highest rate of complications for baby postpartum. Even with adequate control, we typically see that there's lower birth weight infants. We also see a high rate of pregnancy neglect, where the patient just ignores pregnancy. They don't think that they're pregnant. They can't comprehend the fact that they're pregnant. With that, we see a lot of infant neglect and infanticide in our patients who have schizophrenia, who's not well controlled at the time of delivery. So these are another group that making sure it's very well controlled and very close follow-up postpartum, just to help make sure, again, that that baby is in a safe environment as they're going home. Typical and atypical antipsychotics just need to be used on a risk-benefit and alternative basis. These are the one category I would say absolutely go to your resources first, because these are the ones that there are registries for every single one of these medications right now. And so we are seeing that they are changing by the day, which ones are recommended and which ones aren't. Even within the same class. So even within the atypicals, you can have two that are very similarly structured, and we'll see that one is safe and the other one isn't. The ones that we've got the best research and the best data on right now is that quetiapine has the least amount of passage through the placenta. So it's one that is generally considered safe for the fetus because it's getting very low passage with that. The other one that we have is olanzapine, has got some actual random controlled trials with that one and showing quite a bit of safety with olanzapine. So those are the two that if you needed one, I would really try to rely on those. And then when it comes to breastfeeding, most of the typical antipsychotics are not safe in breastfeeding. So in those patients, there's a high rate of transmission. They also have a pretty high rate of decreasing the milk supply. So those are ones that we try to avoid. The atypical antipsychotics are considered safe in lactations. So when it comes down to those being the way that you kind of decide which ones you would want to try to use. So as we kind of wrap up here, again, the biggest things that I just stressed to everybody is making sure that our patients are adequately being dosed, that we're making sure that we always just pause and think, does this patient have a uterus? Are they fertile? Are they not yet menopausal? Do we need to consider that this patient could become pregnant? Even if they're on birth control, there's still a good chance that they'll stop taking that birth control. So making sure that any patient with a functioning uterus is considered preconception until the time that it's not. So keeping that in mind. Screening those patients, and then really relying on those resources as far as getting the most up-to-date information on which medications are getting more information with those registries to make sure that we're getting the best things that we have for our patients, and then not subtherapeutically dosing them. So with that, I hope that this was helpful, and I'm happy to answer any questions that you may have. I have not. We don't have any ketamine clinics in Enid, so if I did, they're usually with psychiatry and. We have one at the hospital, or the two ones at the hospital. I guess that's true, yeah. I've not tried those. I've not read anything specific to those. Yeah, I've heard they work great for people. I'm not sure I'd have to look and see on the safety of ketamine in pregnancy. Any other questions? All right, well, I'm happy to stick around if you do have any questions. The Legislative Bureau meets here in a little bit. So if you have, please welcome to come back and talk to us about the legislative stuff, and we'll be going from there. So if not, we do come back at 8 o'clock tomorrow, and we'll see everybody then.
Well, it's about 5:15. We're sort of waiting on Jami Longacre, a lobbyist. She just left the Capitol to come over here. Most of these slides that are up here are hers. So My co-chair, Dr. Mosier, and I here, we thought we would just hit a couple of high points till Jami gets here, because she's got a presentation. And I sort of at the business meeting, this year we didn't have a lot of scope bills. In fact, I think there was one scope bill that they let through. And that was it. And that was because they had a new Senate Health and Human Services, Dr. Paul Racino from Southside Oklahoma City, and he said, I just don't want to hear any this year. And we met with him back at DO Day here, and he said that now next year is going to be a different story. So it'll probably be pretty contentious coming up. We've spent a lot of effort and time this year on the managed Medicaid. So many of you take Medicaid, and even the employed physicians, it's going to affect. Basically, in a nutshell, what it is that the Healthcare Authority wants this managed Medicaid. And they want to go, and they're going to go from a fee-for-service to an outcome-based. And I think that's where y'all have to really be careful what'll happen. And that's what we've tried to do. We've had a coalition working on this, and we have put out 10 points, some of the main ones that they do not want. When I say they, this is the Healthcare Authority and the governor. And, since the day he got elected, he put together some advisory groups, and the hospitals and AFQACs and all that, and they've decided that being we're 47th in healthcare, he's going to change that. And so what we've been doing for Medicaid hadn't worked, and that's why throwing it over and going to bring in the insurance companies and do the managed Medicaid. Basically, if you guys get tired of hearing what I'm saying, that's fine. Just let me know. We'll sort of wait until Jami gets here. But anyway, one of the big things that we want, and Allison and I, Dr. Bushman, and Jami met with Representative McIntyre, Healthcare Authority, Hospital Association, OSMA, us, and Family Practice Monday out at the Capitol, and spent about an hour and a half. And the Hospital Association they have now bought into this, and they're one of the driving forces on this. Probably a big reason for that is the fact that they're going to change from the Medicare rates that we've been getting, and now the hospitals is going to get the average commercial rate. So now they're doing this under the guise that this brings in more money to the state because they can do some matching federal funds. But the providers, and basically none of the providers, physicians, nurses, mental health, ambulances, none of the providers are really on board with this thing, but they're going to cram it down our throats. And it looks like, and Jami should have more idea when she gets here because they've been meeting on this afternoon, but, about the best it looks like that providers will get will maybe be Medicare, Medicare rate. And then an incentive over that. And you all know how incentives work. If they work pretty good if you don't set them too high, but you can set them high enough that nobody ever hits their incentives. So you're not gonna benefit, we don't think. And that's what we've been fighting for. We don't think you'll benefit as much with what's going on under this. The hospitals are gonna come out like gangbusters. And the thing that we're concerned about too is the physicians who don't work for the hospitals, So we asked for the any willing provider to be put in there. And Corbett, who runs the healthcare authority, said, well, no, we don't, we got some bad physicians out there. And so we don't want to put that in there, any willing provider. And we tried to explain to them, we got docs out, especially in rural and even here in the metro area, who are not hooked up with a hospital and who maybe will be left out of the contracts. And that's the other thing. Well, what about them excluding you? Say you're doing Medicaid now, but if you don't belong to community care or Integris's group here in the city or something like that, what happens then? Why that just wouldn't happen, they say. Well, we asked them to put a lot of this wouldn't stuff in the bill. Well, we can't put it in the bill because we don't know what CMS is going to do, and they have to sign off on everything. And then, change a lot of these mays to shall. Well, we can't do that either because, CMS, we can't have our hands tied. So these are just some of the issues that this has taken a lot of our time, a lot of Allison's time. Coalition meets every week to talk about managed Medicaid and how to protect the providers. And one of the things we asked for Monday was, right now the overhead is 4.7% is all the overhead is. And they have written it in now, the overhead can go up to 15%. And we said, well, why should it be more? That's just going to take money from providers, is where this extra money's going to come from. And the response was, Corbett's response was, well, because we told him what a good job they were doing at 4.7% overhead. He thanked us for that, but he said, that's probably one of the reasons that we're having such bad outcome, because we don't charge enough and have enough services so we get a better outcome. And we can't expect to bring these insurance companies in here to do it, at that rate. So therefore, to get, quote, better outcomes, we got to give more overhead money. Doesn't make sense to me, but that's the way they look at things out there. So maybe it's like Swadley's barbecue, the foggy bottom stuff that we've been reading about the last few days. Yes. Sure, Allison can get what we asked for to make sure that it was in the bill. They told us that because with money, we said they're not there. Well, they said, well, 6 through 10 is in there. And we said, well, 1 through 5 is the most important to us. And of course, they was wanting everybody to sign off right there. And so we told them, we said, well, you put 1 through 5 in the bill, and then we're good. We'll all sign off on this. Well, no, we can't do that, because one of them is any willing provider, and another one is that you don't cut anybody out. And we wanted to have on all the advisory councils, and we wanted physicians on there, like for appeals and things. And we wanted also to be so we had input. Okay, yeah. To provide input. We wanted the associations to recommend physicians to be on there. You know, the healthcare authority, as you well know, took off some people. The governor took them off when they voted against this. And then he put people that I don't even think do any of that. Anyway, here's and I'll just briefly summarize them. Number 1 was any willing provider shall be allowed to participate in the ACO. Number 2 was physicians and mid-level providers located in rural communities that do not have the opportunity to participate are permitted to participate as a contracted provider and paid on a fee for service basis. Number 3, physicians can be paid on the individual claim basis and at a rate that would allow them to continue to participate. And we said, which is the higher of the Medicare fee schedule plus 50%, or the average commercial rate established by an independent agency, such as the workers' comp system, which uses one out of New York, and automatically adjusted for inflation, whichever is greater. Number 4, there must be protection included to preserve the reimbursement and rates paid to Oklahoma teaching facilities and to sustain and add to the residence positions at each institution. And number 5, physicians and providers may contract with multiple ACOs, not just one. Number 6, clean claims get paid within 14 days. Number 7, a grievance committee formed to oversee who addresses this and impose penalties should be a provider grievance committee. Number 8, private entities contracting with the OHCA should be organized in Oklahoma rather than out of state. And they should be not-for-profit, tax-exempt, physician or provider-led accountable care organizations. And then all the guaranteed language in the prior bills that we worked on should be in there. And number 10, the prior authorization structure should be streamlined, standardized, and a standard formulary. So those were what we asked for. Number 11 was the standard drug formulary, so that each ACO or MCO doesn't have a different formulary you have to adhere to. And like I said, they said, well, the last ones are in there, but the first ones they wouldn't agree to, the healthcare authority wouldn't. So that's sort of where we're at on that. I don't know how we understand today that the governor has said that he won't sign a budget unless they come up with this bill for him to sign before he'll sign the budget. So that's put all the people under the gun over there at the legislature.
Dr. Young, we have an online question.
Yes.
I won't be able to credential with any private insurance, so will I essentially be forced out?
That is what we're saying, any willing provider. That's why we want that in there. So that if you are willing to follow the guidelines or the rules that are set up that everybody has to follow, you can see it. You can be a part of this. And that's why that was number one on our list, for that very reason, so that they couldn't exclude people for willy-nilly reasons, so to speak, as some of you know what they do to you. Was there another question back here before I go on? Okay. Well, now I can quit rambling. And we have, well, the chief is here, Miss Longacre, and she's going to, here's your slides if you want them. Okay, and there's your little, that's forward and that's backwards. You can look there or over there.
Okay,
So,
cool.
Go ahead.
This is great. Well, hey, good afternoon. Sorry, I can't really see. So, almost stand. Yeah, I'll put it up there if you don't mind. And Allie or Dr. Young or Dr. Mosier, please jump in at any time. And my apologies. This week is a deadline. And so the legislature is still meeting. And so I just wasn't able to get away as quickly as I had anticipated. But we are thankfully in this being the deadline day for bills to get in the opposite House of Origin. And so we're hopefully they'll be finished in the next couple of hours over at the state capitol. So my apologies for not being here. Have you already, I was just gonna hit a couple of high points on the budget. It's a good budget year, and the reason that we are focusing on the budget always is for Medicaid funding, and a robust budget means no cuts to provider rates, Medicaid funding, and this year there's kind of a glut of dollars, but a lot of that is just a huge amount of one-time monies that are still there. That are there kind of as carryovers, and a lot of that was used last week for what we call Project Ocean, which was the House Bill 4455, which is the big economic development project up in the Mid-America Industrial Park and Pryor. So they did set aside quite a few one-time dollars for that project. But we have certainly seen a robust budget, and we'll certainly keep an eye on that. Also, any funding that goes through OSU-COM also impacts the med school and the residency programs in the hospital. And so we always keep an eye on those things as well. And I think from my last conversation with Dr. Stevens and Jessica Russell and those that are advocating on behalf of OSU, that things seem to be on track for those funds. So I'll start on just a few of the bills that we've been working on this year. Senator Racino there was a little bit of shakeup at the end of the year. Senator Racino moved from vice chair of Senate HHS to the chair, and he just kind of and Senator McCourtney, who was our HHS chair last session, moved to floor leader, and Kim David's running for Corporation Commission. And this termed out, so she's kind of moved out of the picture for the moment. But I will say that Senator Racino kind of put a line in the sand and said, "Hey, we're not going to do any scope bills this year." We met with him on our OO day at the Capitol. I think Dr. Mosier and he hit it off. They have a bunch of Navy flying things that they were clearly had some synergies on. But we've got a lot to teach him over the next several months this summer. I shouldn't say teach, but it appeared to me And I think those of us in the room and the many conversations that we've had with him, that he really doesn't, he believes that that the mid-level should have even more authority maybe than they already have. I mean, that is yeah, and that's coming from his military background. Dr. Young just pointed out, because I think there's maybe a little bit more leniency when you're practicing in a military setting. So we really, kind of narrowed it down to a couple of death certificate bills for that PAs can sign death certificate bills. There was also a bill that, I'm telling you the bills that are kind of moving forward. Death certificate bills for PAs, some VA language for PAs, and then physical therapists. There was a deal struck that allowed the physical therapists that have a doctor of physical therapy to use some of the same terms that some of the other, underneath those definitions of who can call themselves a doctor of physical therapy. But outside of that, we killed a couple of PT bills that just would not require any kind of physician referral. We killed multiple pharmacy bills that would have allowed pharmacists to do not only treating, but also some diagnosing inside the pharmacy. There were a few nurse practitioner bills that were really that egregious the way they were filed, but they were certainly just vehicles to move in certainly different directions. And then also, we continue to fight and defeated the PA bill. I mean, it never came up for a vote, but this is kind of that carryover from Senate Bill 1915 from 2020, that they're pushing not only for more leniency on prescribing Schedule II opioids in not only in a hospital setting, but even outside of the hospital, no longer on site. And then the other thing is their interpretation of the law, which is different than ours, that one physician should be able to supervise or delegate an infinite number of PAs. And we just continue to argue with them on that. And there's been no change in any of that legislation to this point. So I think next year we're going to really have, and there were no CRNA anesthesiologist challenges this year at all. So I think we're going to really have our hands full next year if we are not, that's the VA bill, if we are not ready to really do a good job in the country, in the districts, in the legislative districts, educating legislators about the importance of having physicians in rural areas and physicians in underserved areas and physicians in metropolitan areas, and that mid-levels are certainly welcomed and a great part of everyone's practice, but they cannot replace a DO or an MD in these settings. And that's what I think is kind of frustrating, at least for me, because a lot of the rural legislators are like, well, it's hard to get rural docs, so we just gotta, we're gonna continue to advocate for the mid-levels. And that is really it's frustrating from our vantage point, certainly from your all's vantage point, because I'll tell you, they come out in numbers. I mean, it's amazing how many calls and letters that will come in from nurse groups, PA groups, et cetera. So I think that's going to have to be almost a refocus, if you will, this summer and fall with legislators as we're working on elections and working with raising money for the PAC and helping fund elections to help educate members about the importance of having a physician in their districts. So I think I hit many of these bills that are already dead, that we were able to either kill on the floor, kill in committee, or just were not heard. And most of them were not heard because they just flat did not want to have these kind of big scope battles on the floor. Still, and bear in mind, oh my gosh, there's 3 or 4 pages of them, but The good thing to note on all of this is we went through, this is the second legislature of this session. And so once they finish up here in the next, arguably 3 or 4 weeks, all those bills are dead. I mean, they're dead and we start over from scratch. For this year, we had a bunch of carryovers. We had a bunch of carryovers from last session. So we'll start over from scratch next year. So any questions, comments about scope? I think there's going to be still more activity this summer on attempt at trying to get the medical licensure board to advance rules, or the pharmacy board to advance rules. And so I think we're going to have a not only a legislative strategy, but maybe even somewhat of a rulemaking strategy to help with kind of pushing back on some of those things. So next, kind of under the auspices of the Board of Osteopathic Examiners, we were prepared at the beginning of the session and even last fall for the governor's office to make some attempts to do consolidation, board consolidation. And I would say that members of you all that serve on the Osteopathic Examiners Board, and then also Michael Leake and Allison and others did a great job of educating Secretary Winchester, who is our cabinet secretary over our boards, about the importance of not consolidating those boards. At this point, I think that's going to be something that's going to come up next year. I think it will continue to come up because I got the question this week about car dealers. How come we have a new and a used? Why don't they just come together? I mean, so it's just always looking for almost style points when it doesn't save a penny, it doesn't save a dime. But those are the things that, I think not only legislators, but certainly the executive branch, continue to look for those things. And so those are issues that we're going to continue to have to work on, this summer and fall. So the only bill that really, and then there were certainly bills this year to try to take away any input from the OOA or OSMA or any of the other groups on board appointees. That's been something that we've had a long history of being able to give the governor's office, lists, whether it be the Workers' Comp PA Physician Advisory Committee, or whether it's the Osteopathic Examiners Board, or pick a board. They've been able, when there is a DO designated in statute, to select from a list that's provided by Allison and the board and the executive committee. And so I think that's really something that we want to continue to protect. And we were successful this year, so far. We still have a few more weeks of session, and this is really the scary time when we earn our keep, and that is when things can come out of conference in the following weeks, and amendments on the floor and things such as that, or even things in JCAB. So that's something that we'll continue to also work on. There were some, I think Dr. Young worked on this quite a bit with the Hospital Association on temporary licenses and some of the practices that were used during COVID to be able to almost codify those and be able to use some of those types of practices in the event that we face emergencies. And I think we were all able to get pretty comfortable with the language that we weren't overly concerned about those bills. Surprise billing continues to be it's a topic. It hasn't really been an issue this session. We had a couple of bills carry over, but we didn't see anything on surprise billing. We were fortunate that Representative Bush, who had a price transparency bill last year, came with another vehicle this year to actually put fines and fees if you fail to report certain pricings and have things available on websites. And we were able to kill that bill, and she withdrew it and opted to not move it forward. Just because of we expressed our concern with oversome and burdensome regulations on physician practices. And I think Dr. Young and Allison, I don't know, Dr. Mosier, if you all already started talking a little bit about the MCO. Well, I bet you haven't been rambling. I bet you've been giving them some pretty insightful language or some information. But I mean, this is, we, up until just a few weeks ago, we really felt like nothing was going to happen this year. I think if we rewind to last year, when we left session with Senate Bill 131, which is a guardrail bill, we just anticipated that the governor's office was going to move forward with the RFPs. If you'll recall, we joined a lawsuit with the other medical groups and sued on behalf of physicians regarding the governor's authority. Did he really have the authority without legislative approval to move forward with those contracts and RFPs? We were successful in the lawsuit, and so he had to kind of reset. But I think we mentioned last year, if we think that we're going to continue the same Medicaid program that we've had, really arguably since the 90s, since the last experiment with HMOs, I think we're being a little bit, maybe putting our head in the sand. And we're going to have to, and so I think that's what we've been looking at, or what are some of the ways that if they do move forward, how can that be done that's not just top down, for insurance companies basically setting up tight networks and dictating price and really who's going to see what patient. And because that's really what I think we ended up with, we were going to end up with last year. And so fast forward to April of 2022, we've now seen a bill filed in the House. A new committee floor sub came out last night at about 9:30 that passed off the floor today. That really does, I mean, obviously I think Dr. Young mentioned when I was walking in about our concern about these closed networks and how right now any willing provider is pretty standard with Medicare, it's standard with Health Choice, and it's always been standard with Medicaid. And so this is something that we've certainly been advocating for with Representative McIntyre, and something he says that he's definitely going to address. Now, there was a bit of concern that this was going to be kind of a cram down and we're going to have to take it or leave it, but we met with Senator McCourtney again this week, and he just says this is too, he said there is no way that this bill is just going to become law tomorrow. I mean, we're not just going to accept the House amendments and move forward. So I do believe the next 3 weeks are going to be critical. I think we will be in pretty intense negotiations with the House and the Senate members on some type of conference committee report on Senate Bill 1337. And I don't know what that's going to look like. I mean, there's varying, I think the Hospital Association has signed off on trying to move forward to pull down that average commercial rate, which they say has to be tied to a MCO or a ACO model. We're also hearing from other consultants that say, no, that's not necessarily the case. So we're trying to, get to the bottom of all of that with some of our other healthcare partners. But this is something that, stay tuned, and we're really going to appreciate all your feedback and input, because I think Dr. Bushman, you joined us the other day on a call that you zoomed in for our meeting with Representative McIntyre and with the 3 physician groups with the Hospital Association, OHCA, the Healthcare Authority, and it was. I mean, we are not on the same page, and Allison could speak to this better than I can about the other providers, be it dentist, be it pharmacist, be it behavioral health, and those groups are, nurses even, are very concerned about what the ramifications of this bill are going to be. So I can't really tell you today what it's going to look like at the end, but I don't know if you all said anything different.
No, it was going on today, so you can give us an update.
Yeah.
When you have it.
So, I mean, and we weren't shocked that they were going to move it across. I think the concern is with the appropriations chairs, when you talk about average commercial rate, which we had some discussions about that at the end of session last year, that's the hospital association's estimates are they're going to pull down an additional $600 million. And $600 million, to be infused in, rural and metro hospitals by moving to this model. And so I think that's something that appropriators, that gets their attention. And they're like, how else can we pull down those kinds of dollars in addition to what we pull down with SHOP, to get to upper payment, because we won't be going to upper payment limit. It'll be going to average commercial rate, which is even higher than upper payment limit. So I think those are some discussions that are still, moving forward. And we're just going to really need your input on trying to, how is this going to impact your practices? How is it going to impact your communities? Are you working with hospitals? What does it do to that relationship? We'll lean on Dr. Thurman and others to get, what's it do to the med school? How does it impact? And what assurances do we have on our affiliations with med schools that have an enhanced reimbursement? I mean, that's critical. Those are critical pieces that, I think last year we tried to run language to really protect those and enhance reimbursements, and the Healthcare Authority, quickly got the preprints from CMS that kind of dictated what that was going to look like. And that's, what they're telling us again this year. But hey, it is way over my head on a lot of these federal waivers and working with CMS. So we're hopeful that we can, not hopeful, but, we feel good about our alliances with the other physician groups and the other providers on being able to push back and try to get something that's reasonable and continues to protect independent physicians and independent physician practices. Any comments or questions on that? There's also a tandem bill with it, Senate Bill 1396, which is really the SHOP bill. I think I put that on. Nope. I think it was on that. There it is. The SHOP bill 1396. And this is just they had this bill last year that went alongside Senate Bill 131. But this is how the hospitals, this dictates what the SHOP rate will be and how those funds will be, because that's what the state is requiring for Medicaid expansion, for the hospitals to put up the state match. The state's not putting it up with appropriations. The state's not putting it up with tobacco tax. They're not putting it up with one-time funds. They're saying you all can pay for it with SHOP. So that's the mechanism for SHOP is in Senate Bill 1396. And in fact, in that Medicaid bill 1337, it does. If that bill fails, then 1396 fails. So they're kind of tied together, if you will, from a funding perspective. Yep, that was the old, used to be called the hospital tax and provider fee, and I guess it was passed. Well, it was proposed in 2005, and but it wasn't passed for several years, and then once, I think in 2010 it was passed. But it set up a mechanism where hospitals could actually tax themselves, capped at 6%. I think the rate now is maybe, it's not quite 4, but somewhere in there where the hospitals can actually pay in, tax themselves a percentage of gross revenues, and those dollars are then pulled together. There's 68 hospitals that pay into the pool, and those dollars are used to pull down the UPL from CMS for Medicaid. And that's what helps pay for, that's what got hospitals to the upper payment limit, because the state didn't have the funds to do that for years. And so that is how SHOP has worked for over a decade. So great question, and I haven't even thought about that question in a long time, but that no tax deductions. No, it allows the hospital. So if a hospital was going to get and I don't even know what the percent of Medicare rate is that when they pull down UPL, because I think that may be different for each facility. But it allows them, let's say they were going to get 90% of Medicare to have a inpatient setting or outpatient setting. And by pulling down UPL, maybe that raises it to 125% of Medicare. So it's money. I mean, it is a way to take $1 and turn it into $3 and pull those funds down. And those SHOP hospitals that participate, because not all hospitals participate, but those hospitals that do receive the reimbursement and get their facilities up to the upper payment limit. I may have exceeded my knowledge right there on hospital finance. Oh, 100%. Yeah, it is a mechanism that the nursing homes use it as well to pull. I think they tax themselves at 6%, and CMS has allowed them to it's basically the state doesn't have the money, so the nursing homes or the hospitals tax themselves to become the state match to pull down more federal funds. Oh, and then now we're on any other questions on MCOs or any of that good stuff? So fast forward, Senate Bill 888, that bill we've worked on last year, and then we're gonna looks like we're gonna get to work on it the next couple of weeks. This was the bill that, I think this is the 5th year it's been tried. And this is the bill that would create a pain management registry. So if you have a pain management clinic, then the state is trying to register that facility. And it's really trying to shut down pill mills and trying to figure out who owns what, are there bricks and mortar? And Dr. Young knows all about the opioid issues over the years, where maybe there's been in pill mill situations, almost some temporary offices put up. And so Senate Bill 888, the way it was introduced, was just simply going to be, if you have a pain management clinic, it shall be owned by an MD or DO. And it was just going to be an ownership issue. And then that way, anyone that owned it had licenses that were, you registered your clinic, and then your license was with either the DO board or the MD board. But that has last year, it kind of exploded into more of a Texas model, which required a ton of reporting requirements. And then it exempted the specialties. I mean, it exempted surgeons, it exempted anesthesiologists. And so there was some concern about who's the bill target? And it was really just family practice in general and primary care. Well, and then, that Allison brings up a good point. Then there was some pushback on, we don't really want to control business models for the pain management clinics, and so they pulled out the ownership model. So now we've got a couple of versions that we've been reviewing, and Representative T.J. Marty, who is a pharmacist from Tulsa, Broken Arrow area, and Senator Rob Standridge, who's a pharmacist from the Norman area, are the authors of 888. And we moved it off the floor today just to get it to conference and keep that vehicle alive to have any other discussions about opioids or pain management. And I know that we've actually been working this week with the Hospice Association on trying to clarify some language that pertains to requirements for physicians when a patient is under hospice care. So we're trying to get some clarifications there. And I don't know if you want to speak to any of I don't really know today what we're going to end up with. I mean, we've got the family practice docs, OSMA, OOA, and I don't know that the pain management physicians are really at the table. I mean, I think they're at the table, but I think they're just talking through to their legislators. I don't think they have anyone at the Capitol. But I think we'll be, and we may not reach any kind of agreement at all. I mean, this was just kind of, hey, let's try to see if we can't do something on this. Our question has been, why do we really need it? I mean, do we really need this? It's been 5 years, and since a lot of the e-prescribing and those issues have gone into effect.
Well, the only thing I might say there is what started this, I guess, was the fact that, when the opioid always come about, and there's I'm not familiar with it, but there's evidently a clinic in eastern Oklahoma. There's a clinic in eastern Oklahoma that really rolls them through. And they hire different doctors to run it, and it's owned by non-physicians. And supposedly they've tried for years to close it down and haven't been able to, and so that's what started this bill. There's another one here in Oklahoma City on the south side that's owned by a real estate person, and we've had at least one physician, one DO, that's in prison now for working there, and we've had several lost their DEA license. And the clinic is still open. And so that is, quote, what they're after, is closing these down. We think, some of us do, that, the DA and what have you could close those down, and they don't necessarily have to be punitive to the physicians. Because the way the bills are written that they've been trying to put through so far is just erroneous on any physician that works there. And a big concern then is for family practice primary care, you might fall under that as a pain clinic, just because when you're out in rural Oklahoma or metropolitan area, you got a lot of older patients that are on pain medication. And the reporting requirements are just really, really burdensome. So that's, one of our things was, hey, if one group of docs are going to do it, they all ought to do it. They shouldn't be, you shouldn't just take out the primary care docs, because that's what it's basically looks like it is. So that's just.
Any other thoughts? I would say there's been, I think, a small working group that's been reviewing some of those bills. And so if you're interested, please reach out to Allison just to see if you have interest in kind of being a part of some of those discussions, because they'll be pretty intense over the next week is when Representative Marty wants to try to put us all in a room and see if we can't figure something out on pain. If you would have told me 3 months ago we would be at the end of session with no vaccine bill, I would have said, well, you're crazy. There's going to be at least 10. And ironically, we dealt with probably 70 over the last 2 sessions. And this year we are down to really, 2 carryovers, 2335 and Senate Bill 1225 are carryovers. And then 3145, when I left the Capitol, it still had not been heard. So I don't know that it will even make it today. So we may end up with 2 that are carryovers, and really just haven't heard any, and really none of this is about K-12. It's really all about COVID and COVID vaccines. And so I'm kind of shocked, but it just seems like it's settled down a lot with some of the things that have happened federally. And so we'll keep you posted, but really right now it just seems like there's nothing too much on the horizon. Now, as sure as I say that, there'll be some floor amendment filed or some bill that comes out of conference that does something squirrely, but it just doesn't seem to be a ton of interest in it at the moment. I think they got to vote on vaccine bills, and so they voted and kicked them down the road, and so they can put that on mailers, for the primaries and runoff elections. And so I don't know that there is a ton of interest. And I don't mean to be flippant about that, but I mean, sometimes that's what we see. And anything else, Allison or Mosier or Young, that I'm missing? I know there's been a few other bills that we've talked about at our legislative bureau that have died a very nice and quiet death by either not being heard in committee or not being heard on the floor. And those things don't happen accidentally. We probably do more killing than we do passing, honestly, for the association. And you think, well, does that have a lot of value? You better believe it does. When you see some of the kooky stuff that has been, that can be introduced that you just don't even think about. And you all pointed out a lot of unintended consequences that have helped us just immensely over the course of the last several months. So we're down to the wire. Today's the deadline, and then we will go into conference committees, and then they'll adjourn the last Friday in May. And so I'm going to hit just a little bit on elections, so you can see kind of what we're looking at for this election cycle. You can see there are 13 House members that will be open seats. 7 chose to not seek election or are running for something else, and then 6 termed out. And then 46 House members. So the House is up 101 members. They're up every 2 years, period. And then the Senate has 48 members, but only half of them are up every 2. So we've got 101 House races and only 24 Senate races. So you can see the 46 House members that are running unopposed and did not draw an opponent in their legislative district this year. I know that's kind of microscopic, but I think Megan or Audrey have access to this. They could send it out. And then so 101 minus 46, I mean, those are, so we're already narrowing it down. And so of the 55 House members that still have races, 23 are going to be decided in either on June the 28th or in a runoff in August. And so that's, not sure how I can do all my math standing up here, but by August the 1st, or by the end of August, we're going to be 23, plus 46 down. So with very few races left. So then, well, I'd already done the math, so there you go. 32 House seats will be left. 32 House seats will be decided in the November, in the November election. That says primary, but it really should say general. House seats decided in general, 23. Oh, and one that I've got on there that I just forgot to take off, House District 65, Tony Hassenbach from Elgin, she challenged her opponent and they were thrown off of the ballot. So I need to move her up into she's unopposed at this point. There's the open seats. In the Senate, again, only 24 races in the Senate, 101 in the House. So out of the 24 races, we've got 2 members that have chosen to not run again and 4 that term out. So we have 6 kind of open seats and they're all Republicans that will not be able, or that are not running again. Of those 24 senators, 9 are unopposed that did not draw an opponent, leaving 15 Senate races, really, is what we have left this election cycle. 8 of those will be decided in either the primary or the runoff, and then 7 in the general. And when I see single digits for elections, that just makes me want to do the happy dance, because that just means less money that needs to be raised and less money that we have to have. Now, the House always has a cajillion races, but the Senate is really narrowed down to just about 15. And then Every statewide is up this year. Every statewide official is up except 2 of the corporation commissioners that are on their kind of off years. And so you'll see 8 candidates file for governor, lieutenant governor, only 3. I would say the big races to watch this year are going to be the attorney general's race, and the state treasurer's race will be somewhat interesting. And then the education superintendent, as well as the open corporation commissioner. I mean, right now, the governor doesn't seem to have, I mean, Superintendent Hoffmeister switched parties and is running against, will be running as a Democrat. We are all assuming that Governor Stitt will win his primary because it just doesn't appear that any of the opponents that have filed, I mean, Dr. Yin has filed as an independent. Dr. Irvin Yin, who was in the Senate, he's filed as an independent, but in the Republican primary, it doesn't seem like there's, you know, I mean, there's some wonderful people that have filed, but no one that really appears to have been able to put together a lot of resources, but just to kind of put their name on the ballot. I mean, anything can change, but that's the way, you know, it really looks at the moment. And then there is the congressional races. In Tulsa, Kevin Hern. In CD2, which Mark Wayne Mullins leaving Congress to run for Senator Inhofe's open U.S. Senate seat. And there are 16 candidates that have filed for that seat. So if you live in CD2, which is really basically Kansas, or excuse me, Missouri-ish, Kansas, all the way to Texas, along the whole Arkansas line, it's really that whole side of the state. You're going to have a lot of fun TV commercials to watch because there may not be anything else on but campaign commercials. If you're in the Tulsa market or the Sherman-Denison market, because CD2 is going to take up a lot of oxygen. We don't really see any of the other candidates for our congressional candidates facing much of a challenge. I would say Frank Lucas from Cheyenne, who's got the CD5, which is literally Boise City to Bristow, has probably one of the more formidable candidates that he's ever had. I mean, opponents. And it's a preacher out of Enid. And I mean, I've never seen him even like concerned about having a fundraiser. And for the first time, he's like, I've got to raise some money and I've got to get out and I got to do parades. And so he's taking this serious, you know, definitely. On CD2, I mean, we've got probably 6 state legislators that are running for that CD2. I mean, Marty Quinn's running, former Representative David Derby, Avery Fricks, Representative Avery Fricks from Muskogee, as well as Representative Dustin Roberts from the Durant area, and then plus a lot of other folks that are making up that field. And then this is kind of a unique year to have both U.S. Senate candidates. I mean, Senator Langford's up because it's his time to be up, but then Senator Inhofe is up because he, you know, chose to retire. And so again, there will be a lot of commercials and mail that you'll be seeing over the course of the next few weeks, months, actually. Back up just I thought I put in there. Okay. I was looking at the number that have filed. Inhofe's retirement, year from 7 Republicans have entered the race so far, Inhofe's term, and then Kendra Horn is the Democrat. So I thought there was more than that in the Republican primary, but there's some pretty big names like Congressman Mark Wayne Mullin, former Speaker of the House T.W. Shannon, former Attorney General and Trump appointment to the EPA Scott Pruitt. I mean, I think those are the big, kind of the 3 big names of folks that are running for the United States Senate on that open seat. And then Luke Holland, who is a Bartlesville native and Senator Inhofe's chief of staff, he is also running, and Senator Inhofe has actually endorsed him to take his place. And so that's going to be a pretty crowded field. And so June, July, and August are going to be very, very busy there. And just so you can see, those are the dates for not only for the elections, but also last day to register and early voting, etc., that you can see that's on the horizon. So any questions about the election? I make no predictions. Well, thank you all. I know Dr. Young and Allison and others are always, promoting the Political Action Committee, and you can see this is why that this is why you have a PAC. You have a PAC so we can be active in these races that are before us in the next few months, and then also be able to help our friends that have been helpful, and then also we use the PAC contributions for when members come by the office to pick up a check and to sit down and talk about the issues. And this year we're going to have a lot of, I think, scope issues scope and Medicaid to educate legislators on for this session. So with that, thank you all very much. I'll turn it back over.
Do we have any other questions on anything that was covered? Dr. Martin.
I'm wondering about what's going on with telemedicine. Any action as far as processing or scope of licensure, along with any licensure aspect, is there anything that needs to be
Well, there's nothing at the legislature, is there, on telemedicine?
There were probably 30 telemedicine bills last year, and there's none.
None this year. None this year. No. They still, if somebody wants telemedicine for his licensure, they have to apply and come before the licensure board.
I do want to turn a little bit, but there's a lot of movement on that property and other aspects of it. I didn't know
We are not in the multi-state yet because the hangup is the FBI requires, or they require fingerprints and an FBI check. We're having a problem with the FBI of getting that done. And they've taken a hard line on that all of a sudden, it seems like. So that's where we're at. We're not in it yet. We've got about everything done except that part.
The other one I had a question about was 3145. You're talking about the infectious disease. I wasn't sure how active that still is. That had started me a little bit about we can't do a full research of infectious disease. You got some kids that stay with HIV or stay with tuberculosis or anything else. I mean, that's the raw reading of it is even though that kid had unstable pneumonia contagion, that changed his blood or something else, the raw reading said that kid was water from school. So I didn't know, I don't know what county the news one on the detail of it, but it kind of worries me a little bit for some of these kids that respond to wrong things. I didn't know if it was still active. I wasn't sure from your comment if it's still viable out there or if it's.
I'm looking it up right now. But I will say probably the little snippet that I had up there may not reflect exactly where the bill is today. It did pass out of Senate Health and Human Services on the 11th of April, but has not been considered on the Senate floor. So my guess is, and I will say, having Senator McCourtney, the former HHS chair, as the floor leader, I mean, he said, now you all get over there and kill these vaccine bills so I don't have to be the one that just is the bad guy and says no. But he said no to a lot of bills moving forward, and this would have been one of them.
So I don't think that that's only range
It was, the way Representative Kevin West introduced that bill was so, I mean, it was just kind of squirrely. It was like, what are you thinking? I mean, this is just like backwards.
The COVID bill, I'm sure it's changing. Your unintended circumstances talking about
And to that point, like Representative Cindy Rowe, she's a nurse practitioner and chairs the Public Health Committee. And, she said, I won't hear your bill like this. You're going to have to change it. And it went through iterations. We always were concerned about it, though, because, and this sounds terrible, but when you have authors like Representative Kevin West, who's just a heck of a nice guy, but has typically been, he and some of his Senate compadres have been, running some of the anti-vax bills and such. We just always have to keep a sharp eye on them to make sure that nothing leaches in. But that's a great question, and one that, when that one came out, we thought there is no way this bill is ever going to make it across the finish line. But as I just wanted to verify that it hadn't been heard yet. So, all right, thank you.
Anyone else? Yes.
For the most part, as a physician, our organization is pretty much in lockstep with what other physician organizations do in today. Sort of are in agreement most of the time. Do you think of any examples where we weren't in agreement or something like OSMA wanted to do and OOA differed on that? And by virtue of us having a presence up there, actually made a difference. And we're not just going along with whatever OSMA does.
Well, the one that comes right to mind is 888. OSMA has been pushing that bill, and we have not. We have taken, we don't support it, and it's a iteration that's at the end. And that's why it's been 5 years now, because we do not support the bill the way it's written, where OSMA does. So that's the one that comes to mind for me.
The other one was price transparency.
We also sit on a committee called Patients First. And I don't know if we can use Patients First because someone sued us over that. But
Patients Coalition.
Oh, okay, Patients Coalition. Where OSMA and a couple of the specialty colleges. And again, it's not always a consensus. And we will support something, but they won't. They're like, we don't want to get into that fight. But the price transparency bill.
Yep, that was one where, again, we got that one defeated, or she pulled it, rather, or laid it over. That's the appropriate phrase, right? Laid it over. I'm still learning those. But all of the penalties on that and all of the requirements were put on physicians, even in scenarios where it would be more of something that a hospital administrator would have been handling. And while OSMA was actually in support of that bill, we opposed it, got a couple of the other associations, I think including the family practice docs, to sign on to an opposition letter we drafted. And because of that, Jami was able to talk to the bill author and get it laid over. So that's one very specific this session example of where we disagreed with OSMA and were actually successful.
That's what I wanted to highlight. OOA doesn't matter.
One other, PMTC, is another one that we have continued to look for parity on that board. So you had the same number of DOs or MDs, and we've actually, this issue has still not been resolved, but when they're going through some of the workforce ARPA issues earlier in the session, the number one thing that was addressed, or at least identified, was workforce shortage for nurses, and not nurse practitioners, not CRNAs, but bedside nurses, in the clinical setting and in the hospital. And those dollars, rather than going through the state regents, which then would go to the schools, they didn't send them there, or they're not going to send them there. They haven't done anything yet, because the state regents don't really have to do what the legislature tells them to do with those dollars. So they're sending them or the plan is to send those ARPA dollars to PMTC and kind of tweak the name so it's more of a provider name, so some of those dollars can go for nurse scholarships. And that has been something that, we've really talked to a lot of the House and Senate leadership about how critical it is to keep parity on that board, because we've been 4-2, or, where we've seen, those Dr. Hill and others can speak about this a heck of a lot better than I can, but we've certainly, I think since the bill passed, Senator Roger Thompson carried the bill for us 2 or 3 years ago. Since that happened, we've really actually seen some parity with PMTC. So 50-50 instead of 60-40 or 75-25. So I think that's another place where we really do split with OSMA for sure. And, the family practice group working on this Medicaid coalition, or I guess it's our anti-MCO group, I've never really worked with Carrie Weber, who's Allison's kind of counterpart with the family practice docs, and never really, worked with their lobbyists, but, we've really, like on 888, they stopped me the other day and said, we want to get involved in this pain management bill. We are not for how it's drafted, any version that we've seen. And so we want to join an OOA in fighting OSMA on this bill. And I don't know what their membership is. I don't know if they have DOs or MDs or what, but they're like, we are primary care. They're a family practice group, and their point is, we think that this bill, to Dr. Young's point, is really targeting primary care. So, I think those are some things that they're really seeing Allison take a more of a leadership role in a lot of the discussions on the MCO issue and on Medicaid and others. And so I think it's been very helpful, to your point, Dr. Thurman, to realize that they can hook arms with us and get things done for sure.
Any other questions or comments? Well, if not, stay tuned. This is the race here at the end. That's when things get, we've had it, they'll take and gut a bill and put totally different stuff in it at the last minute. And this is when you'll get that call to action to get a hold of your legislator and help us. As Jami and I think you've seen, we're trying to look out for you guys and girls in your practices, and make sure that you can take care of your patients without undue regulations. Thank you all.